Good morning and welcome. We're going to go ahead and get started. So if there's some folks registering, if they could come on in, and then if we could actually close the door just because of the noise. Thank you, Charles. I don't know what we would do without our IT. I'm Dr. Almeida, and I'm the Director of Behavioral Health Services for the county. Really excited to be here in person. We came together 2 years ago in person and last year virtually. So again, this year it's about coming together again. How do we support children with mental health? And how do we really start early to really make a difference in the lives of children? Just a little bit about myself, and then I will stop talking. I'm a licensed psychologist and a licensed specialist in school psychology, and I've actually been doing this work for 37 years. Always in the public. Thank you. I appreciate it. I was very young, but always working in the public sectors, the school systems, and always working with children and adults that have either intellectual and developmental disabilities, mental health, and or substance abuse issues. So I believe in this work. I believe about working together and coming together. None of us can do this alone. What we learn every year is that more and more, the importance of things like social determinants of health. People need a safe, permanent place to live. They need to feel safe. They need to have food. They need to have healthy relationships. They cannot be scared. It's really fascinating to see as our system has evolved how we really need to address all of those issues because that's how we're going to make a difference. So we'll talk a lot about that. And I'm just really excited too because our focus this year is really about starting early. And what does that mean? So really excited to have a variety of speakers here who are experts in the field, talking about trauma, talking about some early interventions, talking about diversion. So with that said, I'm going to turn it over to our county judge, KP George, who is extremely supportive of mental health issues of the department. We cannot exist, of course, not only without Commissioner's Court support, the justice support, the county support. So thank you, Judge, and then Dr. Shaw. And thank you all for being here.
This might work. Sure.
Oh, we have a mic for online, and that one does work. You're good, Judge.
Okay. I know I'm good. I'm okay. I'm just kidding. This is Friday morning, and it looks like everybody is kind of feeling Friday morning. Come on, you cannot do that. We are talking about mental health, and I tell you this, it's absolutely an honor and privilege to stand in front of you and say hello to you. Growing up in a South Asian background, and I never even heard of mental health, honestly. And even in America, a South Asian society, we don't even talk about mental health. And I'm so excited to see that Dr. Shah, Mr. Rupani, and IBN Sinha, and you guys are taking a step forward to make sure these conversations are happening. And we are talking about mental health, and we are telling people it is real. And I just tell you this, and maybe you heard I say this before. I had a unique experience of somebody very close to me, and their, I believe it is 11-year-old child, right here in Fort Bend County, he hanged himself. And when you go and see those parents, what do you tell them? This didn't happen overnight, and unfortunately, they were not able to catch the sign and symptoms, whatever happened. They were not able to. That's the discussion we are having here. And what do you tell them? After standing in front of them, I said, you know what? I'm here. That's all I can, nothing I can do at this point. But here, we could do something to make a difference. And also, I'll tell you, another mother came and told me, she got a text from her sister saying that go check your daughter's room in the middle of the night. And she was about to hang herself, 17-year-old daughter. And when I hear this kind of stuff, I'm father of three children, two girls and a boy, and I think about my children. And so we have to talk about it. We have to make more awareness about it. And I just wanted to say thank you. You are taking the time this morning to talk about one of the most important things, and especially, first of all, welcome back. Because we're supposed to do this in January, and we are back. And in Fort Bend, we are almost back. Hopefully, we are not going to hit with another variants popping. But otherwise, we are almost back. Everything is normal at the moment. And so I just wanted to say this month is dedicated for this purpose. This week we are talking about our children's mental health, and it is real. And especially my wife is a teacher with a school district, and she come and talk about children facing, because they see it. Many times parents don't see it, they see it. So let's talk about it. Let's have this awareness. Let's take it home and take it to our communities. We could have that personal conversation with parents, and let's not act like this is not real. So, and you all are, I don't have to lecture this thing to you. You feel that that's why you're here. And I wanted to appreciate Dr. Connie Almeida and many other people here and their role. And my chief of staff, Shanika, can you wave at everybody? And if anything we can do to help you and support you, we are always going to be with you. And with that, I conclude here, but I'm here to serve. I'm here to definitely have this conversation. And of course, we are talking about children mental health and mental health in general, and we have to talk about both. And there is a lot of issues we see, maybe many of you don't see, not about you, I mean, you see everything. So, and we talk about, me and Connie sit down at least every other week and talk about a lot of things. So one thing I told Dr. Almeida to just take and run with it, and we will do anything and everything possibly to support her and support each and every one of you so that we have a better future for our children. We all know that we have to do a better job in communicating with this. The biggest thing is about mental health is you cannot see it. And if any other sickness, you could see it, but this is something you cannot see it. The only way you know is maybe a psychologist and psychiatrist and all sitting down and analyzing, and that's the only way they see it. So thank you for what you do. Thank you for being here. And you're going to have a treat, I guess, today. And you're going to learn so much about it. And welcome. Thank you very much.
Thank you, Jared. I'm sorry, I have to stand here so I can be online. So our next speaker is Dr. Asim Shah. Many of you know Dr. Shah, and I know this is not an exclusive, probably, I'm going to miss something, but he's the executive vice chair and professor of psychiatry at the Baylor College of Medicine, and you can talk about the details of that, and the chief of psychiatry for Ben Taub Hospital, the Harris Health Systems. Dr. Shah is also a leader in our community and an expert on mental illness. He's been the chairman of the Mental Health America board. He's also the chairman of the center, the Sobriety Center right now, in many other organizations. So I do hope that he tells you a little bit about what he represents in this community. We are very fortunate to have Dr. Shah. He's a Fort Bend County resident and extremely supportive of our work. And again, just not only his skills, his leadership, but his commitment to this field is just, I am so grateful for that, and it's outstanding. And he's making time to be here before he has to go to do clinic this morning. So Dr. Shah, thank you.
Thank you, Connie.
Yep.
I do. So the topic was starting early, although we started 12, 13 minutes late, but that's okay. But that's okay. Who was counting, right? Yeah. So I know Connie for a long time, and I know Connie's husband also. So, they both are heavily invested in promoting mental health, and one was taking care of Fort Bend County, the other was taking care of Harris County. So both were in good shapes. And a little bit about Judge. Judge has left, but Judge is really, really very interested in promoting mental health, because I know that even before he took oath of the office, I went to his home and we talked about mental health, and he really listened. Not only he listened, he promised that he will do whatever he can to take care of mental health. So that's really impressive, at least to a person like me. So we're going to talk about 15, 20 minutes. We're going to talk about what can we do or what is important in terms of mental health when we think about kids and so forth. If you think about a 12-month analysis of mental health disorder among kids in Texas, let's just focus on Texas. We are in Texas. The total population of kids between the ages of 6 and 17, and again, less than 6 also can develop mental illness, but we focus on them less. And the reason we focus on them less is that A, the data is not accurate. B, honestly, if a child develops some sort of mental illness less than 6, and Connie hopefully would agree as a psychologist, most of the time family has a lot of part to play. But the population of kids between the ages of 6 and 17 in Texas is about 5 million or so, right? And if you think about the population, close to 2 million have some sort of mental illness. That's what percentage? That's close to what, 40%? That's a pretty alarming number. That's a very alarming number. And if you think about it, with this alarming number, what are we doing about this number? And this could be just depression, this could be just anxiety, this could be just panic, this could be psychosis. This doesn't mean that this is SMI. And what is SMI? Anybody wants to? Not you, Connie. Serious mental illness, fine. But what is included in serious mental illness? Serious mental illness is schizophrenia, bipolar, schizoaffective, serious major depressive disorder. But even the definition of SMI is skewed, flawed, because people who have PTSD would say, my PTSD is more severe than anything else. That could be SMI. People who have borderline personality, ask them. To me, that is way more severe than anything else. Or people who have OCD, ask them. Their OCD could be way more severe, but it's not included in SMI. So there's so many people who suffer from so many different things. Of the 2 million, over half of them have mild conditions. Mild conditions could be mild anxiety. And mild usually in this case means that it is not bothering functional capability over a period of 6 months. So it's bothering functional capability for a lesser period. The serious conditions or the serious emotional disorders, you can come in the front of it. I can multitask. That's a good way to keep you on task. So the people who have serious emotional disorder are over 380,000. That's still a huge number. Another important thing, we feel that people, especially kids, can qualify for CHIPS Medicaid in Texas. Unfortunately, not everybody does. The reason I know that is I work at Bentop. We see so many undocumented kids who have no insurance. How do they get care? How do they get care? Because the most important thing in terms of healthcare should be that it should be free for all, it should be accessible to all, and it should be available, accessible at the time it is needed, not 3 months later. Has anybody ever tried to get an appointment for a child psychiatrist? You try to get an appointment for a child psychiatrist. I just received a call yesterday from somebody, and that somebody has insurance, and that somebody is a big shot, actually at a medical center institute. 3 months, not easy. And most of the psychiatrists take cash. I don't take cash, but I'm just saying most of them take cash. And still, 3 months, or a psychologist. Most of them take cash. Still, long time. So then what's the accessibility? That's no good. So again, we haven't done much in that area. So those people who are that 380,000 serious emotional disorder, those need to be seen truly within few days, within a week. Just like if somebody has chest pain, need to be seen ASAP. We're not doing that. This figure about deaths from any of the psychiatric killers, which says 181, that's in 1 year. The amount of people or the number of people who die of suicide in our country, if you think about it in a year, is about 47, 48,000 in a year. And the suicide numbers are always skewed. Why? Skewed towards the lower side. Why? Because in order to classify a suicide death, it has to come from a coroner's office and it has to be declared. A lot of these are not confirmed suicide. They may be suspected suicide. So those numbers are always going to be low. Substance use. Which substance is the most common in adolescents these days? Not the people who know. I'm not asking Renee or Connie because you guys know, but huh? No, substances, drugs. Marijuana, okay. Who wants to guess? So these days, the number one substances which are common in schools, vaping. Vaping is number one these days. It used to be smoking long time ago, then it changed to marijuana, and now it's vaping. Now vaping is so common that everybody is doing that. And people who feel vaping is not harmful or not a problem, it's actually like, if not close to 100 times, but over 50 times worse than cigarette. And it's happening. Even 7, 8, 9-year-old kids are vaping. So it's pretty bad. So that's a problem. In terms of overall Houston area, which substances are seen, even if you count adults? Anybody can answer? The problem is if you don't answer, I get stuck. So we will be here till 3 p.m. So please. Harris County, Fort Bend County, yeah, you know. Synthetic marijuana has decreased though. It has decreased. You're absolutely right. We had it a lot, but it has decreased because of the work we all did with the DA's office and all of that, but it has decreased tremendously. So of course, alcohol is there. Of course, marijuana is there. After that, Houston is big for cocaine, then meth, then PCP. Now, if you go to New York, it's heroin. If you go to countryside, Lubbock, Texas, all of that, it's meth. If you go to California, they always like to fly high. So it's LSD. Fly high, right? Exactly. But for us, it's mostly cocaine because it comes from the South and it's easier. Drugs are usually excess related. So, so all those things are very significant for us to think about. Now, another alarming figure is suicide used to be the third leading cause of death for kids and adolescents or adults between the ages of 10 and 24. Now it is the second leading cause of death. Change from third to second. And again, what is the worry? Change from third to second. It can change to number 1 too, right? It can change to number 1 too. And what are we doing about that? Not a whole lot. Also, it has increased from 10 to 24. The age group is increased to 34. Now, what is the age group of immaturity? Till 70? What is the age group of immaturity? We used to say till 18 or, then we change it to 24 because honestly, the 19 years old are not a whole lot mature these days, meaning in terms of making good decisions. So we change it to 24. But things are changing and people are making wrong decisions. But suicide is the second leading cause of death right now between 10 and 24 and also changing till 34. So that's another thing. Now, during the pandemic, which I'm hoping and fingers crossed and all that pandemic has changed to endemic. And now, as the judge says, that we may not have more variants. I think we will have variants, but the variants would not be as strong as Delta, which was the last strongest variant, right? Because we will continue to have something or the other, but hopefully we will be fine. In the early part of COVID, we saw 30 to 40% increase in emergency room visits because of psychiatric reasons. And what were the reasons? Depression, anxiety, phobia, panic, PTSD also, everything, suicide, suicidal ideations. We didn't have, still, we don't have data of completed suicide. That data is 3 to 4 years lagged. But suicidal ideations, absolutely, we saw a lot of that. So that's concerning. And even the data shows 31 to 35% increase in those visits. I know because I have to staff the ER at Bentab and it was a mess. So that's still concerning. Now, pediatric emergency has doubled. One thing changed in the early pandemic months, that initially the ER visits decreased and then they increased. Why? Because the emergency room visits for kids are directly related to schools. Why? By no means I'm saying that school has anything to do with kids being depressed or so, because when kids go to school, their symptoms are reported much more quicker because the teacher or the counselor or somebody will see those symptoms and they report. Whereas at home, parents may not be able to pick those symptoms. Whereas in school, there is somebody who knows or can identify those symptoms much more quickly, will report and will send them to the ER or will call the parent that, hey, your son or daughter is suffering from A, B, or C, and take them to the ER. So that's one. The other thing which was very alarming during COVID was child abuse. The early parts of COVID, especially when people were at home, we saw an enormous rise in the number of child abuse. Unfortunately, the reported cases of child abuse were lower. Why? Because kids were not at school and the perpetrator or the abuser was also at home. So who's going to report, right? But it doesn't mean that the abuse was less. Abuse was more, but the reported cases, which are usually reported through schools were closed, so were less. So that was also alarming. Same thing happened with IPV, intimate partner violence, that increased also. That was another alarming thing. Sharing some of our MHA's data is here. If you see, MHA does screenings every month. And if you look at MHA's data, 76% of parent screens taken in March show a child at risk for emotional, attentional, or behavioral difficulties. Percentage represents a decrease from February. So if you see the issues which we saw in February are slightly decreasing in March. Why? I think that's directly related to the improved situation of COVID, because people are feeling more comfortable and more confident about the outlook of COVID and things are changing. So that's a good thing. Same thing is happening in youth in terms of the other data. When you think about behavior difficulties or emotional difficulties, everything is improving in March. And I'm thinking April would be even more better because the outlook for people is better. And again, if you think about what would be the most or the largest problem people are seeing right now, the three things are loneliness, isolation, past trauma, and relationship problems. Those are the three things, which would have been different in 2020 when people were much more concerned about COVID and those kind of things. And if you see, COVID is 7th right now, which used to be 1st or 2nd in the beginning, and that has changed, which is a good thing, And I'm always on the positive side, that we need to focus on the positive. So that is a good thing that people are less worried about COVID. It's good to be less worried about COVID, although we need to be still vigilant, just like we need to be about flu every year. So that's a good thing. Again, this is the same slide from MHA, which I mentioned, that COVID or COVID-related worry is 7th, but loneliness another is on top, and that's a bigger worry for people right now. Another thing we saw during COVID, a phenomena called touch starvation. What is touch starvation? Law enforcement would know more that when you put somebody in solitary confinement, they suffer from touch starvation because they don't have anybody, they cannot touch anybody, they cannot hug anybody. And touching and hugging releases oxytocin, which helps in decreasing your stress. It helps in your immune system or building your immune system. And we really figured this phenomena out more during the COVID time, especially the first 6 months of COVID, when truly people were not able to hug each other, touch each other, and you wanted your immune system to be more stronger, but you were unable to because of all those conditions we had. And I always say the worst thing we did in COVID was what? The worst word we used in COVID was social distancing. We should have used the word physical distancing because we should have socialized with the physical distance. But we use the word social distancing, and we should have never used that word. We should have used the word physical distancing. You could have socially distanced yourself and seen each other outside or something. But anyway, that to me, that was a mistake. And we paid for it in the early days of COVID. Texas got back to normal rather earlier than other states, but we paid for it. So one last thing which people don't talk about is COVID orphans. Worldwide, over 5 million people, 5 million kids have lost parents due to COVID. Just think about the trauma those kids have had. Think about the trauma. If you recall 2020 May, New York, images seen on news media, mass graves, those kind of things. And again, I don't want to horrify anybody, but truly, those were horrifying images, right? Imagine if a child not only loses a parent, maybe even both because of that, and not only that, because of early days of COVID, they were unable to go to his funeral. Because remember, in the early days, there were only 10 people allowed, a few people allowed. You couldn't go to the hospital, all those things. Imagine the trauma. There's no closure and all of that, right? That could stay for a long time. So over 5 million COVID orphans, out of which about 214,000 in this country, these are reported. That's a big number. That's a big number, right? So I guess we have a whole day of discussion, conference, trauma-related stuff and all of that. To me, the point to ponder, the things for us to do is we need to think, what can we do for those kids, for the kids, the 380,000 kids who are available? We need to make things accessible to these kids. Just saying that we have this number and you call and do that is not enough. Just saying that everybody can go and pay cash and see A, B, or C is not enough. And lastly, anybody who needs resources, MHA-Greater-Houston.org is a great site for resources. There are many resources available there. Again, if we all make some effort in identifying, helping one child, there are over 40 people here. We all can help. Thank you.
I think that that really highlights some really important issues. First of all, how prevalent this is, how many children can be impacted by mental health, but how important it is for us to think about those groups, and those groups again with these serious emotional disturbance that cannot access care. That's a crisis, and we need to do something about that. And again, you know, if you translate that, those are Texas numbers. Well, you can translate those numbers to Fort Bend County. You know, if we have a population of over 850,000, I think we have, what, 23% of our population are children. You know, you can do the math. And then you think about how many children in Fort Bend County fit into that serious emotional disturbance group that need access to care right away. So really important to think about that. Thank you. So we are moving. I just wanted a couple of housekeeping. I forgot the housekeeping stuff. We will stay on schedule. We'll get back to schedule because we actually we have a presenter that unfortunately is out sick. So that presentation will be a lot briefer than what we had planned for this afternoon. So throughout the day, we have a variety of speakers talking about some of the work that they're doing around trauma and early intervention, and just, you know, really exciting about this. And this is an opportunity for us to really learn and think about how we can collaborate together around these issues. We will have lunch. Thank you to the Rupani Foundation. We're very appreciative. I have to thank all my staff because they have been working extremely hard at putting all this together, you know, and so they've become IT experts and, you know, a variety of things. So really appreciate that. So our next presentation is actually, so the next hour, we're going to talk about, you know, starting early and hear from a couple of experts from UT, and then also from Donna Anderson, who's actually with Behavioral Health Services. And Donna is with us part-time. She actually is a CASA volunteer, has been a CASA volunteer for many years and worked in the school systems for many years. We have this opportunity, we're part of this Texas Change in Minds Learning Collaborative, which I really didn't know what we were going to get ourselves into, but it seemed like a good idea. It was something that was funded out of the Episcopal Foundation and the Alliance, and now is actually under this other organization called Social Current. But it's this opportunity to really develop a shared knowledge about brain and what we know about brains and how to incorporate that into practices and policies, and also how to address race equity when it comes to brain development. So exciting work. And so Donna's going to talk about that. So I'd like to welcome Donna Anderson. Do you know how to work this? Okay. And okay. Then you just click. Okay, got it? Go ahead.
I don't see the cursor, just click it and, okay.
Yeah.
Let me go back.
Very good.
That's okay.
You're good?
Go back.
Okay.
Good morning. So glad to see everybody on a bright, shiny Friday morning. My name is Donna Anderson, as Dr. Almeida said. I'm a new member of the Behavioral Health Services family, and I'm so pleased to be part of this organization. And I think we're all very fortunate to be part of Fort Bend County because they put so much emphasis and importance on behavioral health. And this is why we're all here today. So I'm grateful to be part of that. I'm going to be talking about our Social Currents grant, and I am a project coordinator, and I'm coordinating this grant called Texas Change in Mind Learning Collaborative. And this Learning Collaborative is the grant that we are so fortunate to be a part of. We were awarded the grant from Social Current and the Alliance for Strong Families and Communities. Their purpose is to believe that our county can thrive when everyone reaches their potential. You know, we all have potential beginning, but then we reach our struggles and we can't meet sometimes that potential. So hopefully with this Learning Collaborative and everything that we're all doing here will help everybody reach their potential. It's funded by the Episcopal Health Foundation and the Powell Foundation. These are the other organizations that have been fortunate to be part of this grant. You see, it's a wide variety of organizations within Southeast Texas. You see New Hope Housing, Austin Public Educational Foundation, Santa Maria Hostel. So we have a large group that's involved in this wonderful grant. So what is the purpose of our grant? Well, the main purpose is to understand the effect of trauma on brain development. This is an important factor on mental health, and it's something that is up and coming as very, very important material. So we're grateful to be able to focus on this and to share this information. We want to understand and communicate how the brain develops and how trauma actually alters that brain's architecture. We've always known that maybe somebody came from a difficult background, maybe somebody had difficulties, and we think, oh gosh, but did you realize that it really affected their brain development and how they produce and how they work in society? We want to translate brain science concepts into programs, practice, and policy. We want to increase an understanding of the kinds of interventions that work. What can we do to help those that have experienced trauma? And most importantly, to improve the outcomes of children and families right here in Fort Bend County. So what is brain science? Well, it's a valuable topic, and it's the study and understanding of what really affects that brain development. I'm grateful to be able to follow Dr. Shaw, who is quite the expert. Okay, I am not a neuroscientist by any means. My first job in the 70s was I was trained as an elementary school teacher. So I've done a variety of things in education and all types of things since then, but I'm not a neuroscientist. So I'm going to share with you in an elementary state of how to understand what I have tried to learn here, okay? We're studying what happens with the brain development. And you know, experiences are what build the architecture of our brain. Our experiences will definitely shape us. Let's look at the brain. Okay, so if you look at the blue part, the frontal lobe, most importantly, what happens there is it helps us interpret harmful and helpful actions. How do we see things? As harm, help? That's very valuable. If you look at the temporal lobe, the green part, that helps us to understand the perception, interpretation of sound. Is it a threatening sound? Is it a favorable sound? Is it loud? Is it soft? How are we interpreting the sound that's coming to us? It also affects our visual memory. If you look at the parietal lobe, you understand, it helps us understand where we are. What are our surroundings? What's affecting our surroundings? How do we feel? Do we want to be touched? Do we feel pressure? Do we feel closed in? All of that comes from that part of the brain. The occipital lobe, the yellowish part, that helps us process our visual cues to see what are we really seeing and how are we seeing it. It may not be virtually what it is, but that's how we're seeing it. And the cerebellum plays a major part in balance and voluntary movement. So how's this trauma affecting the brain? Well, in the prefrontal cortex, rational thinking is the most important there. What is rational? Now, you may think you see somebody and go, oh my gosh, you're the most unrational person. What's going on in this part of the brain? It's not that that person just wants to be irrational, possibly, but maybe they're not making the connections there to really tell the difference between what is and what isn't rational. In the hippocampus, that helps us be responsible for memory and differentiating between the past and present. Something's happening to us, and immediately in our brain, it may take us to the past. And we may think we're experiencing something from the past when really we're in the present, and that's not really what's happening. In the amygdala, most importantly, it helps us be wired for survival. Are we frightened? Are we in flight or fright mode? Where are we in our state? So we said that trauma can affect these parts of the brain. So how is it going to affect us? Well, I said experiences build the architecture of the brain, and our experiences shape us. Good experiences obviously help us in a good way, but negative experiences help us in a negative way. These connections that should have been going on in all of those parts of the brain can be lacking connection. Take an example, your cell phone. You've been on the phone before and all of a sudden it gets staticky and then, you hear parts of something, not all something. Imagine what if the brain is not connecting and you're getting parts of the brain working, but not all of them. Sometimes on that cell phone, you completely lose service. Does that happen to our brain too? Sometimes we completely lose service? Well, severe trauma changes the architecture of the brain and the way that we function. The more traumatic experiences we've had, the greater damage we have. The effect on trauma is incredible. Okay, let me see. How am I going to? Shannon, will you help me? I'm sorry, I'm going to start this for you. This is a wonderful, quick little video that will help you understand. Which one am I going to click on? This one to get it to start?
Yeah.
There we go. Okay, thank you. I can understand.
Modern science now tells us a great deal about how brains are built in childhood. Did you know that early childhood experiences actually change our brains in ways that affect our health throughout our lives?
We have a very rich and rapidly growing science about early childhood development, and particularly how early experiences affect long-term outcomes in learning as well as physical and mental health. And we also have a huge amount of new research that is helping us understand how adversity early in life, and particularly the toxic stress that young children experience, gets into the body and actually affects the development and architecture of the brain.
So experiences we have in our earliest years affect how our brains get built. That's important because the basic structures we develop as infants lay the foundation for more complex structures that develop as we grow. Just as a house needs a sturdy foundation to support the walls and roof, a brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain to provide a sturdy base for a lifetime of better health. On the other hand, if a child experiences a pile-up of negative experiences, such as abuse or neglect, and if no caregiver is there to provide support, a sturdy brain foundation may never develop. That can lead to lifelong learning difficulties and health problems, including addiction and mental illness.
It affects the cardiovascular system, it affects the immune system. And so what this science is telling us is that we ignore the early years at our peril.
It's amazing to think that the experiences we have in our earliest years can affect our health for a lifetime. Since strong societies are made up of healthy individuals, it's up to us as a community to make sure all kids have the kinds of nurturing experiences they need to build healthy brains and bodies.
Sorry, you guys. It's unfortunately not working for me. I was using that. Okay. So we have a quick video here, and it's talking about what are these traumas that we're referring to. When we say trauma affects the brain, how is trauma actually going to affect the brain? I was using that one. So sorry, you guys. Okay. How do I get back to? Okay, now I'm going to go to the next slide.
I was going to mention Shanna Brown, who's apparently now our technology.
We just missed it.
expert.
When it says ACES.
Shanna's been with the department about 4 months.
That's it.
Um,
And you can start. Oh,
2 years in HP.
Okay, then after that, can I use
One
this
with
one again to
computer,
get to the
5
next one?
years with the private police department. And now she's, I guess, our technology expert. Shannon, I'm glad you're here.
I tell you, you guys, this one just does not want to start. Okay. I'll tell you about it. How about that? Okay. ACEs, adverse childhood experiences. So what do we mean by the adverse experiences? Well, here's an example. And in child development now, we're really trying to focus on these experiences and realize that they are making a difference in the growth of the child, the ability for the child to function in school and everywhere else, as well as what's happened to the brain. These are the most common and the ACEs that they're looking at. So they ask you to, there's even a test that you personally and children can take to determine how many ACEs have affected them. For example, verbal abuse would be one ACE. Physical abuse would be another ACE. So these are things that the child has experienced in his early growth, in his home, in his surroundings, sexual abuse, emotional neglect. Someone in the household was threatened with a weapon. May not have been the child, but you know, young children, they see a loved one threatened with a gun, it might as well be themselves because they interpret that way. If someone's been in prison, that greatly affects them. Is there drug or alcohol use in the home? Is someone in the house mentally ill? Child might be not at that point, but if someone else is, it's a great effect to the child. Has the child been bullied? Does he feel unimportant? Does he lack family support? Lacking family support, I put, is number one. Remember, I'm not the neuroscientist, but I'm telling you why, as an educator. We can look at these and say, okay, this child has 7 of these. That means he has an ACEs score of 7. That's huge. That's huge. But you may look at it and say, well, golly, I've got an ACEs score of 3. What, is there something wrong with me? No, maybe not. And that's because you had family support. And that's the thing. If you have someone surrounding you who can give you that pat on the back, give you the support, pull you through the trauma, and help you, nurture you, there we have a difference. Here are some of the things that can actually happen to the brain from this trauma. Lifelong impairments, physical and behavioral health, poor educational achievement, lack of economic productivity. It increases stress, anger, impulsivity, and the inability to effectively cope and problem solve. So maybe these kids can't problem solve, but we can now understand why. Do you know that 90% of the children in residential treatment centers have high complex trauma? Other things that can happen to the brain: loss of brain cells, damage to brain cell connections, enlargement or shrinking of certain parts of the brain, hyperactivity of certain parts of the brain. It can also delay certain aspects of brain maturation, and it can disrupt attachment patterns. All of this is greatly affected by the trauma. So now we look at individuals in the community, maybe your patients, maybe your students, maybe your clients, the people that we work with. And do we see them as someone struggling, someone that's had a bad experience? Or do we see them as someone, what are they doing? What is wrong with them? Why are they acting this way? This is one of my favorite books, and it's written by a phenomenal psychologist who really focuses on brain development and child development. It's called What Happened to You? Bruce Perry and Oprah Winfrey wrote the book together. Remember, our grant is called Change in Mind Learning Collaborative. But not only do we want to change the mind of the children who've had the trauma, we want to change our minds. We want to be able to look at individuals differently. We want to be able to look at them and say, what happened to you? Not what's wrong with you. View that behavior as a survival mode, not willful disobedience. It's not their fault. The good news is the brain is elastic and it can work and it can stretch and it can get better. And so the elasticity of the brain allows us to help children and adults who've had severe trauma. The two main ways to help are through trauma-informed care and specifically trust-based relational intervention. You've heard TBRI. This is for all the vulnerable children that have had hard lives and difficult experiences. All children can heal from trauma. Healing is possible for all. It's how we go about it and how we help them. Resilience is what everybody needs. We all need to be resilient, and we need to help these children learn resilience. Trauma-informed care teaches us how to realize the prevalence of this trauma, to recognize those signs and symptoms and be aware before it's too late, to respond by embedding this knowledge into policies and procedures, and to make sure we resist from re-traumatization. Resilience can bring back health and hope to children. Trust-based relationships teach us how to make connections with children, how to have deep emotional relationships and nurture. We're very fortunate here in Fort Bend with behavioral health services because we have partners that we work with. We collaborate with you guys. We are so fortunate that we can take this knowledge, and through the programs that we have, we're able to reach CPS, social services, CASA, probation department, judges and attorneys, the sheriff's department, crisis intervention team. We're reaching out. We're trying to help and get the word out and get the news out on how important it is. We want to pass this word. We want people to look, what happened to you? How can we help? A couple of the things that we're doing within our department is we have a TBRI collaborative planning group that works with TCU, and we have on our team CASA, juvenile probation, school district staff, behavioral health services, emergency shelter for abused children. These are part of our group that's working together. We have collaborated for TBRI caregiver training. It's a 4-day training, all-day training that focuses on this. Who's going? CASA people, behavioral health people, faith-based organizations, school districts, CPS, law enforcement. We're trying to reach out to everybody as much as we can. Trauma-informed care training for judges and attorneys we're working on. Trauma-informed care training for foster, adoptive, and biological parents. This summit today we've been working on. And we have another convention coming up in September, which is for keeping toddlers and infants safe. So now I challenge you. Can you go forward and can you make the difference? Can you do something to help our children in need and to make that difference? That's what I challenge you. Thank you so much.
So much. That was excellent. And sometimes we need a school teacher to teach us. So really, thank you. Appreciate it. And this is actually a perfect segue to our next presentation because we're actually going to be talking about Circle of Security. And we have Ms. Cervantes and Dr. Jacob with the Nurturing Resilience Initiative with UT Health. And really fascinating work. I found out a little bit about Circles of Security actually when I worked for 0 to 3 in Washington, D.C., when we started our work with infants and toddlers. So again, this is a great partnership that we've established. We actually have an MOU signed, don't we? Yay, that's an accomplishment within county government. So that I'm just really excited that you're here, and I look forward to looking at how we continue to expand these services, because as Don has said, you know, this trauma impacts our children, but they can heal with the appropriate intervention. So thank you and welcome. Thank you.
I'm just getting trained so that I don't get into trouble. So, oh, okay. Okay. I think I'm a fast learner. I'll let you know. Very good morning to each one of you. And I just want to say thank you. Thank you for inviting me, Dr. Alameda. This is a privilege to be here amongst a community of people who wants to make a difference in children's lives and people's lives. And today, you know, we have the honor to talk about something that we got funded to do in Fort Bend County. And, you know, they say every single drop counts. It makes a big difference in the bucket. And so this is our little drop that we'll talk about today. A little bit about myself. I am Dr. Seema Jacob. I am an early childhood psychologist. I work with kids only from prenatal to 5 years of age. My colleagues jokingly tell me that anyone about the age of 5 is too geriatric for me. I say they become too smart for me, and so that's why I like to stick with the little ones. And with me, I also have my colleague, Ms. Neftali Cervantes. She is a licensed clinical social worker. And so we're going to talk about, the Circle of Security Parenting Program. So, you know, we've had a really rich morning talking about why we would like to focus on really building and strengthening and protecting our children, and also why, you know, brain development is so crucial because it sets the stage for a lifelong foundation for well-being, for health, for physical health, for mental health, and also as adults, how do we cope and live, and what do we pass down to the next generation? So our program, the Circle of Security Parenting Program, is focused on that early experience that parents can provide for their children. And specifically, we're going to talk about the attachment relationship. Our experiences as young children is happening within that family context. And our first experience of that relationship is with that one adult caregiver. And if we're fortunate enough, we have more than one strong, healthy, protective, nurturing caregiver in our lives. And the more we have of those adults as we grow up, better sort of protective shields we have around us, and the better is our brain development. So the Circle of Security is based in this theory of attachment. What does that mean? Attachment is this unique relationship that forms between an adult, a caregiver, and a child. And it doesn't just randomly happen. It happens in these everyday, regular experiences that that baby and that adult have. And the baby cries. What does the adult in their life do? Oh, they might go respond. They might check for the diaper. They might check, oh, is it feeding time? I should feed that baby, right? In those moments of that interaction, the adult learning about the child and the child being able to communicate their need, right? In those moments of interaction, they learn about one another, but they also learn about themselves as a unit, and that baby learns about the world. And that is the attachment relationship we're going to talk about. All children have this care-seeking system within them, also known as the attachment system. And just like children have this inbuilt need for food, for physical safety, for shelter, they also have emotional needs related to emotional warmth, emotional comfort, feeling emotionally safe, desire to develop autonomy and independence and mastery. Also, the desire to develop a positive sense of self, who I am, how I am in this world. And another important piece is how an important sense of developing that the place of the world of people around them, the place around them is positive. The goal of this attachment system is twofold. One is that individual experiences a sense of safety and security, not just physical, I'm talking about emotional safety. In simple terms, I feel loved, I feel safe, and I know there's someone for me. And the other goal of this attachment system is regulation of emotional experiences. Oof, that's a big word, very psychological word. What does that mean? We all have feelings. Positive feelings, negative feelings, strong feelings, unpleasant feelings. And as children, we're not born with the ability to make sense of all of that and be able to live our lives. We learn about our feelings, why we feel this way, what led to us feeling that way, what happens when I feel this way, and what do I do with all of these feelings? They learn all of that in that attachment system. So that role of that caregiver is so important because it sets the stage. Just like we heard about about brain development, it sets the stage for life. This is what the attachment system does. And then the circle of security also really leverages what we know about attachment and attachment styles. Secure attachment style is what improves child development. So that is what this program really wants to teach parents about. And this parenting program really focuses, their 8th chapter really focuses on giving that knowledge and skill sets to the parents. So my colleague Neftali is going to talk a little bit about secure attachment. What exactly is that?
Yes. Thank you, Dr. Jacob. Good morning to everyone. I'm Neftali Cervantes. I'm a licensed clinical social worker, and I started in this field about 20 years ago as a licensed chemical dependency counselor, but I've been with UT Health for about a year and a half now with the Nurture Resilience Initiative, particularly the Circle of Security. And so I'm grateful to be here, happy to talk to you about Circle of Security and what is secure attachment. Well, secure attachment is the foundation for Circle of Security. And how do we know when a child has a secure attachment relationship with their parents? Well, this is what we see in children who have a secure attachment relationship. They are relieved and pleased to see that their caregiver returns when the caregiver has stepped away, maybe for a few minutes. The child shows that he expects to be comforted when they're in distress. They might run to the parent, ask to be picked up, or open their arms. They're easily soothed when upset. Their infants are generally content. They're willing to explore with their caregivers. And what do we see in caregivers when they have a secure attachment relationship with their child? Well, they provide adequate support. They respond appropriately, often enough, not 100% of the time, but often enough to the attachment needs of the child. The needs such as protection, comfort, to delight in them, to help them organize their needs. And of course, they help the child organize his or her needs by being empathic with them, by for example, matching the child's facial expressions with their own face. the other. I'm learning here. Okay, so these are the benefits in the long run that we see of children who develop secure attachment relationships with their caregivers. And as you can see, in some of these traits, such as enjoy more happiness with their parents, get better along with their friends, have higher self-esteem, know that most problems haven't answered. All these traits will help them develop a strong social and emotional skills that in turn throughout their lives will help them to feel more hopeful, be more empathic, and of course have healthy relationships, which is probably one of the most important ones. And there's also 3 insecure attachment styles. Avoidant attachment is when the child does not turn to the caregiver for needs of such as protection, comfort. The anxious resistant attachment is when the child is overly clingy to the parent, it's afraid of exploration, might not be able to go out and explore, to establish his or her autonomy and mastery. The disorganized attachment style, which is probably the most problematic, is when the parent is the source of comfort for the child, but also the source of fear for the child. And this usually happens when there's issues with the parents, issues such as abuse, neglect, and other issues with the parent. And well, going back to what is Circle of Security, well, these are the founders of Circle of Security, Bert Powell, Glenn Cooper, and Kate Hoffman, and they developed Circle of Security as a way of explaining attachment in a simple way to the parents. And Circle of Security Intensive Intervention is the longer program. It's a group-based format, 20 sessions long. It has an assessment space. They assess the parent-child relationship. They also take individualized videos of the parents with their child to help them see themselves with their child. And the Circle of Security Parenting Program, which is the one we do, is a shorter program. It's also group-based format. It has 8 chapters. It's usually conducted in 8 to 10 sessions. It has videos and discussion-based series for parents to look at videos of other families as a way of learning and to help them practice and apply the concepts of Circle of Security. Circle of Security manuals and videos have been translated into 14 languages, and it's available in over 30 countries. And of course, we have it available here. And I'm gonna let Dr. Jacob continue.
So what happens in the Circle of Security intervention, or not intervention, actually in the parenting program? So it is a program that really teaches parents the attachment needs in children early on. And they talk about the Circle of Security, which is literally a circle. I think there it is. Yes. And really breaks down attachment into simple terms and focuses on helping parents think and reflect for themselves how to be the secure base for the child, which is the hands on top, so that they can support the child to go explore the world, feel safe enough to explore the world, but also establish a sense of autonomy and mastery of the skills of the world, and then also be a safe haven for their children, the bottom portion of the hand, so that when children want proximity, when children want to be coming back to their parents, either because they're overwhelmed or they feel emotionally unsafe, they feel welcome to come back to that parent. The Circle of Security model also helps parents think about their own experiences of being parented, because honestly, we all first know about parenting because we all have been parented a certain way. It's through our own parenting relationships with our caregivers. So this model really helps parents to think about their own parenting experiences and how that impacts their own ability to be available or not available for their children in a way so that they can be the secure base or the safe haven for their child. And then another important message that Circle of Security really stresses on is you don't have to be perfect parents. You just have to be good enough to be able to develop a secure attachment relationship with your child. And good enough means just 30% of the time, you're able to meet that attachment needs. That's it. So the Circle of Security program, we're very privileged and honored to be able to bring this work in partnership with amazing community partners here in Fort Bend County. So we're offering, so it's offered through UT Health's Nurturing Resilience Initiative. I think you all might have a flyer. If not, we're happy to distribute. Holly, our program manager, she has more flyers. But this is the full initiative that we are privileged to get funding to do. It's focused on building resilience in children and families here in Fort Bend County. So there's a lot of different components to it. But one aspect of this component is offering Circle of Security parenting programs. And so you also have the flyer for that. It's a call for recruitment. We're recruiting parents for our next round of groups. We have English and Spanish groups available, and we are running these groups for 10 weeks. And we're taking referrals through our community partners who've been really helpful in getting us, get started and getting us these referrals for our parents. So our community partners are Baker Ripley Early Head Start and Head Start program, our infant toddler court team with Dr. Alameda and her wonderful staff. And then we're also recruiting through local primary care providers in our community. I think, let's watch a video on the Circle of Security parenting program. It's put together by the creators themselves. So this should hopefully pull all the things we spoke about together. Ah. Oh, the right screen. Oh, I didn't even notice the screen. Wow. Yes. Wow.
Parents, we all wonder if we're getting it right. We want to know we're meeting our children's needs, helping them grow, and giving them all that we can. We try to combine our own experience of being parented with the advice of others and our own instincts and beliefs about what is best. And still, we so often worry that we're not succeeding. In a world that is always offering the next best parenting solution, the Circle of Security is based on decades of attachment research. Unlike many behavioral perspectives, it offers relationship tools to provide a new way of understanding your children's needs, creating lasting security for them, more satisfaction for you. The circle graphic has been created to help you know what to look for, so you can read your children's behavior to guide you in meeting their needs. It's really not complicated. People of all ages have attachment needs. These needs can be divided in 3 ways. Let's look at this child. First, he needs to know the freedom and confidence to go out and explore his world. Second, he needs to feel assured that whenever he's ready, he can come back for comfort and protection. Third, he needs his caregiver to be in charge in a kind way. 3 basic needs that can be thought of as going out on the circle, coming in on the circle, and hands on the circle. Let's have a look in more detail. Feeling safe and supported, our children want to discover their world. When going out, they need to know that their exploration is encouraged, that we're right there watching over them, delighting in them, offering help when needed, and ready to enjoy their new adventures with them. And when they're coming in, they need us to refill their emotional cup. This means organizing their emotions and letting them know we are delighted to welcome them back, protect, comfort, and understanding. The key for us as parents is to remain strong and kind, while knowing when to encourage their going out into the world and how to be available to welcome them back to us. It's crucial that we learn to identify our children's needs like this, because misreading them or worse, missing them altogether, can cause pain and frustration. We all know how uncomfortable it can be to be held too close when we want to be out exploring, or kept at a distance when we need emotional support, or simply to be without someone who is bigger, stronger, wiser, and kind, who we can trust to understand what we need when we're feeling lost, confused, or out of control. When a child misbehaves, the cause is often rooted in how safe and secure they feel. So it's not surprising that they behave well when a parent learns to tune into their child's needs on the circle in this way. And because our needs on the circle never disappear, learning to read cues can help you better understand and meet the needs of people of all ages, including your own. So that's all there is to it. Just know that at any given moment, your child is somewhere on the circle asking you to meet a need. Support by going out. Welcome by coming in. Be the hands that keep me safe by staying in charge and committed to helping me feel connected. And please remember this. There's no such thing as perfect parenting. A circle of security will come to realize that good enough is, well, good enough. All of us are going to miss needs on the circle time and again. Welcome to the club. But if we meet our children's needs enough of the time, the results will be happier, healthier, more secure children, and parents too.
Well, thank you. That is the end of our presentation. I don't know if we have time for questions, but I am happy to take questions.
I think we were going to do questions at possibly the end
Okay,
of the,
perfect.
I do have one.
She's basically telling all of us, like, don't ask questions, but only I get to ask questions, right? Yes.
Sorry, but I think it's interesting because about UT Health and government medical school out there. They operate Harris County Psychiatric. We all are all familiar with. So it's very kind of surprising that why are you focusing on young children? Why is there having this nurturing out of, a traditional psychiatric hospital? And I know they could experience outpatients. I mean, I think I know the answer, but I think it's fascinating, the answer, but why?
I think that's a fabulous question that I feel I have not much knowledge to answer that directly. So oh yeah, I didn't introduce myself. So I'm a faculty within the Department of Psychiatry, and part of why I was hired and I got attracted to coming to UT was this very initiative that we have to start early. And that is the key to building resilience, to prevention, to promotion, and not just for children, but also families. That is how we build healthy families. And, we were fortunate enough to be funded to do this work in Fort Bend County. And I know there's a lot of services in Harris County. So the mission of this initiative is to be able to serve communities that do not have as many resources. So increasing access, right? And I think that is what drew me to this place. And I think this initiative is perfect for that. And I love little ones. So and I get to do this. I get to do and love and enjoy it. And I get to do it with a community who's committed to doing it. Absolutely. But I don't know some of the other aspects of it.
I think you answered it, but I think it's wonderful to see, a traditional psychiatric setting. I mean, with, really in one of the largest, probably in Texas, if not the country, that now is expanding their work and their focus to really on young children not resilient.
Yeah, and just to add to that, I think the field of psychiatry, even though it is focused on intervention for significant severe impact, I think the field of mental health is moving away from that really hardcore mental illness kind of perspective to moving towards more promotion, prevention, and starting early. And we cannot wait till the problem happens right? We saw all our numbers early in the morning, right, with Dr. Shah's presentation. We cannot wait for that to happen. We need to do something. And especially this pandemic has just brought that to the surface. And so we need to be doing this as mental health professionals. We can't just target intervention after, something has become a problem, something has become a disorder. So. Thank you.
I know we're running a little behind schedule, but really, we're going to be fine. So I know you all hear me say that a lot, but we're going to be fine. This is really fascinating because you will see these common themes throughout the presentations, which is good, because sometimes we really get caught up in, the evidence-based practice or the terminology. And then we have to step back and think about what is it that we're trying to do? We're trying to build strong relationships. We're trying to support families so that they can be there for their children. One of the things about the circles of security and the attachment work, and I have a really good friend, Dr. Prachi Shah, who's amazing. She talks about our ability to delight in our children. And that word just brings that joy. And just think, when we're struggling with all of our stuff, financial worries, domestic violence, depression, work, everything else, we lose that ability to delight. I think that's such an important concept that I hope we can all hold on to. So with that, our next presentation in this series is actually by Amit Matwani. I got it? Okay. With the Rupani Foundation, who actually are also our sponsors for lunch. So I'm very grateful. And, we started having this discussion. I think we met before the pandemic and heard about this program called Informed Parents, which actually is an international program. And just amazing work, again, about supporting children and families, starting early. And so thank you for being here and thank you for your support. So turn it over to you. Thank you.
Before I begin, I'd actually like to call our board chair and founder, Dr. Rupani, to share a few words.
Can I? Sure.
Can you? Thank you.
Coming up, so just bear with me because I just got it on.
Nice.
Okay, cool. That's, I'm gonna put it on.
So obviously we've never set out for a hybrid presentation. So we're very grateful that our IT department could actually be able to start.
Good morning, everyone. My name is Nasruddin Rupani. I'm the chairman of the board and the founder of Rupani Foundation. I wasn't planning to speak, but while I'm listening, I really feel I should address it and at least bring it in front of the experts, what I feel, because you're an expert, I'm not certified expert, but I think we need to still think, when you say early, how early and when we need to start talking about it, right? Where does it start? What are the root causes? So I think we need to start looking at, I've always been advocating that our terminology from 0 to 3 is outdated. We need to talking about -1. Let's talk about -1 to 3 and 0 to 3, because I think we don't know where zero starts. So I feel like we need to talk about -3. And also I think it's very important that we really talk about mother's health. Mother's health is far more greater important than the child's health, because if mother is not healthy, don't expect the child to be healthy. So that's why Rupani Foundation is investing into prenatal conference. So we are hosting every year a prenatal conference for all pregnant mothers in this country. And one thing we're doing is diversifying it. We're going to have this conference this year in multiple languages, not English, Hispanic, Persian, any language. So we're going to talk about diversified prenatal conference. Another thing I would like to really see that we need to collaborate. We are sitting here, we don't know each other, but we need to collaborate and work together. Thank you.
So, uh, you'll hear non-experts often use phrases like "they say," because we want to be careful not to step on an evidence base somewhere. And they say that our brains are wired to react positively to cuteness, and that we're sort of intrinsically compelled toward it, and ostensibly that's a possibly a survival mechanism for young, cute children. That's why, when we see young, cute children, we want to pick them up and take care of them. And so I do my best to try to incorporate as many photos of these young, cute, happy kids that we get to work with, because I think it just really, really creates a lot of good positiveness in the presentation. So what a great place to start with some photos of the children whom we work with here in the U.S. And actually here both in Southwest Harris County and the border with Fort Bend County. Want to first recognize and thank our board chair and founder, Mr. Nasruddin Rupani. He's a great human being. If you don't know him, please find him and shake his hand. He's obviously into collaboration. Outside of running global enterprises, he's an international philanthropist who's been investing in international development for more than a couple of decades now, and brought that philosophy home, realizing that think globally, act locally. Investing in our own backyard, realizing that early childhood development and early interventions are equally as needed over here as around the world. It's easier to name which boards he's not on than the ones he is on. So you'll learn much more about his work. And he also sits on the Behavioral Health Advisory Committee for the state of Texas. So yes, very, very, very glad and privileged to be able to work with Mr. Rupani. I want to, on the note of not just following the giants who preceded me here and are in the room, but those who've influenced so much of what I will be parroting. Because again, I'm not an expert. What I am is an executive administrator who's been exposed to the brilliant evidence-based data and the interpretations of it that all of you experts bring to us. And so I will be a parrot. And the folks I'm calling out here are folks who have influenced not just obviously the field, but I've been privileged to maybe have been able to work with some of them directly. Dr. Keonta Moore, who is a multimodal researcher, one of the Renaissance people of our time here in Houston. She is a fellow at the Baker Institute at Rice, as well as the head of the Hackett Center for Mental Health at Meadows. She also did the evaluation of our Informed Parenting program, which I'll share with you later. Dr. Cynthia Osborne, the head of the Child and Family Research Partnership, and now at the Prenatal to 3 Policy Impact Center. I'm a sort of a fan person, and I wait every year for when she and her group are going to release policy guidance on early childhood education. Quinn Ann McMahon, who's local here and in Fort Bend County, who I think is just a gem at the George Foundation, I think is really, really doing bleeding edge work on human-centered design with coordinated asset-based community development. Dr. James Heckman, the Nobel laureate, earliest investments lead the greatest return. You can't have salient work without economists coming and mucking it up with money talk. And Dr. Heckman got the Nobel by showing the return on investment for early childhood education, by putting that into dollars. And folks have interpreted his work to say that there's a 9x return on early childhood and investment. That's huge. Dr. Letha Houston, who is emeritus over at UT, but has been at many institutions, and her work is integral to proving the efficacy of programs like Sesame Street and how media can be very helpful in early childhood work and how to do that positively, not to mention, of course, her work in childhood poverty and early childhood education. Dr. Libby Doggett, who, is part of the Obama administration in education, really, really brought this back to the mainstream for all of us. and brought it back to national policy. Dr. Bruce Perry, who was cited earlier, the head of the lead of the most well-known longitudinal study, 30-year study now, 40-year study possibly at this point, on the efficacy of early childhood education that began in the mid-60s. And Dr. Cynthia Lamy, who I think came up with worked really hard with the Robin Hood Foundation to come up with some econometric equations on the return on investment for early childhood education. Dr. Chris King, I had the privilege to work with, who really focused on dual generation interventions. He's an Ascend Fellow at the Aspen Institute, and he looked at combining the efficacy of workforce interventions for parents and early childhood education in the same household, and how that creates an interlocking strategy for breaking intergenerational poverty and creating economic mobility across generations. And of course, present company, Dr. Asim Shah, who whenever he coughs, it becomes a peer-reviewed publication, and Dr. Almeida here, who I had a great conversation with on the phone, and was telling me that she was she's been for decades already interested in the econometrics and the merging sort of the pragmatism and the moral imperative of investing in early childhood education. So it's a privilege to be able to work and be exposed to the work of all of these folks. Now, my biography is really, I had to start, I helped start a company called Now Social Solutions that makes Apricot. It's a nonprofit. And, you know, from there, I pivoted into direct services and have been in the nonprofit health and human services arena for a while. Been able to have been in direct service programs, worked with Dr. King and Dr. Houston on developing a 2-gen anti-poverty strategy for the city of Austin, as well as with the LBJ school, developing some econometric equations there, and have had the privilege to work with so many families around solving community problems and building collaboration to better address family needs. But remember, I'm a parent, so don't take my word for it. I'll do my best to cite the best experts as we're moving forward. The Rupani Foundation uses the Informed Parent Program. It's a curriculum that was developed uniquely for Rupani Foundation in its work in Pakistan originally, in making sure that parents, uniquely moms, could be the first and best teachers of their children. Because early childhood education and center-based education, which I think the data shows is the best, is not necessarily available or plausible to be able to deploy on a wide scale. So how can we bring that knowledge to the parents where it could be most efficacious? And not only that, but the negative one here, how can we bring that knowledge to pregnant parents so that they are aware of the importance, of course, of prenatal health and the implications thereafter? We inform, unlock, and connect. Inform by means of direct education in these parenting groups. We unlock, you know, as my board chair was mentioning earlier, so much good information is out there, but it's under lock and key because it's not necessarily accessible by language or for whichever other obstacles there may be. Let's get that out there. If that means translating everything, let's do that. If that means just putting it on big screens everywhere, let's do that. If that means making conferences for community members as opposed to the professionals, let's do that. And so that's the unlock portion. And then connect, of course, is the wraparound. We have to make sure that we are supporting the family in all of their needs so that we can protect that early childhood investment. So helping navigate the social service system and make referrals and warm handoffs. Don't take my word for it. Let's see. If I do that, did it come? Oh, there we go.
If I can get this message to the world, I will be so.
And let's pause for a second. Could we applaud for Shannon Brown, please? Not only has she been there every step of the way for me with the presentation and how to get it uploaded and everything. I mean, I'm talking about midnight last night. But she took time to tell me to breathe and to take care of myself. And, you know, Shanna is a gem as well, you know, so thank you so very. Now, we're seeing this interview with Oprah Winfrey and Bruce Perry, Dr. Perry, whom we've mentioned earlier. As soon as I started with Rupani Foundation a little over a year ago, this is the first thing we did because he was speaking with Oprah like literally a week after I joined. Our whole team got together and we watched this live at South by Southwest EDU. This is just a 2-minute portion, but it's pretty salient. Let's take a look.
People may be surprised or even shocked to learn that our brain development and decision-making patterns are shaped by the first few years of our life experiences. And, you know, when I first started talking to you 30 years ago, we were talking about, we were doing a program called 0 to 6, what happens in those 0 to 6 years. What I have since learned from our discussions is that it's not even, it is 0 to 6, but those first 2 months, which makes sense because anybody who has ever had a baby, been around a baby, knows anything about babies knows in those first couple of months, that baby is just taking in everything. They're like a sponge. Sure. And you're saying in this book that in the first 2 months, go ahead and explain it.
So,
This is the big moment. Attention, everyone.
all right. So first of all, I think, you know, there's a lot of work that's shown that adverse experiences or traumatic experiences during development change your biology and make you at increased risk for heart disease, you know, mental health problems, substance abuse, all kinds of bad things. But if you actually start to look at when those adverse experiences take place, it turns out that the most important time appears to be this first, you know, the first start in life, the first couple of months. And so when we look at kids who have lots of adversity and few relational supports in the first 2 months of life, then they get into a healthy environment. After only 2 bad months, they have worse outcomes than kids that have a good 2 months. And then something happens where all kinds of bad things happen, lots of trauma, lots of adversity.
Okay. So, you know, it's not all doomsday, but it's pretty salient to know that those first 2 months are that important as far as the insulation that can occur by having a positive environment. He goes on to say, fortunately, that okay. Thank you. He goes on to say that that's not the end, that we can continue by consistently creating positive environments through institutions and protective factors that can be solved for. And that kind of resilience, as we've heard about earlier, can be created. So it's not over. We have to continue. Now, so we know that early matters for school readiness and for brain development and emotional health. So, you know, no problem, right? Well, yes, problem. There are 2 key really strong standards for early childhood education. NAEYC, N-A-E-Y-C, that I'm sure we've all seen that acronym, as well as Head Start. Now, NAEYC is typically the accreditation for private childcare centers, you know, that are very top level and meet very, very high standards. Now, those are going to be very expensive centers. Head Start centers are the centers that are federally funded that should be accessible to folks who are technically in poverty. The problem is this pie. Not that it's out of season for pumpkin pie, but the problem is that this is what we have available for Head Start, and this is pretty much the population who needs it, or who needs to be accessing this kind of education. Actually, that pie sliver should really be half of that. And the problem is scarcity, it's cost, there's cultural barriers as well. I grew up in Fort Bend County over by Willow Ridge High School, and my mother worked, she cycled through 3 shifts during the week. And nobody could have convinced her that I would have been in better hands at center-based education at 7 months or 12 months. She would have held me tighter. There are cultural barriers to that as well. And so those need to be addressed in many ways. And there's a study out of U of H coming out right now that's demonstrating something similar with Head Start enrollment. And then, of course, education on the importance of this. So no matter how you slice it, it's a problem. And I think slicing a pie like that might still be illegal in Fort Bend County. I'd have to check with Sheriff Fagan on that. But it is a problem, and it's a problem because we are more stressed out than ever before, and the risk factors are higher than ever before. And going back to those ACEs, I encourage everyone to take an ACE quiz. It's 10 questions long. My score is a 4. Take a look at what your score is, and then see what the potential outcomes could be related to that. But these are risk factors. Anyone tell me what they see here, a risk factor they see here? Just shout it out. Yeah, okay, you're giving me the number, right? But tell me an example of one of these risk factors. What do you see? Nutrition, yes, poor nutrition. What else? Screen time, right? Lack of stimulation. What else? Domestic violence, right? Trauma in the home. What else? Depression. Remember, someone caught that. Yes, depression. What's that? Substance abuse. Yes, that's correct. All those things in the household create risk factors, which obviously affect brain development and definitely affect parental and maternal interactions with the child. And then, of course, we have the global stressor that encompasses all of it, which is financial. Poverty is a huge, huge risk factor for so many families. Now, that's not the end of it, because there are protective factors, and that's what our job is to try to insulate and create resilience by inculcating protective factors, not only within the family, but also within social institutions. Someone want to name some of the protective factors we see here? Positive adult role modeling, fantastic. Our board chair loves to invoke the proverb, I think it's from at least a couple of Nigerian tribes, and it's iterated throughout Africa as well, that it takes a village to raise a child. And you'll see this group of adults, anyone think about a non-parent role model in your life who is there for you and just, a good person? Could be an aunt, uncle, teacher, friend, but my mind jumps to exactly who those folks are, and I still remember them now. It makes a very, very big difference. You see positive interactions between mother and child, healthy stimulus for learning, experiential learning activities. You see this young girl with horses. That's why out of school time programs are so important. Whenever something isn't happening right at home or not happening right at school, how can we continue to supplement and subordinate to try to make up for that and create protective factors? Of course, good nutrition, and you'll see these moms learning stress management techniques. Now, to be clear, 3 of these photos are photos of our programs. And so, always insert cuteness here. Don't take my word for it. Dr. Kianta Moore, I lifted this slide from one of her presentations, demonstrates, of course, the risk and protective factors and the positive contributive factors for early childhood brain development. Let's watch one more video. This is going to be of what we do with our Informed Parenting program, how we try to contribute to the insulation and the protective factors.
In a world full of wonders, all a child needs complete care and a learning environment to explore the hidden treasures within himself. Bali Foundation, a vision to promote and contribute towards the holistic development of children. The nexus of the foundation is to provide essential early childhood development services at household and community levels, leading to enduring solutions to poverty alleviation. Societies without education are paralyzed in true sense, and if the issue prevails, it can be catastrophic for the children as well as the society they are living in.
Poverty is the main cause for non-availability of education in most of the marginalized societies. According to a recent survey, 90% of the families are living in poverty with very limited access to quality education. Through the development-oriented programs, Rupani Foundation plans to provide high-quality, free early childhood education services to the communities and facilities in responsive parenting, health, hygiene, and family harmony. These programs mainly focus on pregnant women and children up to the age of 4 by involving and engaging parents in the process of brain development and early education in order to equip them with necessary mental, psychological, and physical care and awareness. Through these efforts, the Bani Foundation plans to bring change in the behavior of the marginalized communities by pushing them out of the vicious cycle of poverty and social deprivation.
Open and shut. That's going to be stuck in your head all day long. So let's see. Did that get me to the next? There we go. And cultural competency counts. And we're looking at our team on the right-hand side. When we're working, we actually have built a group, and we're modeling a unique community mental health program that creates sort of a crosswalk between the clinical side of mental health and where the families who are refugees right now need to be met. And on the right-hand side, you'll see our team. They actually they sang verses from the Quran for some Afghan refugee women who don't get these opportunities to share. And they did Mehndi, and we're sharing stories. And we develop trust that way. And with trust and early childhood education, you have a window into the family to be able to then bring in all sorts of other services that the family may need, whether it's clinical support, educational support, social services, or what have you. Speaking of wrapping around, we have the Informed Parents program sort of as the epicenter of our work. And then, of course, that's the gateway to being able to bring in the other key mechanisms to really protect that investment on early childhood education. And this is, very tiny, but these are some figures from Dr. Moore's evaluation of our work. And basically, the left slide shows where the assessments were at the beginning, and the right slide shows where they were after the program. And the dark blue is showing that, that excellent, basically. And these elements are behavior management, supporting peer interaction, entertainment for the child, playing with the child, singing with the child, storytelling with child, reading with child, info sharing with child, learning material, child supervision, daily routine, home environment. These are all things that are obviously very important for positive parenting interactions and for positive brain development. Cost. Well, we know Head Start and NACI centers typically cost about $1,000 a month. And programs like this can cost $650 per participant. And this is important for policymakers to know. This is not a replacement for center-based education. And I don't think any data is going to tell us that. However, folks like Jim Heckman, who was the original economist to bring value to early childhood education, is now studying programs just like this. One that's happening in Jamaica, Bangladesh, Ireland, and in rural China. That's a very similar program where community health workers go and visit the home environments and demonstrate positive parenting and interaction techniques to moms specifically. And the ROI is very high. And so it's definitely an intervention that's worth considering, especially when it comes to being able to go to scale, because it will be a long time before that pie slice meets all of our needs. We try to use the village, asset-based community development. And so we're blessed to have a lot of partnerships. The Alliance is in the room, and among many others whom we partner with, and many potential partners. You'll notice a couple of the Fort Bend institutions there on the bottom, subtle messages that if you aren't partnering with us, holler at us. And, clearly I'm not worried about seasons with pumpkin pie in the summer. So a little Christmas doesn't hurt anyone either. So thank you all so very much for watching our presentation, and happy to answer any questions offline.
Thank you. This is just really fascinating. The common theme, the importance of connection, building that trust, building that safety, not only among us, but, fine, I'll go back up here. That with the people that we work with, and you see that common theme in the Informed Parents Program and the Circle of Security and the TBRI that, we'll be talking briefly about later. So that's just fascinating. Okay, we need a break. So just come back as soon as you can. Yeah, 10 minutes. I know, you've all been great, just 10 minutes so we can get started. We have some having some great discussions, which are really important. That if we can definitely start in 5 minutes, that'd be great. We definitely don't want to push lunch back too far. So we will break for lunch at noon. Lunch again is available in our break room right to the side. And I think it's box lunches. So we have 30 minutes for lunch, just for people to get their lunch. And then we actually have a panel discussion that's going to be facilitated by Dr. Profile with 3 of our judges that have been working with infants and toddlers, are very familiar with trauma-informed care, with TBRI. So it'll be very interesting to hear, and a great opportunity to hear from judges of how they incorporate this work into their courts and into the cases that they see. And I just wanted to mention also a couple people that are here that we've worked with for a very long time, and Daphne McCadney. Do you want to stand up? Yeah. So Daphne is, I don't know what her title is now, but she's a CPS program supervisor, but we've been working with Daphne, I don't know, Daphne, 20 years?
You and I have been working for 25.
Oh, God, yeah. Okay, well, I just ran into somebody that apparently I supervised 30 years ago. So that was when I was working with Richmond State School Community Services, right? And people with IDD. That's a long time. CPS is, we all hear stories about CPS. It's really, really hard work. I actually am on the advisory council appointed by the governor to the advisory council for the Department of Family and Protective Services. And, we listen, we study, and we try to advise. Complex system, a lot of trauma going on with not only the children, but of course the workforce. And, I'm really good friends with the judge who's the chair of the committee, of the council. And so she spent a lot of time writing with CPS and actually going out to the homes and doing the investigations. And we've learned a lot by doing that. So I just want to say, Daphne, thank you for all your work. She's retiring soon. It's kind of, how many days, Daphne?
It's not till October 31st.
Oh, okay, good. Thank you for all that you've done. So, okay, so with that, I'm actually going to introduce our next speakers. I'm sorry, I can't see very well. So trauma and grief, and this is really an important distinction. And so I'm really delighted that we actually have 2 speakers that are going to be focusing on this. So Dr. Stacy Grant, who's also with UT Health Houston in the Nurturing Resilience Initiative, is going to talk about the 3 T's, oh gosh, that's hard to say, of trauma: trajectory, treatment, and trust. And then Dr. Taylor, who's a licensed psychologist, also with UT Health, is actually going to talk about making meaning and moving forward, recovering from traumatic grief in youth. So really excited. So we'll have both of those speakers until about noon, and then we'll break for lunch, 30 minutes, and then come back for our panel discussion. Thank you.
Hello, everyone. So my name is Dr. Stacy Grant. You're gonna have to excuse me. This is my first in-person presentation in a very long time. So if you find me like staring at the screen, it's just habit, been virtual. So let's see, how do I? There's a clicker. There's a clicker, right? Oh, okay. Is there a pointer?
Yes.
This one? We do. Look at that. Yeah. Yeah. Okay. Changes everything. Should have never told me about that. Okay. So I will just introduce myself briefly. I don't want to take up too much time, but my name is Dr. Stacy Grant. I already said that, but just to reiterate, I am a postdoctoral psychology fellow. That might be kind of a big term. What does that mean? Basically, I just received my doctorate and I'm still in the process of training. And yeah, wrapping up in a couple months. Really exciting. Saw some claps. Thanks. I'm also part of the Nurturing Resilience Initiative. So I am working through UT Health as well with Dr. Jacob and with Neptali. So let's see here. Oh, okay. Still trying to figure out the pointer, guys. Okay. So try to come up with a really catchy title, you know, grab everybody's attention initially and then continue on with the information. So the 3 T's of trauma: trajectory, treatment, and trust, which as Dr. Almeida, I'm not sure if I'm saying that correctly. It's really picking up on the themes that we've been talking about this morning, right? So trust, what trauma looks like, how it can look differently across ages, all of those kinds of things. So just brief overview. So I'll talk a little bit about the definition of trauma. Surprisingly, I don't know if that's come up this morning already. We've used the word trauma a lot, but maybe some people don't quite know what it means or what it consists of. We'll also touch on the trajectories of traumatic stress. So how can it look differently across the different stages and in different people, regardless of the event that they've experienced. And then I'll also touch just briefly on trauma-focused treatment. So there is quite a few. Okay, so what is trauma? Does anybody want to take a stab at what trauma, like what's the definition or what it means? Really okay if not? Yeah, exactly. So it's just a really distressing event, right? So props. Perfect. Thank you for being a volunteer. So it can be, it's defined as just a disturbing or distressing event, right? More specifically, there are quite a few varieties of trauma. So there's acute trauma, chronic trauma, complex, all of those kinds of things. And that can vary in terms of the number of events. So in regards to the ACEs we've been talking about this morning, how many events or how many traumas has an individual experienced? If it's acute, it's just one. Chronic, it could be repeated exposure to the same event or a similar event. And complex trauma is more so multiple events. All right, so I'm sure we've all heard of PTSD. So it stands for post-traumatic stress disorder. This is where we're getting into kind of the specifics of maybe mental health psychology, what it means to be diagnosed with PTSD, what that can look like. In addition to being diagnosed with PTSD, there's a variety of other diagnoses that take into consideration general trauma. I keep forgetting that I'm not pointing up here, I'm pointing here. So one of the first and most important things is that the individual be exposed to a traumatic event. I'll touch a little bit on what kind of events those might be. But the exposure can be either direct, so the individual experiences kind of head on whatever the event may be. It can also be an indirect exposure. So anybody in terms of like our first responders, nurses, doctors, really anybody that is continually being put in a situation where they're experiencing a traumatic event. It doesn't have to be either one of those things. It can be someone that's a witness to an event. Or even just learning about it. So if you find out that, a loved one of yours is experiencing domestic violence, or you, even our counselors, our psychologists, anybody that's working in behavioral health, if they're continually being exposed or hearing about situations their clients are experiencing, that can even serve as a traumatic event as well. So kind of getting into the specifics of PTSD, individuals will have to experience or tend to have re-experiencing, which consists of these individuals here. So get ready because this is about to happen a lot, this pointer stuff. So distressing dreams, memories, thoughts, a lot of distress that comes from re-experiencing the event. Avoidance, it would have to be at least 3 or more, catching my typos. Places, people, activities, or thoughts and feelings that tend to be related to the event. And increased arousal. So you find that you have difficulty sleeping, bouts of irritability, trouble concentrating. I'm using a lot of psychological jargon up here, but hypervigilance can mean always being on edge, right? Or being very startled, easily startled by certain things that maybe you wouldn't have been startled by before. So a lot of these, so going back to re-experiencing, avoidance of certain things, increased arousal, all of these things would need to occur for more than 1 month for it to be considered PTSD, as well as having clinical or just more increased distress or impairment, specifically in terms of like your day-to-day stuff. Not being able to go to work, not being able to engage in relationships as you normally would, because the trauma keeps replaying and is really kind of putting a hold on just doing what you would normally do. So what does it mean in terms of a traumatic event? What does that look like? Before I go to the next slide, does anybody have an idea? You could just shout them out in terms of what you think might be considered a traumatic event. War, death of a parent. Yeah.
Every time I tutor, your parents let me get a telephone.
It's just like life shattering.
Incarceration.
Uh-huh. There's a big one. I'm surprised no one's really shouted out just yet.
It's abuse.
Abuse.
Human trafficking.
That's a huge one.
Car
Car accident. Yeah. You guys are all touching on a lot of things that are on this very non-exclusive list. Natural disasters, hurricanes. What was that?
Freeze.
Yeah. Oh yeah. What was that? I'll remember the name. Snowpocalypse or something. I think it was something somebody mentioned. War, serious injury, motor vehicle accidents, witnessing violence, domestic violence, abuse, sexual assault, and even neglect can serve as trauma. COVID, could be a really big event as well. Okay, so trajectories of traumatic stress. What does it look like? How can it vary? So per this very elaborate chart that I have here, so you'll notice that the disaster will occur, followed by any immediate reactions to the trauma or to the disaster, followed by both short-term and long-term recovery. So typically what you will see when someone experiences a traumatic event, or if they classify for PTSD or any other stress-related disorder, you may experience some resilience. So basically you'll have an immediate reaction, but then you'll tend to kind of level off and kind of go back in terms of what your day-to-day functioning may be. You're not experiencing really any distress, no symptoms that I'll reference here just in a little bit. Some people may experience just resistance, which means they don't have any distress. They don't experience any symptoms in regards to the trauma. None of those things that I mentioned on the first slide, right? In terms of delayed onset, you'll see bouts of resistance. And then all of a sudden, when you think you're okay, it's like, oh, nope, here's these symptoms. Here's the trauma playing a role in your day-to-day life. Chronic is quite the opposite of resistance, right? It's where just distress all the time, and you're just kind of wondering, okay, when is it going to go away? Recovery, relapse, has a little bit of resilience here, and then also kind of resemble just the difference in terms of when the symptoms are playing a role and when they're being most present within your day-to-day life. Yeah. All right. So how does trauma impact our general mental health? How does it impact our functioning? The one thing that I didn't, as I was putting these slides together, that I didn't realize was maybe the use of animations. Again, with all this virtual presenting I've been doing, that's all I did was like animations and videos and images, because I'm trying to get some engagement when people maybe sitting at home, having to deal with a lot of other distractions, right? So one thing that I might like to reference in terms of this slide is a traffic light, right? So your red, yellow, green light when you're driving. In terms of these kind of steps of impact on mental health, prolonged sustained distress and impairment is your red light, right? So when you are reacting to a traumatic event, the red light's kind of like, stop, can't go anywhere. Everything that you do and everything that you think in any part of your life is impacted by the trauma, right? Your yellow light is more so these acute trauma reactions, something that happens maybe very immediately, but then tends to subside very quickly as well. So it's not something that tends to linger for a long time. And resilience is obviously your green light that says, okay, a situation happened. We experienced this really difficult or distressing event, but we have the capacity to recover very quickly. We have the ability, the support that's been mentioned. We have all of these protective factors that are allowing us to move forward. Okay. Telling you, I'm getting tripped up by pointing up here. So we talked about a traffic light metaphor, right? The other thing that's really important to remember when we're talking about trauma are the ABCs of trauma. So you'll notice A, affect, B, behavior and biology, C, cognitive, and the S's are the social and school. So what do all these things mean? Affect really takes into consideration more of our emotional reactions, whether we're feeling some anxiety, maybe experiencing some guilt as a response to the trauma, anger, sadness, feelings of helplessness. Behavior takes into consideration just that. So what are our actions? What are our responses, our reactions? How is our sleep? How is our appetite? Everything that we need to incorporate into our day-to-day, how we express ourselves. It can even take into just more of our health behaviors. Are we experiencing any difficult, increased heart rate? Again, referencing sleep and appetite, or more so, behavior. In terms of our cognitive aspects here, this can take into consideration difficulty concentrating, having those same unhelpful or intrusive thoughts repeatedly, as well as maybe memory problems. And social and school is one thing I think in terms of it can be at any age really, but in terms of children, social could be being more avoidant, withdrawn, not doing those things that they enjoy. And school, you tend to see a decline in performance, motivation, all of those things, completing assignments. So along with the ABCs of trauma, we also will tend to see an increase in comorbidity. What does that mean? If you have trauma, if you have PTSD, if you're diagnosed with any of those things, there is a very high chance that you will also be diagnosed or struggle with something else, specifically major depressive disorder, an increase in substance use, panic disorder, which can make sense, right? In terms of being easily started. So you're always feeling on edge, always reading into maybe some signs that your body's telling you that something's wrong, as well as suicidality. So those that 80% per the slide, as they say, right, will tend to experience just a difficult try with regarding, reliving, re-experiencing all of those things in regards to the trauma that they had experienced in the past. As well as functional impairment, which I had touched on that. I think we'd all touched on that a little bit already as well. But having difficulty in our relationships, our jobs, how do we function at work, financial stressors, how are we dealing with I don't know about you guys, with increases in housing and paying for housing and just the general increase in across the board. Gas is increasing, like just paying for groceries and all of those kinds of things. Financial stress plays a huge role in terms of trauma, as well as any just specific health problems, mental or physical. Okay, so up until this point, I've really talked about trauma just more generally and how it impacts us regardless of age. But how does it impact our youth? So in terms of abuse and victimization that we often see in childhood, these things can be correlated with other forms of trauma, whether that's PTSD, an acute stress disorder, anxiety disorders, specifically social phobia, meaning you're not wanting to go out and engage with other people. You find that you're often very, they're avoidant, they're not wanting to spend time with friends and others their age, other peers. Generalized anxiety disorder, depressive disorders, again, increased substance use or even abuse or dependence. I know we talked a lot about vaping, marijuana use, other use of illicit or street drugs, right? That's one thing you'll tend to find is more used in individuals or children that have trauma or a history of trauma. And delinquency and criminal behavior. So specifically in terms of children, as school-age children, those that are in high school, truancy can be a big factor or a big sign in terms of trauma. So if it's impacting the individual, they will tend to either not come to school, they'll be late, and they're having difficulty sleeping, which then kind of trickles down into their day-to-day. And just more generally, violent behavior. So not only pure aggression, but then you'll see aggression within dating and spouse or partner violence. Other problems can often, you'll see in our kiddos is lowered self-esteem, often a lot of self-blame or shame, academic performance, like I mentioned earlier, and more neurobiological impacts on development. Okay. So this chart is from a study that was conducted in 2009 by Finkelhor, Turner, Ormrod, and Hamby. So it's a little bit dated, but it gives the idea in terms of level and percentage of victimization in our youth. So the study was based on a cross-sectional national telephone survey, which I thought was, 2009, what is that like? Oh my God. 10, 15 years ago, something along those lines. It's not that long ago. So, but when you think telephone survey, I don't know, but it involved quite a few children aged 0 to 17. So as you'll see on the chart across the range here, and then in terms of percent victimized. Before I go into any numbers and kind of discuss what this chart means, any thoughts or any kind of shout outs that anybody can pinpoint from this? Any conclusions we can draw? Maybe kind of hard to see too.
There's a particular spike in witnessing violence as folks age. Yeah,
exactly, right? Especially here, just in terms of like not even the specifics here, but you'll see like any victimization. So any event here tends to go up, especially in terms of like sexual victimization with age. Maltreatment tends to stay pretty low, but consistent across ages. Physical assault. So it was pretty shocking in terms of their results. 60%, which obviously you guys can tell in terms of the percentages here, but that's a pretty large number. That's more than half of the children that were surveyed or the parents that were surveyed in terms of one victimization. In terms of experiencing 2 or more victimizations, the percentage was about half of 60, so about 38 to 40. That's still a pretty large number in terms of our children who aren't even really considered to be an adult yet, right? So under the age of 18.
It's just a question about the data, sorry, but is it self-report?
So it was both self-report and based on parent. So there was a combination of both, but the The sample size was, I think, about 4,500.
Right, well, it might just be that they don't recall that, or they didn't have the words to label that as
Right.
domestic violence.
Right.
Sure.
Right, exactly. Very good point. Or like Dr. Shaw had referenced earlier in terms of child abuse not being reported. It's not that the number had decreased, is that the reports had decreased. So just something to keep in mind. Yeah, yeah, exactly. Okay. So what does trauma look like specifically in terms of age? Well, within our early childhood, so kiddos that are younger than school age, so younger than 5, you'll tend to see an increase in more fearful reactions across new situations, a more stronger startle response, more aggression, especially more tantruming, regression in terms of milestones. So whether that's walking, talking, toileting, as well as a poor development of emotion regulation skills. So I know I had used that word earlier. Dr. Jacob did a really great job of explaining what that means. But basically knowing how to handle those emotions as they come up. Within our school age children, more increase in intrusive thoughts or unhelpful thoughts that are linked to the initial trauma. A shift between being both withdrawn and aggressive, so avoiding or isolating self. Again, poor emotion regulation and social adjustment and fewer friends. But if they're withdrawing, that would make sense in terms of why they don't want to, or why they're isolating or having fewer friends. Within adolescence, they're often very embarrassed by the trauma reminders, which can make it difficult for treatment because they're not being open to expressing the reaction or the reminders. Increased risky behavior, so substance use, sexual engagement, and poorer school performance and occupational achievement. Lots of things that we're kind of touching on that are continuing to pop up, right? Additionally, within our early childhood kiddos, we'll see that brain development, like Donna, right? Okay, as she had mentioned earlier, which I thought that was a great presentation, but it highlights again that trauma can impact our brain development, level of IQ, ability to handle any difficult situations that may come our way. Within our school age children, we'll notice that they are less likely or have difficulty managing fears. Again, a lot of the emotions that come up with the anxiety and aggression, sustaining attention and learning, problems with impulse control, adolescence, again, difficulty being able to gauge or estimate what may be dangerous and what may be safe, which would make sense if they're engaging in a lot of risky behaviors because they don't know. They may not be able to tell the difference between the two. Additionally, poor understanding of consequences and difficulty with more general problem solving. So one thing I want to touch on now that we're talking about how it looks and how it may play a role in our school age children is how can trauma and ADHD look different? With a lot of these things that I'm touching on, a teacher may just say, oh, you just the kiddo has ADHD. It's difficulty sustaining attention, difficulty staying in a seat, all of those kinds of things, because it's a pretty common thing that's coming up in our schools, and that I often find I get referred a lot is kiddos that are dealing with attention issues. So it's really important to, as a provider, as somebody that's trying to highlight, is it trauma or is it ADHD, is to look really closely at the behavior and to try and to get an idea as to what thoughts are they having or what are their behaviors related to. When do these things come up for them? Is it specifically within the school? Is it at home? Is it even in the presence of somebody that they're around pretty frequently? That's one thing that I would recommend if somebody's trying to identify the difference between those two, if it ever comes up. Okay, PTSD in young children. So I'm sure since there's a slide on it, it may be kind of obvious that the answer to the question I'm about to ask you all. But is it possible for children, especially young kiddos, to have PTSD? Yeah, right? How funny would it be if I clicked and I was like, no? Not funny, but anyways. So yes, young children can and do develop PTSD, but I think the difficulty is being able to say, how do you pinpoint that? How do you identify in terms of their behaviors? What if they're unable to speak to you and tell you what they're thinking or how they're feeling? So it's often very important to highlight that classic triad. What does that mean? Really targeting or labeling their thoughts, helping them to put into words maybe what they're thinking or how they're feeling, identifying their behaviors through observation. Just go ahead and go to the last one there. And yeah, thoughts, behaviors, actions. Those are really important to try to help pinpoint, is my younger child experiencing some reaction to trauma? So you'll notice within play, a lot of the focus on their play or their directed play is more specific to the trauma. So is it recreating the trauma? Are they having increased nightmares regarding the event? Those types of things. We talked a little bit about the attachment, right? So if you notice that the attachment maybe is insecure between the parent and the child, there may be some new separation anxiety. So when the parent walks away, the child will cry. But if there's no attachment there and the parent walks away, child is just kind of trying to attune to themselves and care for themselves. Okay. So I'm going to touch on just briefly some options for trauma-focused treatment. But one thing I want to highlight before we jump into it is the difference between trauma-informed and trauma-specific, because there can be a good difference between the two, and it's often a good indicator to know which direction you want to go. Do you want to seek some trauma-informed care or treatment for the individual, or does it need to be more trauma-specific? So trauma-informed is primarily services that incorporate knowledge about trauma in all aspects of delivery. So this can look like police investigations, any legal proceedings, child welfare, or physical or mental exams. So it's quite a variety, and it's a lot of things that I believe maybe a lot of individuals in this room provide, right? So the services that you may be specific in providing are more trauma-informed, whereas trauma-specific is designed to target the symptoms that the individual is experiencing. So a lot of things that I've been referencing throughout this presentation, the ABCs of trauma that I had referenced earlier. So some examples, which I might be able to just go ahead and jump to the next slide. Pinpoint, because I will talk about that, but prolonged exposure, cognitive processing therapy, and trauma-focused cognitive behavioral therapy, which I'll touch on a little bit in a few slides. But some things to just in general to remember when you're considering trauma-focused treatment. So let's say that you are in a situation you have to refer out. There's an individual or a kiddo that you're working with that may need trauma-focused treatment. Getting an idea as to what the components are can be really important. So first, most important, in my opinion, is psychoeducation. That's educating the individual on what is trauma, like we did today, what's its impact, what can it look like, just giving them those. Most people, when you provide education, they're like, oh, that's right, that's me, right? A lot of people that I work with, when I say like, well, what is anxiety? Can you tell me what it is? A lot of people don't know. And so giving them the answers to questions they may have is very beneficial. Directly addressing and processing the traumatic experience when appropriate. Increasing their sense of safety, both physical, emotional, psychological, giving them a safe space to be able to open up about the trauma. Helping them to identify triggers for their traumatic reaction. Some people don't know. More oftentimes than not, I will hear this situation happened, I reacted in a way, and I'm like, okay, well, what happened right before that? Or what do you believe? Oh, I don't know, it just happened out of the blue. More oftentimes than not, there is a trigger, and helping them break that down is something important to treatment. Developing emotion regulation skills. and also helping to develop trauma-informed parenting. You all may be wondering, well, what does that look like? How can parenting be trauma-informed? Specifically, that's helping parents to understand the impact of the trauma, helping them to recognize the signs, symptoms of what their kiddos are experiencing, and then also teaching them ways to be able to respond and understand more in the moment, without further traumatizing or serving as a reminder, that re-experience, right? So further adding to the traumatic event that the child had experienced. The main goal, though, is something that I want to highlight and that I probably shouldn't have put so tiny at the bottom, is the focus on improving symptoms and improving functioning, resiliency, and just general development. Those are the main things. So if there's nothing you take away from all of this, just remember this very tiny sentence down here at the bottom that I should have put in bold. Okay, so non-extensive list of trauma-focused treatments. These are just as another slide, but these are just a few of the excellent trauma-focused treatments that we can work with both adults, adolescents, children's families. Couple of good ones here, as well as these here. I think there might have been some focus on a couple of these already, or just touching on them. But one that I want to talk about, or two actually, but I can get through them pretty quickly, is parent-child interaction therapy. Has anybody heard of parent-child interaction therapy? Aside from the behavioral health providers in the room. It kind of gives it away, like just in the title, right? Parent-child interaction. It really works on improving the relationship between the parent and the child, right? It's an evidence-based approach originally intended to help address disruptive behaviors in children. Well, I was going to say just in early childhood, but not really, because it goes up to 7. But it tends to work best between children between the age of 2.5 to 7. It targets the caregiver-child relationship. It helps to improve the relationship with children, as well as teaches the parent more positive parenting skills. And then last, it's short-term, but not time-limited, so it can be anywhere from 12 to 14 sessions. Before I continue on to the next treatment, would anybody like to guess, and it's okay if not, why this type of treatment would be helpful in trauma-informed care? Yeah. So I think that's a good point. To be able to,
The answer.
she said resilience, to help improve resilience. Yeah, right. To be able to help foster and support that interaction, that relationship, and to be able to provide that sense of support for the child. The other thing to consider would be if the primary concern or the primary issue that's going on with the child is related to behavior or related to any kind of parenting concerns, this could be a good referral or resource for treatment for our kiddos. Okay, so trauma-focused cognitive behavioral therapy, mouthful, TFCBT, is probably the better go-to for that, the acronym. It's an evidence-based and evidence-supported treatment. Again, similar to parent-child interaction therapy, it conjoins the child-parent model. Is effective with children ages 3 to 18, so it's definitely more inclusive than PCIT. But again, it focuses more on the emotional and behavioral difficulties. So not just disruptive behavior, but also the emotions that are related to the trauma. And it's a component-based treatment protocol based on the acronym PRACTICE. Don't have enough time to go into that, but I definitely would. But it takes into, or it focuses primarily on psychoeducation, all components of PTSD that I had referenced earlier, so re-experiencing, avoidance, working with the parent to be able to accomplish that as well. And similar to PCIT, it's time limited, structured approach, and can be completed within 12 to 20 sessions. Okay. So when I came to this point in my slide, when I was creating it, I was like, I've talked about everything but trust. Slide, trust. So it's very important to identify trauma reminders. I know I just barely glanced over that. I barely talked about it, but it's so important to be able to identify triggers of trauma. These can be really a variety of things. It could be a person, a place, a situation, a feeling, a sound, a smell, anything that's happening in our day-to-day lives. It can be internal, external. But again, it's very critical to make that association between what is the trigger and what is the emotional response or the trauma response. What is that relationship between the two and when does it occur? If you don't know that relationship or you haven't identified those things, treatment tends to not be as effective, but it's definitely a critical piece to treatment. And provide trust and support. Whether you are providing the trauma-focused treatment or you're referring for them to engage in that type of treatment, providing a sense of stability to foster that support or that trust, to model what that looks like for children or even adults, even adolescents, at any age, is something very important to working with those that have experienced trauma. Okay, just briefly, referrals and resources. One really great one is the National Child Traumatic Stress Network. Child Advocates of Fort Bend offer a variety of services, and the Child Welfare Information Gateway. These two are really great websites. There is also, I think, the Attachment and Trauma Centers of Houston. They offer TBRI. I know there's some, I think we're going to be talking about that a little bit later on. But if you're looking for a provider, let's say that you went to all of these websites, there's no one at the Child Advocates of Fort Bend, and you're really struggling to find somebody that offers TFCBT or any trauma-focused treatment, going to that website specifically, tfcbt.org, you can find a provider across, I believe, the nation who's received credentialing. So, all right. And then these are just kind of the specifics, web pages if you guys wanted that information or any resources. But I made it right on time and I talked very fast. So thank you all. If there's any questions, please feel free to ask. If you need any follow-up, I'd be more than happy to answer. But yeah, thank you guys. Thank you for following along with my non-virtual self today.
We'll have all these slides available, right? So on our website and folks that download and all that, right?
Absolutely.
Right.
All right, well, good morning, everyone. And good morning, and thank you to Dr. Almeida for the warm welcome and introduction. Thank you to Dr. Grant for really kind of setting me up and talking more about the relationship between trauma and grief. My name is Leslie Taylor, and I have a research life and I have a clinical life, and they converge at trauma, especially trauma in children. And so a lot of my work focuses on how to provide effective treatments for children who have been through traumatic events, children and adolescents, and also how to do that in an efficient and effective way. Because what that looks like in a research setting may look a little bit different in a clinical setting. Today, what I'm going to be talking with you about is grief and childhood traumatic grief. And so it was really great to hear earlier when we were talking about what is trauma. What does that mean? Well, it can be loss. It can be the death of a loved one. And we're going to be diving in a little bit more deeply relative to that. The name of my talk today is Making Meaning and Moving Forward, Recovering from Childhood Traumatic Grief. And I want to talk a little bit about what making meaning means in the context of losing somebody. And so if you've lost somebody in your life, and especially somebody that you really care about, it's not necessarily making meaning about why the event happened. You know, some people take comfort in everything happens for a reason, but that's not what we're talking about here. We're talking about making meaning in terms of this person that you love. How do you sustain that love for them on a daily basis? How do you keep that going and memorialize it in an adaptive and healthy way? And so that's going to be a focus of what we talk about as we talk about adaptive recovery and grief. Okay, so our objectives today, we're going to identify some of the individual and contextual factors that contribute to grief reactions. So any of those individual differences that may serve as a risk or a buffer for us, and then contextual factors. So those can be anything about our surroundings, anything about our social environments that may pose a risk or protective factor for us. I want to help you guys increase your understanding regarding emotional and behavioral symptoms associated with childhood traumatic grief, and then describe some ways that you can support bereaved children, adolescents, and their families. And so some of the key takeaways today will be to examine and take a look at children's mental health currently, because it's a little bit different now that we're kind of coming out of the pandemic than it was before the pandemic, and how this can serve as an increased risk in terms of being able to adaptively recover from grief. I also want to let you guys know and talk a little bit about how children and adolescents experience grief or express grief differently than adults, right? So a classic example might be a parent might say, hey, you know, we lost, you know, your dad at Christmas time, and, you know, he loved holiday music, and the music that he loved, I don't want to play it anymore. And the parent might think that's really helpful for the child, but the child will think, well, I miss that music, and it's very comforting to me to hear it. So there's a difference in the way that they grieve. Adaptive ways of grieving would be to listen to that music for that child. And also noting that many youth will go through a traumatic loss or experience traumatic grief, and they will recover naturally, right? So they may have a traumatic loss that happens to them, and they'll heal naturally, kind of like some of those curves that we saw with Dr. Grant's presentation. Most of us, those symptoms or issues that we are experiencing will remit naturally with time, but for others, they'll need a little bit more support or intervention. Okay, and let's do a brief status update, just talking a little bit about where we were for children's mental health before the pandemic, and kind of do a timeline. So some of you may be familiar with some of these numbers. I'm going to just throw them at you really quickly. Some of them are probably common sense. You may already be aware of them. But prior to the pandemic, what we knew to be true was that 1 in 5 children in the United States had some sort of emotional, mental health, developmental, or behavioral disorder. Many of them were not getting the help that they needed for them. And that could be due to access, identification, a number of different issues, why we weren't getting them into care that they needed. We also know that there's been an increase in feelings of sadness or hopelessness, a strong increase in those that are hospitalized for psychiatric concerns, and that also these mental health concerns, we're seeing patterns across subpopulations. So we're seeing things like, for example, in youth that are under the age of 13, for whatever reason, Black children are more likely to die by suicide than white children. Anybody dying under the age of 13 by suicide is really concerning. And what's happening in our communities of color, we need to help people. So all of this is happening prior to the pandemic. And then during the pandemic, there were other things going on that were serving as risk factors in children's lives. So school closures were happening. And so one of the recent kind of systematic reviews, which is basically we take a look at a whole bunch of studies and do an analysis at trends, and we see that the longer that youth were out of school, the higher levels of psychological distress that they experienced. We know that schools typically in times of disaster are strongholds in a community, right? They may be a place for people to meet, families to meet and problem solve what's happening, places to get a good meal, places for teachers or other people in the child's life at school to identify if abuse is happening or anything like that. But all of that was taken away. We also know that many youth experienced high levels of loneliness. At least a third of youth reported high levels of loneliness at the beginning of the pandemic, that first half of the pandemic from March to July. And so they've also done systematic reviews on loneliness and its impact on youth and youth development. And the trends that we have seen have been that the experience of loneliness, not necessarily the intensity of that loneliness, but the duration of it, are predictive of depression later in life. And not just for a couple of months. So it's not like you experience loneliness and then a couple of months later you might experience depression. It's you experience loneliness and maybe up to 5 years later it's predicting your level of depression. This is astounding. So, you know, this is all of this to say these are the risk factors that are kind of happening, you know, in the moment. I think everybody has kind of talked a little bit about child maltreatment and some of the risks there that may have occurred during the pandemic, in that children were isolated at home, parents are stressed out. This creates an environment where abuse may be more likely to occur. They're not around other people who are mandated reporters who could maybe sound the alarm and get help. And we're also seeing psychiatric inpatient admissions relative to the pandemic. So a lot of people weren't necessarily going to healthcare settings during the pandemic out of fear because they didn't want to catch the virus. So it wasn't that admissions necessarily increased, but those that came in were more severe and also were concerned about COVID. It was related to COVID. So their mental health conditions exacerbated due to COVID. I was isolated at home. I wasn't able to see mental health providers. I was away from my friends at school. All of those things kind of led to a psychiatric emergency. And then this is from October of 2021. So this is a joint statement by the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatrists, and the Children's Hospital Association. So this is saying our kids need help. This is a national emergency. This is October 2021. This is from the Surgeon General in December of 2021. Help us, help us. And then here we have articles in CNN and the New York Times Magazine that are from this spring. And so all of this kind of is setting the stage for how are children going to react to COVID-related bereavement. And so for those of you who may talk with children who have been through grief and loss, you may know that this is one of the most distressing events that can happen in someone's life. If you're a child, if you're an adult, the loss of somebody that you care about is huge. 1 in 9 people will lose somebody as a result of COVID. That's what the latest estimates are telling us. And that many of the people that will be lost are of caregiving age. So it's grandparents, it's parents, it's aunts, people that play a substantial role in children's lives. Maybe it's a teacher or a coach. And finally, that we are one of the states that has the largest population of people that will be bereaved as a result of COVID-19. And so I want to next show a clip that really brings all of this together. If I can do it, I'll try.
The arrival of yet another Omicron variant has health officials on high alert.
As we continue our look at what's become a pandemic roller coaster, Susan Spencer considers that other COVID crisis, our mental health.
This is Coco. This is Juliet.
At home with her guinea pigs, Natasha Beltran seems like a happy 12-year-old. But since 2020, she has been struggling with grief beyond her years.
I remember my dad as a very funny guy that has a lot of friends near his neighborhood, and he likes to go movie theaters, hiking.
So you have a lot of good memories. But on April 28, 2020, her father, Julian Pena, just 50 years old, died of COVID in a Bronx, New York hospital.
The nurse called me and she said that it was really bad.
Maxine Beltran, who is studying to be a nurse, is Natasha's mother.
They were running out of ventilators and they said, we have to remove him. And they removed him. I didn't know how to tell her. I had to. I didn't want you to tell her.
How did you tell her?
I had to tell her. The daycare lady to help me tell her.
Had you been able to go to the hospital and see him? No. So you never got to say goodbye. And not being able to say goodbye haunts them both.
I thought it's my fault that my dad died.
Did?
Yeah. I was like, if you would have talked to him or been there for him, he would probably be alive.
That's a terrible thing to try to live with.
I know.
It wasn't your fault. When a 10-year-old loses her father and can't even go to the hospital to say goodbye, how do you undo that?
Well, it's not a matter of undoing it. It's how do we help children cope with those situations. We just looked at what was going on.
Psychologist Arthur C. Evans Jr., who heads up the American Psychological Association, says unresolved grief is just one piece of the pandemic's widespread mental health fallout.
We're seeing the number of children going to emergency departments and in psychiatric distress going up. We see a number of people who are dying because of overdose, over 100,000 people last year. We're seeing the number of people who are experiencing anxiety and depression at 4 times the rate.
4 times?
It's 4 times what it was before the pandemic.
In a country divided on everything, roughly 9 out of 10 Americans agree the U.S. is in the grips of a full-blown mental health crisis. And even now, with masks coming off, would you expect the mental health situation to also get a little bit better as the virus recedes?
No, it's going to be with us because what we know from research is that when people experience these kinds of traumas, people after 9/11 or Hurricane Katrina, that we expect to see people experiencing problems for at least another 7 to 10 years.
So you're basically talking about a second pandemic.
We are, because if you look at the numbers of people that are affected, it's clearly at the scale of a pandemic.
Oh, that's cute. Yeah, and one horrific number tells Natasha Beltran's story. More than 140,000 children have lost a parent or a caregiver to COVID. And getting help for these kids can be almost impossible.
To find a children's therapist that is covered under your insurance, it was mayhem.
You couldn't find anybody.
I couldn't find anybody, and I'm a single mom. I don't have her dad. I don't have any help or somebody that could chip in or contribute.
In most parts of the country, kids are seeing significant delays in getting the help that they need, not just weeks, but often months. And, you know, that would be unacceptable if our kids had cancer, for example, and we were told that they can't see a physician for 4 months.
California may be about to change that.
Every school I visit, I hear the same thing. We need more resources. We need more counselors.
California Superintendent of Public Instruction, Tony Thurman, oversees the system with more than 6.3 million students.
I'm certain that you know the challenges that our students and our families are experiencing.
He's pushing an ambitious bill before the legislature.
We've set a goal to build a pipeline of an additional 10,000 mental health clinicians over the next several years.
10,000 in the California school system.
10,000 in California.
So you quoted somewhere as saying this is the way where we can leave an important mark. What did you mean by that?
Job number one has got to be attending to our social emotional kids. So I think that's the legacy that we have to leave.
In New York, the Beltrans went months without proper help until they found a nonprofit called the Children's Village. Daphne Torres Douglas is its vice president of behavioral health services. We're always hearing all the time, oh, kids are so resilient.
Resilience doesn't take away the trauma. We still have to address the fact that they're hurting.
Which is why the Children's Village provides counseling free of charge.
We see a lot of young people suffering from losing family members, and we see young people not having the ability to cope, and we see the adults not knowing how to help them.
Oh, yeah, oh, we got one.
The social worker assigned to the Beltrans worked with them in their home. What was it about the social worker that reached you?
So many things. It's just her energy, so positive, so calming. Like, I understand what you have gone through, and I am here to help.
You feel like you could talk to her.
Yeah.
What's your assessment of how the Beltrans are doing?
They're doing really well, but this may be a long process for them, and that's okay. And as long as they have one another and they are connected to one another and supporting one another, that'll be okay.
A hopeful outlook that 2 years later, Natasha Beltran is ready to embrace. Natasha, a lot of kids have lost parents and caregivers. What would you tell them?
It's not your fault.
You won't ever stop missing him. But that's okay.
I know.
How do I stop it? Wait, just advance. Uh-oh, I may need backup here. Well, thank you for indulging me in watching that clip. It was a little bit long, but I think it gave kind of a really good picture of thank you so much, of what's happening and what's coming, right? So this is a disaster of large scale, the pandemic. That's what it has been. And so we're just now starting to see the fallout, and it's still coming. And so I think it's really important to take note of what bereavement means and what some of these other terms mean. And so let me go ahead and bring those up. So just to give you a crash course, so bereavement is that period of grief and mourning after death. So a lot of times we may interchangeably use terms like bereavement and grief, but they're not the same thing, right? So grief is that personal experience of how we express kind of sadness over that loss, how we process it, and what that looks like. And then mourning is the expression of the consequence of that loss. So that may look very different based on your cultural, your spiritual orientation. It may mean a funeral. It may mean a wake. Other types of things that you would do after somebody passes away. Would you cremate them? Do they get a burial? Things like that. That's more of a mourning process. And then relative to childhood grief, there are going to be normal grief reactions that are processes that the child goes through that's going to be very difficult in children and adults, but these are what we typically see in children. And it can look a lot like post-traumatic stress symptoms, maybe a little bit like depression, but this is what you typically will see is these normal grief reactions, disruptions in sleep, maybe there's a lot of stomach aches, maybe the skills that they had mastered earlier in life, like, toileting on their own, maybe they're bedwetting, especially for younger children, 5, 6. They may be more withdrawn. They don't feel as connected to others. They have trouble concentrating, or they may be preoccupied with the death. And we'll talk a little bit about why that might be the case. And then as part of the grieving process, what we want to facilitate for children and parents and other caregivers in the child's life can be critical for this is to really help them accept the reality of death, experience and cope with those painful reactions, adjust to the changes in their identity that they might have now that that person is no longer in their life, and also engage in more adaptive coping strategies. So developing connections with new people, being able to do that and being able to progress in their development in a normal way. And then also making meaning, which we'll get back to. So when we talk about childhood traumatic grief, we're really talking about the child or the teen is experiencing that cause of death as horrifying or terrifying. So you might think that that means only a specific type of death, but it doesn't. It can be a death of natural causes. And so if that is how the child experiences or understands the death, then it's considered traumatic grief. And there's other symptoms that may go along with that as well. And they look a lot like trauma. It's avoidance and numbing. So it's not wanting to be around any reminders of that person, or maybe just presenting as numb. So if somebody presents as numb, they may be disengaged. They may not really show any kind of feelings or emotions. It could be that they're showing that startle response that we talked about earlier, or that we heard about in an earlier presentation. Or it could be that there's other types of reminders of loss. So, you know, I can't even really look at that chair in the corner anymore because that was that person's chair. They always sat in that chair. They love that chair. And now they're not there anymore. Or, you know, I don't really like going home after school anymore because it was that older sibling that was taking care of me, but they're not taking care of me anymore. A babysitter is. And so that might be a change reminder. And so those are some of the things that may come up when children are experiencing some traumatic grief. They also could become very distressed or upset when they, you know, come up with happy memories. The happy memories of that person come up. They become very distressed and upset. And then finally, there could be some secondary adversities or adversities or losses that are connected to what happened. So changes in, you know, finances, maybe they're sharing a room with somebody now, or they've moved to a different place. All of those things can really exacerbate or make worse adaptive grieving processes and trigger more of a traumatic grief response. And so I want to talk a little bit about the circumstances of death and how those can influence grieving. And so these are some of the instances that we know that can result in more of a traumatic grief response from children and youth. So, for example, if someone's had cancer and they've been exposed to the medical procedures, or if they've had a prolonged illness and they've been exposed to those, if they somehow have images of that dying parent in their head, things that they have seen over time, and this could even be of a death of natural causes. If they've seen some of the severe distressive family members over all of this, or if they've experienced homicide or suicide, all of these things can contribute to the development of more of a traumatic grief response, especially when we're talking about homicide and suicide, because kids are pretty savvy and they know when you're holding back. So if you aren't honest with them about what happened, because maybe, you know, you're ashamed in conveying that information to the child, they're going to pick up on it. And so it's really important to be honest with them. So here are some examples of what traumatic grief looks like just in terms of a child's words or a teen's words. So every time I start missing my brother, I keep picturing his face the way we found him. Or, you know, avoidance of, I try not to think about him at all. I'm never going to be able to graduate like Dad wanted because I can't stop thinking about his suicide and I can't concentrate in class. And there's some other examples here as well. All of these would be considered more maladaptive or not adaptive grief responses. These are some of the things that we talk about when we talk about adaptive and maladaptive grief. So there's an idea that adaptive grief responses and maladaptive grief responses happen in tandem. They happen at the same time. And often they include trying to reconcile these three types of challenges. So the distress of being separated from that person and having a yearning for them. The thought that, you know, my life isn't what I thought it was going to be now that this person is gone. Their absence is so profound. I feel lost. I don't know who I am anymore. And then any kind of circumstance related death. So maybe that's a feeling of shame or guilt because I wasn't there for them, right? Just like the girl in the video mentioned, I feel guilty. It's my fault. You know, those kinds of feelings can really prolong a maladaptive grief response. But an adaptive way would be to say, you know, how do I continue to maintain a connection with this person after they're gone? Or, you know, I know that, for example, this person would have wanted me to continue with soccer practice every day, so I'm going to go. You know, that's how I'm going to deal with the distress that I'm experiencing. Okay, so let's talk a little bit about supporting, and I'll try to move through as quickly as possible. I don't believe in taking away time from lunch. I wanted to show this quote here from Dr. Ranierson, who is a grief expert, and to say, effective support with somebody you know is going through a grief reaction is the attitude of open listening and accepting whatever they're saying and not feeling pressure about giving advice or somehow taking that feeling away from them. So a key way to support somebody who is grieving is not necessarily to say, you know, I want to take away their pain. I want to, you know, provide comfort and ease or take away the pain. But it is to provide support, which means to provide some sort of foundation, right? You want to buttress them. You want to hold space. So that's key. And so I want to show a brief video from a documentary called Speaking Grief. It's in the public domain. You guys can Google it. You'll have the link to it in the PDFs, but this is what you should versus should not say to a grieving person.
Everything happens for a reason. Everything happens for a reason. Everything happens for a reason. He's in a better place. She's in a better place. He's in a better place. Move on. God only gives you what you can handle. God only gives you what you can handle. God doesn't make any mistakes. I understand. I know how you feel. I know how you feel. Get over it. Just get over it. Get over it. Just give it time. You'll be fine one day. You'll get over it. You'll get over it. You will get over it eventually. I'm sorry. I'm so sorry. The pain this loss has caused. I don't understand how you feel, but I'm really sorry that you're sad. This is hard. I know today is going to be hard. I'm thinking about you. It's okay to grieve. It's okay to be sad and to be a grieving person. Take all the time you need. I'm here for you. I'm here for you. You can talk to me when you need to. I'm here for you if you need somebody to talk to. If you want to talk about your person, I'm here. Oh, that's powerful.
It's a wonderful video, and there's lots of resources on the website, but it speaks a lot about grief. I may need help again. I'm sorry. Okay. That one? Perfect, I did it. Okay, thank you. And so just like they mentioned in the video, there are things that are good to do and things that don't help so much. There are really concrete ways that you can support a grieving person, right? So maybe it's providing them with a list of options that you can do for them. Hey, Want me to do your laundry today? You want to take a walk in the park? Oh, you don't want anything? Okay, I'll just keep asking. I'll ask another time. Things like that, continuing to check in. But always ask before you help, because you never know if that load of laundry that you did was the thing that smelled like their person and they weren't ready to wash that yet. Things like that. There's also developmental considerations relative to describing what happened to the person that died, especially to children. And so, for example, things that kids need to know as take-home messages when you're talking about what happened is that death is irreversible. They see cartoons all the time where people come back to life, things like that. This is irreversible. Somebody isn't just going to sleep for a long time. And to describe it in concrete terms can be really hard. Sometimes we speak about death in terms of euphemisms, but it's better to be concrete with kids about it. And there's places like Bo's Place is a good example that does grief support groups who can really kind of talk parents through. You can call them anytime. They can talk you through how to explain it to kids in a developmentally appropriate way. Also making sure that all functions, that they know that all functions end at the time of death. So for whatever reason, that child may think that that person is still in pain. Are they hungry? Are they thirsty? Or what's going on? And so they may feel really bad about those things, not realizing that all of that's over. There are also signs and symptoms to take a look for. A lot of these look very similar to some of the trauma responses. If you see those types of things from a kiddo, that means they need more support and potentially for further evaluation and connection to treatment and intervention. So it could be that a support group is good for them and that helps a lot. It could mean that they're still not responding well to a support group and they're showing mental health concerns, and that would be a good time to refer them to more intensive treatment, like Dr. Grant had mentioned, some of those trauma-focused treatments. Kiddos may in particular have a really hard time with transitions from a new grade or school, holidays, special events, any rites of passage where they feel like their person should be there, but their person's gone and they're not there. So those can be triggers for them. And that can be a good time for families to kind of come together and figure out, how do we navigate this? How do we keep this person in memory and also accept the loss? How do we accept that they're gone, but also keep them in our memory? There's lots of ways that school and community professionals can help. So if you know that someone has passed away or died in the child's life, just reaching out and say, hey, I'm thinking about you. I'm here if you need anything. And being able to kind of toggle back and forth, develop a plan. Okay, we want to have a structure and a routine for you, but if you get upset, what do we do next? What's the best way to support you? And there's other therapeutic work that can be done as well. So it can be making kind of a memory book, things like that. Maybe a school counselor can help with that. Because these aren't necessarily intensive interventions that require a licensed mental health professional, but they can be very supportive in terms of adaptive grieving. And I know I'm going through quickly, but that's on purpose. And so, this is in the weeds stuff, practitioner stuff on your slides. If you want to take a look, we definitely want to make sure that we're screening and assessing children who have been bereaved for trauma symptoms and for grief symptoms. So we know that when we do certain treatments for kids, there are treatments where we can focus specifically on those traumatic aspects of their bereavement. So maybe it's being exposed to that person, seeing them go through medical procedures, and that will take away the trauma symptoms, but the grief symptoms may not go away. So in order to get those grief symptoms to go away, we need to focus on more of those loss reminders that may come up. And so here's just some ways that you can do those assessments. Here's some of the gold standards for therapy. One of the great ones to add to what Dr. Grant presented on is called trauma and grief component therapy. It can be done in group and individual. It can be done as more of a universal treatment protocol. Trainings for the treatment are often free in our community because one of the developers is part of our community, Dr. Julie Kaplow. But this is a really great one because it's component based. You can do one of the components, the universal one, which includes that psychoeducation piece, which can be really helpful for youth with a whole group of them, a whole group of youth who may be experiencing some issues and don't necessarily need intensive treatment, but they need to get an idea of kind of what's happened and make sense of it. And then I'm putting some of our information here just for UT. And some of the services that we offer. So at the Trauma and Resilience Center, we offer trauma-focused therapies. TFCBT is one of our gold standards that we use. We also do the TCGTA for grief, which I just showed on the slide. We're primarily telehealth, but we do office-based counseling. So we're happy to help any of you. And I think telehealth can really help alleviate barriers to access, which is something that we're hearing a lot. And then finally, I wanted to close with a series of pictures from the documentary Speaking Grief, and I highly encourage any of you to watch it. It's in the public domain. It's only about an hour long. But as part of this documentary, they ask all of their interviewees who were survivors of bereavement, they ask all of them to talk about their person, and they use their person's name. And one of the things that came up was that people said, they don't ever ask me, people don't ask me about that person anymore. Now that that person is gone, they don't say their name because they think it's going to bother me. And they don't say their name and they don't ask me about him. And it creates a hole. I want to talk about the person. And so when they said the person's name, these are the faces that they got. No sadness, all smiles. So that concludes my talk. I have resources and references in there too. Thank you everybody for your time. I really appreciate it.
Excellent presentations. I keep thinking about how do we replicate this? How do we get more people to hear this information? I mean, sometimes we take it for granted, the relationships and the resources that we have in the community, but this is amazing. I mean, this is, state-of-the-art research and services. And so that's something I need input and help with. How do we expand this work and this information? Again, I'm just so grateful that we were able to pull this together and be here in person. We do have lunch, I know that. We do have the panel with our judges. I also wanted to mention that this afternoon we have Dr. Sotelo? Okay. Well, I guess it's Spanish. It looks like he's from Spain. I'm Portuguese, so some of you know that already. But he is MD, PhD. He's the vice chair and the chief of child and adolescent psychiatry and the director of the ADHD outpatient program at UT Health and an expert on this. And so looking at, what is ADHD? What does it look like along the life course, in the lifespan, but also preventing some of those negative consequences of ADHD. ADHD is the most common childhood mental health disorder. And often, I did my dissertation on this. It was called hyperactivity disorder back then, long time ago. That there still was the importance of an accurate diagnosis is critical. Often mislabeled, really need to look at what's going on. It can be depression, it can be a bipolar disorder, but it is so critical to have an accurate understanding and an accurate diagnosis because that often dictates the course of treatment. And you can make some mistakes if you don't have the right diagnosis. So I know it's Friday, but this is also an opportunity to hear from an expert. So I hope you will all stay around. And again, we have lunch, the panel with the judges. We will have an opportunity after the panel with the judges to have questions and answers. And then we have the ADHD presentation, and then we'll wrap up. We will be done by 3:15 because I will not talk after that. But thank you, go have lunch, and we'll see everybody back here, 20 minutes. Lunch is here, so you don't have to go anywhere, so enjoy. He's been there for like 4 or 5 years. And Dr. Copley is now funded through the county, through ARPA, as a child developmental specialist. So I'm really excited to have her on board. And she works with the infant toddler court and pretty much leads the infant toddler court. And then we have Amanda Anderson, who you started out as an intern too, didn't you? And she's our part-time social worker. And of course, then you met Donna, who also has joined the team. We're very fortunate. In Corbin County, we have 2 child observation settings. One is right next door, and the other one is in Sugarland. It's in Sienna Plantation. But basically, they allow us to do some of the parent-child work, and also for CPS and attorneys to come and observe through a one-way viewing mirror that provides that opportunity for observation, but not intrusiveness into that relationship in that time with the parent and the child. So it costs $200 to put that mirror in. I remember when I asked facilities to do that, they're like, "What do you want us to do? You want us to knock down a wall and put in this mirror?" But it's been fascinating, and every time we move offices, they move our mirror, so we're good. Dr. Copley, and thank you, judges.
Thank you. So, what Dr. Almeida was saying about the observations, we have parent-child assessments that we do through observations with young children and their parents, and then we do something called visit coaching when the families come into our office and they have a CPS case, and so then we try to help them with parenting skills, and we'll talk a little bit about TBRI. Trust-based relational intervention is something that we teach parents to do with their children in hopes that they can reunify with their children and then go on to become better parents. So I've been really fortunate to work with these 3 wonderful judges and get to know them. We testify in court almost every week in one court or the other. So we have 2 different courts that we work with. So we have some questions about the judges. Judge Millard and Judge Ramadas are in the 328th. We call it the infant toddler court. And then Judge Rawlinson is in what we call the cluster court, and she sees children ages 0 to 18. So that's why we have children in both courts. We don't just work with the infant toddler court. So I just wanted to ask each of the judges to talk about what makes their court unique, their Fort Bend County court. We've had some discussions about this, and they talk about how they've worked in different courts and that we have some special things in Fort Bend County. So if you want to just take turns.
Sure, I'll go ahead and start. What makes us unique in the 328th is this infant toddler court. As a matter of fact, on my way in the door today, 15 minutes ago, I ran into Miss Anderson, who reminded me and showed me some pictures of the importance of early childhood intervention. Because CPS picked up these 3 kids who were severely, the word escapes me, neglected. And I stumble over fancy words sometimes. Neglected. They were neglected, and so they were 3 ages. And the little one, the little baby, wasn't nearly as delayed as the middle one. The middle one wasn't nearly as delayed as the older one. And once we took these kids into care, they just catapulted up to where they needed to be. So the main thing that we try to do, it's like a tree. You guys, a lot of you folks know the Bible. I can't tell you what verse it is, but like a tree planted by a stream, and that's how our kids are supposed to be raised. And the quicker we can get them uprooted from where they are into a place that's like a tree planted by a flowing stream, the better off they are. And that has been our main emphasis. So we don't go by the statutory timelines necessarily. We have more court hearings. We have them every month, every 6 weeks, depending on the situation. And it's not as adversarial as in a lot of courts. We more try to cheerlead mom and dad to do the right thing and to get them to get where they need to be. And that's what I wanted to say. Judge Millard or Rollinson, anything?
Uh, So I have the Coastal Bend Children's Court, which is a children's protection court. It sort of echoes a lot of what Judge Armada said about the infant and toddler court. Y'all have a specialty court in the 328. And the children's protection courts, there's several across the state of Texas. And they're also a specialty court. They're a court that only hears CPS cases. So with the thought being that the people who work in that court, myself included, even all the way to the bailiff and the other staff, all have more of a trauma-informed child welfare focus that is supposed to help move families, hopefully towards family preservation, but in any case, move families and children in a better way through the child welfare system.
Well, first of all, I wanted to say to all the moms out there, happy Mother's Day weekend. God bless moms. Moms are very important, as we all know. And one of the things we do in the infant and toddler courts is we really try to provide assistance for the parents and give them a lot more resources than are available in other courts. Judge Rawlinson and I come from the same background. We spent several years together on a daily basis in CPS court in Harris County. And what a stark contrast it is from what we have here in Fort Bend County. I remember one day I looked at the a cause number on a case, and it dawned on me that the numbers were the year first, and then the last 5 digits were the number of cases filed. And I looked at one and I said, this is the 9,826 case filed this year. And each case may have one child, they may have 12 children. Like, wow, that's a lot of kids. And so they are just so overwhelmed. I don't think they have the resources that we have here. And it's been just such a wonderful thing for us to be able to provide more resources. We have an awesome child advocates here that we have CASA appointed on every single case. And as a judge, these two judges know where I'm coming from. We don't get to go out and talk to these people. We don't get to visit the homes and see what's going on. We rely heavily on child advocates and also on behavioral health services to help us out. And, you know, since I've been here doing this, I've seen that when we all pull together as a team and support these children and support the parents, we can have some real success stories for these families. And it's just really a great thing to be a part of. And if you practice in our courts, you probably know about that. If you don't, or if you don't encounter our courts, drive on down into Houston and sit through a CPS docket, and then come on into my court one Thursday, and I think you'll see a pretty dramatic difference in what we're able to provide the citizens of Fort Bend County.
Great. I want to add, can I add one thing that Judge Millard said? He said something about we support the parents, and I think that is vitally, vitally important. Dr. Profile, I mean, she'll get down on and teach these parents how to get down on the floor with their kids and do those and do the things that they want to do. But taking it from a different perspective, some time ago, I was talking to one of the juvenile probation officers. This goes to the importance of parenting and to early childhood intervention. And I asked this probation officer, he's still over there. I think he's fixing to retire. And, but he was probably there at that time, 20 years. And I asked him, I said, hey, what is the common denominator that you see with all these kids over here in juvenile? And he said, well, he goes, I don't really know what you mean by common denominator. But I said, okay, well, what do they all have in common? And he said, I'll tell you this. He says, I'll tell you this. I can count on one hand the number of fathers I've seen come through those front doors. And I said, you're lying to me. He said, I lied to you not. I can count on one hand the number of fathers I've seen come through those doors. So I'm going to be here to tell you, it is about parenting, and it's about teaching these parents how to be decent parents. We don't need them to be, you know, as good of parents as y'all are, just not as bad as they had been. And I say that in all sincerity. If we on a 10 scale, if we can raise them up from a 1 or a 2 to just a 3 or a 4, these kids got a shot, right? These kids got a shot. And I just wanted to say that, Judge Millard sparked me to say that.
You sparked it, right?
Back to you.
Back to me.
So speaking of common denominators, there's other things too, right? Besides fathers, there's a lot of things that we find that a lot of these parents have in common that we've been talking about this morning. A lot of parents have mental illness, substance abuse, domestic violence, single parents, right? So there's a lot of those things. So I just was wondering if you can each just maybe talk a little bit about, what might make a difference for these families, whether it's just their attachment to their child that makes the biggest difference, or is it, getting treated for mental illness or substance abuse? What do you think of that?
So we'll just go down my line here.
Sure.
Okay. So I think one of the things, like earlier when I was watching the presentation on the Rupani Foundation, for example, I think one of the things is building that community around a parent. So all of the treatments and all of those things, those are important, and I'm not going to say that they're not, but we're only with them statutorily for a year, maybe 18 months. And I think we have to build them in that 18-month period of time for them and their children to continue to be successful, as we have to build them their village and their community. And what does that look like? And it might not always be that the parent is necessarily the person who is going to be responsible for the 24/7 care for this child. Maybe their mental health will preclude them from being able to be that sole caregiver for the child. But then again, it's incorporating all of those other pieces in the community. The teachers, the daycare staff. We use a lot of these, the next door neighbor, we use a lot of these people to be additional eyes and eyes for us and assistants, because they're going to keep on with the family in the future. So that's what I would say as being one of the most critical pieces of ongoing success that we see is families who have been able to build a good support system.
I'm loud enough, people can hear me. The things that we see, sadly, we get these affidavits when children are removed and it becomes a court case. There is a removal affidavit that we review, and then we make some preliminary determinations in the case about whether to grant emergency custody to CPS, and then we have a more detailed hearing where we decide whether there's a reason or good enough reason to keep the children in CPS care. So we get these affidavits, and I can tell you, it's almost like it's the same affidavit every single time. You just change the names around, and the things we see are drugs. That's the dominant thing. So substance abuse, really, it's drugs and alcohol. We see a lot of that. We see cases of mental illness, see a lot of that. We see violence, criminal activity. Sometimes we see all of the above. And so those are the root problems that cause children to come into care. And so we really focus a lot on those things on the parent side. And because we have a lot more hands-on in our court, we meet every month with the families instead of every 90 days, which is statutorily generally how we meet. And it makes a big difference being able to have them in. We hold them accountable. We get them up there, we give them pep talks, and then when they need help, we give them resources to help them. And it makes a huge difference. But the thing that really, I think, makes the biggest difference, because the kids, we've got these children, they're traumatized, or they wouldn't have come into care. So they've been abused and neglected, so they're traumatized. And then they're taken away from mom and dad. And that's a very traumatizing thing. The kids, they love mom and dad, even if mom and dad are bad and abusing and neglecting them, they still love mom and dad. So it's very traumatic for the kids. So it's very important for us to get them into a good, safe placement that potentially can be a long-term placement. We always look for relatives wherever possible. And I know one of the things I do, and I'm sure these judges do as well, is very early on, I'm asking questions about the future. What are we going to do to be able to get family members qualified to receive resources down the road? Because these things require that we have these things in place for months before we sign a final order, or they may not qualify for financial assistance. And we know that it costs money to raise children. It does. That's a fact. And so, to help the children out, we want to make sure that there are ample resources for these kids, no matter where they go, whether that's back home with mom and dad, which is what we all hope for, or with relatives, or even with foster parents. One last thing I wanted to say is, when I first took the bench, we have some really good ad items for the kids, but I don't think they were prepared for my standard of what their job was. And, you know, we would have things like they're supposed to file a statement of compliance that tells us that they've actually been out and visited these kids. And I remember the first month, it was like a statement of what? You're kidding me, right? You guys don't know that you have to do this? And they've changed. They've really ramped it up. And now I see those statements of compliance come in. And why is that important? It's important because if you're appointed to represent a child, if you're not out there visiting wherever your child is, whether it's in a foster home or with family, you're not getting good information about your client. And sometimes kids, when they're in out of their home and in a foster home or in a relative's home, they will be doing things that seem to be disruptive and, you know, make people angry sometimes at them because they're acting up and they're doing things that you learn when you come to seminars like this is the byproduct of a child that's traumatized and needs a lot of care. So we've been working with our attorneys to recognize the signs of the trauma that these kids go through and how to address it. And you know, we're trying to give them the tools to be able to focus on that and recognize the signs of trauma so they can get these kids help.
Sue, I don't even remember the question, to be honest. But
No, you answered first.
well, I was just gonna say, like, from a judicial perspective, just listening to John again, you spur a lot of people thoughts, I guess. But one of the things that I imagine that y'all do in your court and that I do in my court, and I'm sure it drives everybody crazy, is I've been in front of judges who don't ask any questions. It's like 5 minutes in, out. And I think that probably sometimes I'm guilty of like belaboring the point and asking, they're staring at me over there. They're like,
She was looking at me going, that isn't his problem.
And like excessively asking questions. And I just think that that's really, even though it might be sometimes aggravating, I think it's fundamentally important for figuring out what resources we can find, like John was saying, for the kids and for the family, because that's ultimately, and I chip away at them too. Like, again, I'm sure it's very annoying. Like, where can we find this tomorrow kind of thing? Because, yeah, I just think that that is crucial.
I don't know what the question was either, but I have to say something that Judge Rawlinson talked about. She talked about how she kind of wears these lawyers out a little bit because she asks questions and she demands things. And I want to tell you, I found out something about Judge Rawlinson that I didn't know. Not that. So she expects the lawyers to go the extra mile. Why? Because doggone it, she goes the extra mile. She goes, and these older kids, she helps them fill out job applications and applications for school and FAFSA applications. Well, she does that. And she doesn't get paid a crying dime for doing that. So she goes above and beyond. And Judge Millard talked about how this is traumatic for these kids. And that was the toughest thing. I used to be in Chris's shoes. I was a prosecutor for a while. And the toughest thing about removing these kids for CPS for me, you show me a kid who's in an abusive or neglectful situation, and I'll show you a kid who loves his mom and dad. And, you know, we take them away because we have to. I mean, they need to be taken away, but it's traumatic. And so the more that we can work together, because I'll tell you what, we all have problems in our lives. And so like tonight, let's say Millard, let's say his car won't start in the parking lot. It's not the end of the world for him. He still can make it home. He still can make it to work tomorrow. He could, you know, right? Because he's got this support system. These parents, if their car doesn't start, they lose their job, right? If their car doesn't start, they miss counseling. And now they're being yelled at by a judge. And on it goes. So they have these multitude of problems that For us, we can get over these little things. They can't, which again goes to why we need to get in and get in early and keep after it.
That's right. Awesome answers. I just know that Judge Armadas has to get going, so I think maybe if you other two judges could stay around maybe for, I think, question and answers after this, right? So,
And thanks a lot, because I got a domestic violence thing in my court. I kind of got to be there.
Thank you. So they were really easy. That was a really easy panel because they didn't even know the questions and they just talked. So they were very easy. So we're about wrapping up. I think the last thing was just about the importance of, seeing families when the children are young, but we've kind of addressed that a little bit. So maybe if we do a little question and answer, we can talk about that a little bit more now. But I don't know if you want to bring up other presenters. Well, just the one about seeing families when the children are young. Do you want to do that one now? Okay. So I would just ask the difference between seeing families when the children are young versus, and that's all that you really do, versus seeing the teenagers. And I know that you've talked about that too with how it's different with the families with adolescents.
Sure. So, right. So as she stated before, I see children 0 to 18, and I don't know what the cutoff is for infant public court.
3.
But that being said,
Well,
John
we
also
see older kids, because if there are older
Attached.
kids that are the sibling group,
There you
we
go.
take those into.
Right. And in addition to that, John was an ad litem, like you said, for a decade or more.
Yeah.
Who's and also seen older children. But and it's kind of just what Judge Armadas said when he looked at the picture of the children who had suffered the neglect. The baby looked like a baby. The 5-year-old, maybe not so much. So it's clear on the teenage side when there's not been early intervention. A lot of times they're dual status youth. By dual status youth, I mean they have their CPS case and they have their juvenile case. Most of the time, there's no parental involvement or very slim parental involvement. There's usually complex mental health issues. And a lot of the PTSD markers that were in an earlier presentation, especially with the risky behavior. The list goes on, and a lot more resistance to treatment, I would say, on the older end whenever we don't catch them in the under 5 age group. And it's not to say that there aren't hard cases in the under 5 age group, because we've definitely seen hard cases in the under 5s. But when you have a 14-year-old, a 15-year-old, a 16-year-old, a 17-year-old who don't trust adults at all, and you're not only are they just in their normal teenage place as a teenager, but on top of that, they don't trust adults and they have all of these other compounding situations. It's pretty evident why, because a child like a 5-year-old, a 6-year-old, a 7-year-old, that child still, generally speaking, will fit into a family structure and understand the parent-child relationship. When you get to 15, 16, 17, it becomes a lot harder, because this is a person who's very parentified themselves. And again, like I said, lacks trust, lacks all of those things. And you're having to try to help them realize that they're not a grown-up and that it's okay to still be a child, that somebody should be taking care of you. Somebody should be meeting these needs for you, and it's not supposed to be you. So I would say that is the primary difference.
Yeah, Judge Rawlinson sees all ranges of age of kids, and I feel like we're pretty lucky because we get them when they're really young, and we have an opportunity to put them in a safe and stable home, and they really thrive once they get into a safe and stable home. They can have a lot of issues as well, but the damage hasn't been done as much. And, we get these kids that are older and you said parentified, and I think what you're referring to is that they've been the parents. They've been, you've got a 13-year-old and has 5 siblings, and basically they're the parents. And it's really heartbreaking to see that. And then you get the kids that are older and they've had a rough life. And some of these kids, it's so sad. You visit with them, they don't know the most basic things. I remember I had a young man, he didn't know how to cut his toenails. He didn't, and they were pretty bad. And he didn't know how to do these things. So I got him a kit where he could do all of these things and have a little grooming. And we talked about deodorant and stuff like that. And then, I know as an ad litem, what I would always do with the older kids is really talk up and preach about college and what a difference that can make in your life. And I would tell them that, you've been in CPS care, so you get this once in a lifetime opportunity to have your college paid for. And so I talk a lot about that. And I know Jamie does as well. She's getting them prepared to become adults, because eventually they're going to be adults and they're going to be out of our care and custody. And we won't be able to do things for them. We hope that they'll continue to stay in touch with the people that care about them. But, they need to know things about how to apply for a driver's license, how to fill out a college application. And when these kids they're literally, a lot of them are going to be on their own when they get older. They'll age out. We hope they stay in care, but very often they age out. I'd like to see the statistics on how many actually take advantage of college.
I heard it was 2%.
It's quite low.
It's if you're a parent and you're paying for your kid's college, what a deal it is to get a free ride to college and what an opportunity that is. And I just look at it and I think, surely they're going to jump on that. And sadly, very few of them do. But I always made it a point to really talk it up and talk about how fun college is and how many friends you're going to meet and relationships you'll develop. And so we do what we can. But I think at the end of the day, if we can get in early, we can make a very profound difference in their lives. We hope we can with the older kids, and we do the best we can.
Yeah, I think that that it's interesting about having them being parentified, right? Like they're acting like the parents, but then they don't know how to be adults, right? So that kind of goes together, right? They've been acting like an adult in a way, but they don't know anything about being an adult, and as a parent of 2 young adults, just thinking about how hard it is to get them to understand how to apply to college now. It's not like it was when I went to college and you filled out a piece of paper. Now there's just so much to do to apply to college. How are they going to know how to do that, right? So it's hard. So, okay, so that's it. And then I guess if we want to have the question and answer with everybody, bring other people back up, or no, whatever you want.
Trying to figure out what works the best.
We had a missing speaker.
So we have a little bit of time. I was looking at the schedule and we have a break, but we also have an opportunity. So here's my suggestion. The judges are here. We have an opportunity to ask questions of the judges. We also can take a break and then come back. Dr. Propoli and I are going to do like a 5-minute overview of TBRI, but that creates some time for the discussion. And then we'll talk. We can move the schedule up, except Dr. Satula, right, has clinic until, yeah. So that's why we can't, yeah. Anyway, it's not like I just meet you guys here until 3:15, but we're trying to manage all that. But so I think, Drew, are there any questions specifically for Shannon? You have a question?
Yeah, but it's from an attendee. All right.
Oh. Shannon has a question from the chat. So yeah, and then we'll take a little break and then we'll come back because we also want to show the MHA.
Okay.
So my understanding, CPS only.
No, my court is a general family court. It's a district court. So I hear everything. This morning I heard adoptions, which is the funnest thing we do. We do divorces, custody cases, name changes, domestic violence cases, and then we also are responsible for CPS cases. So the way our court works is there are 3 district courts in Fort Bend County, 3 family district courts. Each has an associate judge. So there are actually 6 courts. most of the courts, well, our court has the infant and toddler program. So we retain the cases where there are children 3 and under that are in CPS care. We keep those cases. The other courts, and we do for the older kids as well, they all get referred to Judge Rawlinson in the cluster court,
Which is only CPS cases.
which is only CPS cases. And Judge Rawlinson, I'm not sure why they call it the cluster court.
Well, that's why we changed it to Coastal Bend
Yeah.
Children's Court so that you didn't associate it with another word that starts with
Yeah.
cluster.
Because it
Just to be
sometimes
perfectly
can be,
honest.
but no, and you have, how many counties do you have?
3. So I am the children's court judge in Galveston, Fort Bend, and Wharton.
She does a lot of driving.
I used to, not so much anymore, but yes, I used to drive.
It's almost great. You just zoom in.
So if y'all get cases that are in CPS, there's something else that y'all differently because either y'all can mandate for them to do or have done for them.
Sure. Let me see if I understand your question. Like, do we treat children with mental health issues differently than, let's say, children who are not presenting with mental health issues in the cases like strictly about substance abuse?
Yes.
Okay. We don't have like a special docket for children with mental health issues or anything like that. But what I would say that we do, and I might, and y'all do as well, is each case is really done in, I hate to use the word like round table. That's not really, we don't, especially now on Zoom, we're not sitting around the table, but I would say that the children's court and the infant and toddler court operate in a less adversarial approach to court hearings. So it does go by question and answer, but we do a lot of like group talking, and we will sit down, and if that is a particular issue that's come up in a hearing about a child, then yeah, we're going to focus, and it's kind of everybody adding to the conversation about what resources are going to be best for this child, and taking into account, because something else that I thought of earlier when I was watching the presentation, I'm sorry, it was the one before the grief presentation. When I was looking at that, I'm thinking to myself, like, I am not a PhD, and I am not a licensed counselor. I really probably, even though I've been doing this for a long time now, have a surface level knowledge of mental health needs. So how do I not do more harm than, which is really deferring to all of the people with the education. So a lot of times what we'll do is I'll say, I honestly don't know. Let's recess our hearing and come back with the child psychiatrist or the child's therapist or this or that, and see if we can delve down into what the issues are and how do we best help. And it's done on a case by case. So that's the reason partly too that the cases take so long to be heard sometimes, is because we're really doing a deep dive into the issues and seeing if we can identify what resources that maybe are atypical CPS resources, but are going to help a child or the family. Does that answer your question? Okay.
I had a question. Give your chat question.
So we have an online attendee. So I'll specifically address Judge Rawlinson, but for any of our innovators, partners, supporters, and collaborators in the audience, who all happen to know resources out in Galveston, we have an attendee who thought, wow, this is a great presentation. I'm awesome they're doing this before bid. Awesome they're doing this for Harris County. What about Galveston County? So I figured you probably have a unique perspective when you're there in terms of resources that sort of mirror what has been spoken about throughout this presentation, which has been those collaborations, the evidence-based practices, and a lot of the organizations using those evidence-based practices to focus on trauma as well as child attachment. So do you happen to know?
Okay. So I don't know who is asking the question, but I'm going to use it as an opportunity to plug my pilot program, which is, so in Galveston, Galveston has a pilot program that's started 2 months ago. It's one of like 3 or 4 in the state, I think. We have an early intervention court liaison. And what she does is it resource mines essentially. And she sends out a weekly newsletter that lists all of the new resources that she's found for that week. There's also a collaborative in Galveston called Aces to Assets. I would encourage that person to join it. They have a monthly collaborative group where they bring together different community resources, but they also send out just a list of upcoming like events for youth or events for parents or families. And then we're also the Children's Court, my court in Galveston, with our early intervention court liaison program. This is the first month we're doing it, on the last Thursday of the month for 1 hour, starting a brown bag series where different resources providers in the community will be presenting whatever their I think the first one this month is Family Service Center. I can't remember who it is next month, but I actually just sent the email yesterday and it has the presenters for the next 4 months coming up. So there are a lot of resources in Galveston, a lot that we didn't know about until we got this person, Barbara, who does all of this information sharing, but yes.
The Family Service Center, Galveston County, is involved with our. So that's someone who.
We had a couple over here. The young lady in the back, I think, raised her hand first.
Do the kids go on college visits?
Yes.
Yes. Child Advocates actually has a Wings program. I believe it's called the Wings program. That's the older kids. Nest is the younger kids, right? The Wings program, they go every summer. And they think they've had to modify it the last 2 summers because of COVID. But they do a college tour, and I don't know where all they go. But they do.
State schools, I'm sure, because that's
what the
tuition will be
tuition,
paid for.
right?
So.
And they also, I mean, the waiver has been expanded. You guys didn't ask us about the waiver, but it has been expanded over time. So you can like do trade schools. It doesn't have to be college. And I think I could be misstating this, so maybe I shouldn't, but I think that there is a push to take away the age requirement, right? And that might be starting, or maybe it starts next fall or something like that, where it used to be you had to engage in your first college course by age 25 or 26 to trigger it, and then it lasts a lifetime. But I think they're taking away that age because of the 2% quota that Dr. Broccoli mentioned.
This young lady?
Yes, I had a question. Thank you so much for the service you provide for families and children on a daily basis. In your, I guess over a year, how often, so it's a 2-part question. The first part is, how often do you kind of audit your data by outcomes and stratify that by race, ethnicity, language, and gender? And then the second part to that question is, if you do so, what do you do with those outcomes?
Okay.
I can answer that really easily. I don't know. I just don't. I really don't. It sounds like a pretty darn good idea to do, but I'm not aware of what we do. You know, we look at the cases that are filed and how many are on file, and we're doing that largely for backlogs and that kind of thing. But I don't know.
Well, CPS does
do that.
CPS
does.
So
You handle your data.
right.
Yeah.
Well, and our systems are a little bit different. Like, so that's something else to understand, is that I'm an appointed judge, and Judge Millard is also, but Judge Armatis, the district court judge, is an elected judge. And the state, my court is formed out of like a specific piece of legislation. So, which is different than the district court. And so for our purposes, there are reporting requirements and stuff that go along with being a statutorily created court, right? So the legislature wants to know, and make sure that the money is being spent the way that they intended it to be spent. Every October, I want to say, is and I'm pretty sure and right on this, and you just simply don't remember because we haven't gone in person in 2 years now. The judicial conference, we meet with our Region 6 director, we're 6B, our Region 6B director, who is the regional director for DFPS. And we sit through an entire afternoon of presentations of like counties across the state where DFPS has done like intake, outtake. And although I don't think they break it down by gender. I don't remember gender being a category, but I could be wrong. Race is certainly a category though. Reason for removal is a category. And my whole point in like telling you that we're a different kind of court is because we have a computer system where we don't have to, but we can input all of that data and create the reports ourselves. And I don't think that you have that since your county. Anyway, so yes, that information is there. And there are also data specialists at the department that we can send like requests to, like, I want to meet with you and I want you to tell me just this information about my court. And I think you guys could probably do the same thing, but I'm not 100%. So, and then what do we do with that information? So last year, for example, or 2 years ago, maybe, we got information about the time it takes to close cases. That was like a big push by my regional judge, was the time that cases were staying open. And so we take good information and modify and take it to our CPS people here at the court level and the county attorneys and stuff and say, you guys are taking too long to close cases. We got to do something about this. What are we going to do? And it would work the same way if it was a disproportionality issue or something like that. Although in Fort Bend County, I don't want to misstate, but I don't think that disproportionality is I think that probably disproportionality by age more than anything, not race.
Yeah. This young lady.
I'm curious. I don't know if you guys have the stats for it, but do you know if the parents that come into the court, are they past clients when they were younger? Like, do you think that it's a generational thing?
Oh, yes.
Oh, yeah.
Yes, 100%.
See a lot of that.
Every day.
Well, and sometimes I've represented kids who are in CPS care as a child and have a child that's in CPS care. So
We see that a lot.
Yeah.
We also see families that have CPS cases and then criminal cases with different courts, different attorneys, different timelines, and that can be very challenging.
I mean, right. Even back like when John and I were working in Harris County, and like one of the things that triggered me earlier whenever Judge Armadas was talking was like, do you remember our docket was right behind the juvenile docket?
Yeah.
And so we would get to court for our CPS docket, and the judge that we were in front of would be finishing the juvenile delinquency docket. And again, it's like you said, I mean, sometimes there was a mom there, sometimes, but it wasn't.
they're supposed to be there.
It wasn't.
They serve them and they're supposed to be there, but
We didn't see a lot of parents in the juvenile docket. But anyway, but those parents, a lot of times when I was a county attorney, we would learn that parents were in jail because somebody like John would go over to the jail to visit his client and be like, guess who I saw in the tank while I was over there? Or whatever. So that's how so they do have a lot of crossover, a lot of criminal history and a lot of generational.
Very, very definitely there's a generational component. And we all hear the phrase break the cycle and so forth, and it's so applicable. It's just, really kind of sad to see these kids repeating their parents' history and then 16 and they have a child that's in CPS care.
I just wanted to add, Judge, to that. So if you think about why would the county care about this? Like, why would county commissioners possibly fund this? Because that's exactly it. The county does have a responsibility and a concern around public safety, reducing the number of people with mental illness in our jail, improving court processes, So that's why it makes sense, because of just what they said. You see this intergenerational pattern of CPS involvement, criminal justice involvement. So really, if you start early, that's wonderful. We're gonna break that cycle.
And I really like, I'm glad that they love doing the infant and toddler stuff because I really love the teenagers. And because of that reason, like, so I'm trying to stop them from being the next generation. So perhaps if we, like, tell me what your barriers are to going to a technical school or going to college or like whatever, and let me see how I can break down those barriers for you. Because a lot of times it's just, it's different than, and I don't want to stereotype this group of people here, but it's like different than how I was raised, right? Like I was raised with an expectation of going to college. It wasn't like, are you going? It was, where are you going? And so a lot of them don't even think of that as a potential place to end up. They live what they see. And so it's helping to remove those barriers. So when you, like Dr. Profili said, like the FAFSA is overwhelming. Okay, cool. We have some really dedicated PAL workers here in Fort Bend County. And so I mean, I don't want to take away from the compliment that Judge Armadas gave me, but I don't personally sit with them and fill out the FAFSA. But I do bring people to the table who's like, they need to fill out their FAFSA. It's very overwhelming.
You're asking the questions
Right.
when they're in front of you.
And so it's like, how can we remove those barriers so that we can get you educated, or we can get you a job, or we can get you wherever, so that you don't become generational?
We have one more question, and then we are going to take a break.
Going along with that, I'm also curious, starting early, focusing on supports and connecting families to a support system. Have you got any data or any kind of outcomes with families where they come back into the system, not as parents, but even for their own children? They come back. And I don't know.
Like black and white data, I don't know. I honestly don't know. That would be like a behavioral health question. I don't know. But what I can say is, in my experience thus far in Fort Bend County, at least, having behavioral health, having Dr. Profili in the systems, I can think of cases where people have had other children while the CPS case is still open. So that child might come into care. But in terms of they've gone away, we've closed their case and they've come back, I actually can't think of anybody. But again, I attribute that not so much to myself, more to the like behavioral health and people who intervene in the case.
One of the outcomes we track for everything that we do, CIT involvement, conversion programs, is criminal justice involvement, subsequent criminal justice involvement. Now clearly looking at that longitudinal, is really important. We don't have the data, but that would be great to be able to do that. We have done some, not with the infant toddler, but, with CIT in terms of demonstrating the value of our crisis intervention team. We have another program that focuses on adults with mental illness. So we've actually looked at, we all talk about these wraparound supports and all that costs money. And it's like, well, yeah, we spent $30 on Uber, but that got them to court and to see their kid, and if we hadn't provided that, you'd have had to reset your attorney. That attorney would have cost you $150 just for resetting that. And, so it's been really exciting to, we don't do it on a large scale, but we do focus on that, demonstrating the value of what we do in terms of those cost savings and that criminal justice diversion.
So, and I think recidivism is probably tracked by the department on a per county basis. I just don't know. I don't know that it breaks down. But I mean, to that end too, I just use it as a platform to push for early intervention in a lot of different situations, not just CPS situations, in which you would probably save a lot of money on the back end.
Absolutely.
So Thank you, judges, really appreciate it. We are going to take a break because I know I think we have 20 minutes for lunch. That was the fastest one. And I do apologize. We're like, okay, everybody just grab their lunch and we need to start. So let's take a break. Let's take, 10 minutes, 15 minutes. We are going to come back and we'll have a video with some amazing artwork. As part of our children's artwork. Yes. And then do it at the, and then, quick PBRI. When I live for a property, so.
And then I do have a little thing up here, because you and Prophylator.
A little thing.
The next little slide, you and Prophylator are gonna do a little bit about.
We are.
Okay, cool.
Yeah.
All right.
But MHA is gonna show their,
Are they, she gonna be first before y'all?
yes, yeah. All right. Oh, okay, let me just do the TBRI thing.
Okay.
Pass. I mean, it will just, I don't know where.
It's 9 minutes, 9 minutes, we're good. Okay.
Well, I don't know where Dr. Profile is. Okay. Dr. Profile, oh, Dr. Profile, do you want to come up? Are you leaving, Dr. Profile? Okay, thank you, Judge. Bye, thank you. Okay, so we're gonna go ahead and get started. And, really appreciate everybody staying with us for the afternoon. I know some people had to leave, and also I wanted to thank the people that have joined us online. So, thank you for being virtually with us. And we will make all this information available to everybody. Shanna will figure it out. It'll be on our website, and if we have to email it to everyone, we will. Shanna has several times put the QR codes up there. So we really appreciate everybody's feedback. It's also on your evaluations in the back. So we really would like feedback. Also, I just had the opportunity to talk to the executive director of MHA, who asked me if we do this every year, and I would love to do this every year. And they said they would love to partner with us. So that's a great opportunity, and thank you. And so we will be doing this every year. Okay, I think we were going to talk a little bit about TBRI, and then MHA is going to show the artwork video. So there's a flyer out there. We've been talking a little bit about trauma-informed care and services, and we had a great presentation about, really the difference between trauma-informed care and trauma-specific interventions. I think that's really important to distinguish and to understand. Actually, Dr. Profile and I and Michelle are trained clinical practitioners in TBRI. And so it's been fascinating to learn about this and to think about how we use this with our children. So what was it, like 6 months ago, 7 months ago, we decided, right? We decided, well, we need to form a Fort Bend County TBRI collaborative, and it was amazing. We just did it, so it's Fort Bend County, Behavioral Health Services, Juvenile Probation, Child Advocates, and Lamar Consolidated School District, Dr. Jennifer Roberts, and Parks Youth Ranch. And it's been amazing. We've just pulled it together. I don't know how many people have been trained, but you've offered how many trainings so far? Maybe 10?
Twice a month for about 6 months, so probably about,
And then the first month you did 4.
I think we did 4, so maybe about 12
Right.
already, so.
So there's this opportunity. It's free. You have to go to the overview one first, and then every month they have, it alternates.
Every
So
2 weeks. So since everybody has to do the intro first, that's a 6-hour. They start at 10 a.m. to 4 p.m. usually at the CASA office, Child Advocates of Fort Bend. And so the intro is the first or second Tuesday of the month for 6 hours. First, and then the 2 weeks later is one of the other 3 principles.
Right, which
So you do
is
the intro and then
right.
one of the 3.
Right, and the 3 principles are connecting, empowering, and correcting. So we couldn't do TBRI training every week, but this really kind of allows the opportunity for folks to, get trained, get the 24-hour caregiver training. And so you get a certificate, and again, it's free, and we provide lunch and everything. And there's a flyer.
There's a
right?
QR code on here. If anybody wants to, you can just take a picture of it with your phone or whatever you do. Is that a picture? You know how you click on it?
Yeah.
And then you get the QR code and then it'll have the list of trainings through November of this year. I don't think they're ending in December because of the holidays, and then we'll probably start up again.
Right.
I don't know if we have copies.
Oh, they should be in the back table. Are they in the back table? Are they over there? Yeah, I think I just put them over there. And there's also another flyer over there with some of the statistics. Yeah. Sorry, thank you. Thank you, Deputy Deaver. Deputy Deaver works very closely with us. He's one of the 2 CIT youth certified trainers in the state of Texas. And
He went through the caregiver training.
yeah, and he's also done the caregiver training, right, Deputy Deaver? Deputy Deaver, you are a certified TBRI caregiver training, right? Okay. Woo, okay. Okay, so that was the briefest presentation we've ever done.
You have a question or you want to- do you have a question or you want?
Yeah.
Okay,
Right.
good.
Now, this is not the clinical training, but it's the
It's not the
care.
practitioner training,
Right.
it's the caregiver.
Yeah, that. Okay, so I'd like to turn it over to MHA and really have this opportunity. I guess this is children's artwork. And it will be nice to enjoy this. And Jamie, Dr. Freeney, can you tell a little bit about what your role is? When did you create this? You just did this, Shanna? Very impressed. Yeah. Shanna's just, yeah. Thank you, Shannon.
Yes, thank you.
Okay, great.
All right, good afternoon. I'm Dr. Jamie Freeney. I am the director for the Center for School Behavioral Health at Mental Health America of Greater Houston. And I want to thank Dr. Almeida for allowing us to jump in at this last minute since we had some extra time. And I do want to acknowledge Renee Tomzak and Tina McDowell, who are our CEO and our Chief Program Officer at Mental Health America of Greater Houston. I am the director, as I said, at the center, and the center sits at the intersection between education and mental health. So while majority of our services are through professional development with school districts, with administrators, and with those serving youth, we also convene stakeholders that impact children's mental health, whether that be from an FQHC, a hospital system, a child advocacy organization, an after school or summer program. We have over 30-something districts that attend our monthly meetings, as well as we are partnering with wonderful providers such as UT's Grief and Trauma, the Menninger Clinic, or not the Menninger Clinic, but NMHPI, and other organizations. So it certainly is something that we know is a collaborative effort and takes a group effort. And so we are hoping to continue our partnerships and extend those partnerships well into Fort Bend County. We have worked for many years with Stephen Shills. He used to be at Fort Bend ISD, and he's no longer there, but they are really progressive and have a really wonderful mental health program set up to support their students. So we hope to continue to work with many of the schools and with some of your organizations if you find some of the work that we do can help support your services and your clients, because we do provide training in trauma, children's mental health, self-care, suicide, youth suicide awareness to individuals that are, again, are serving youth. Our professional development curriculum is evidence based, and we do have empirical data that supports changes in knowledge, as well as changes in perspective of educators working with students who have experienced trauma, as well as students who have experienced grief, as well as those students who may be having difficult times and maybe having some suicidal ideation or self-harm. Our training program helps adults feel more comfortable asking questions and addressing those needs as they arise in schools. And so one of the opportunities that we get to share with you today is our youth showcase, a youth art showcase. It's an annual event. And this is one of the few opportunities, but one of the most important opportunities, especially to me, because we get to hear directly from and engage directly with the students around mental health. And so in a moment here, I'm going to show you the premiere video that premiered on our Facebook page at 12 o'clock. And it's very short, it's just 9 minutes. But hopefully you will take away the fact that some of our children do have the words to articulate how they're feeling. And if they don't have the words, they certainly have the talent to showcase that through art and through drawings. And so before I take my seat, I do want to leave you all with this thought. We've mentioned today several times that trauma and things can pass through generationally. We see generations of families going through the juvenile justice system or the justice system. We see families living in the same communities, experiencing the same hardships generation after generation after generation. We have children that we're trying to save or trying to help who are actually matriculating or going through a system that they did not create and that was not created for them. So while we are trying to be saviors and to go out and help them, I would encourage us to take a step back and see where in the system we are going wrong, because it shouldn't be that generations and generations and generations and generations of families are experiencing the same thing. That tells me it's not their fault. It lies within the system. So with that, I will thank you. I'm going to share the art showcase, and I hope that you enjoy it. And thank you again so much for your attention. Just hit it.
I don't know what else. Just give me, yeah.
Oh, you want to
Yeah,
take it? Thank you.
I got you. Okay, bears with us. Hold on. Oh, that's you doing that. Okay, I have to go in and come back out, so just bear with me here.
Can you see?
Yes, I can see. Just.
Hi, everyone. Thank you so much for joining us for our 6th annual Youth Mental Health Art Showcase. My name is Cecilia, and I am the program specialist with the Center for School Behavioral Health at Mental Health America of Greater Houston. Mental Health America of Greater Houston is Houston's longest-serving mental health education and advocacy organization. We've been around for almost 70 years, which is pretty cool. This is my 3rd year being involved in the showcase. I'm super excited to be here today and to get to talk about this incredible showcase with my buddy Kim, who's going to introduce herself in a minute. But we've produced this showcase now for the last 5 years. And we really created it in order to help reduce stigma, and we want to help open the lines of communication between students and their teachers, their parents, as well as that peer-to-peer connection. We really see art as a healthy way to express yourself when you're dealing with challenging thoughts. Art has this great ability to build community. It's this safe environment, really, for you to get to think through how you're feeling and what you might be going through and how you see the world. And we just really love that connection between art and mental health. So I'm going to turn it over to Kim, my wonderful co-host for today, who's going to introduce herself and talk about where we're going today.
Thank you, Cecilia. Hi, my name is Kim Thurmond, and I am a supervisor here at Texas Art Supply, where we are filming, and I'm also the events coordinator. And we are so excited and happy to be involved with the showcase this year and other great art initiatives here in Greater Houston.
And y'all have been around for quite a while, right? Like Almost as long as I.
Yeah, Texas Art Supply has been around for over 50 years.
Yeah, so it's pretty amazing. They're a local business. We definitely encourage support here. And we'd like to take a minute too to thank all of our fabulous community sponsors who, without, we definitely could not do this program. They've donated some incredible prizes this year for our showcase winners, including gift cards to purchase art supplies. We've got some tickets to family-friendly activities throughout Houston. And we also have some art classes. So we're very thankful to get to share these fabulous prizes with our students. We know they're going to be really excited to get them. Now back to Kim to introduce our artist testimonials.
Some of our artists were able to record information about their pieces and how mental health and art are connected. And it's very meaningful to hear directly from young people how art helps them and their peers to express their feelings and why they chose to participate.
Hi, my name is Bella. I'm 13 years old. This is my piece, How in the World. I created it because I wanted to show people that even through hardships or challenges, we have the power to bring light, hope, and color into our lives as well as the lives of others. This piece, How in the World, relates to mental health because we're facing dark emotions or just feeling really negatively about the world around us. Sometimes we need to embrace those feelings and know that it's okay. Just know that the light will always shine through in the end. No feeling, no matter how strong or negative, will last forever. Art is a major part of mental health. It's an escape from our busy lives and a chance to actually think about what's going on. For me, even picking up a pencil for a couple of minutes greatly clears my head. I hope this piece relates to you as much as it relates to me. And just know there is always hope in this world. Hi, my name is Kush. This is my artwork, Rainbow Tears, and it is about, the tears are rainbow as you can see, and that symbolizes how sometimes when you cry, it can make you feel a little better about yourself. It can make you feel happy. When I'm inside, I'm going to cry for a little bit, and I my tears away after that, just feel much happier, I can be much happier. And sometimes just tears help through that and they help you breathe. And sometimes when you're sad, crying can be good. And I think art helps mental health because when I'm sad, drawing just suits me and it makes me feel so happy. And I feel like when I focus on a drawing, I just get away from everything in life and I only think about my art rather than problems, stop and think about why I'm sad. And the quote on the shirt is "Be a rainbow in someone's cloud" by Maya Angelou. And that quote, what it means to me is you can spread happiness to make others feel better because you never know what they're facing at home, how they're sad. You never know, they might be happy on the outside. So always act kind to others, and that is my piece, Rainbow Tears.
Hello, my name is Sheena. I'm a sophomore at Summit Creek High School. And the tips I would give young artists is to have fun, be creative, show the world what you think, how you receive, how you wear your artwork to be received. I would say to explore techniques, explore different art styles, explore different mediums, so it allows yourself to enjoy yourself, basically.
My name is Maya and I'm 10 years old. I love to create and to make art. Getting creative helps to calm me down and can also cheer me up. When I've created something I'm proud of, I feel like I can do anything. Making art builds my confidence. In this piece, I used origami folds to create a rainbow design.
Through art, I show what I think for how I see things. It is a way to show what we need to say without saying it, and it provides a better understanding for others. My advice to those who are interested in creating art is not to worry about technique, because that will come eventually with the practice. Just be thoughtful of the emotions it will evoke in the viewers. Acknowledge that sometimes they would be different from the ones you think.
And we greatly appreciate each artist taking their time to share their stories with us. And now we're going to announce the prize winners. Congratulations to them.
Yes.
And we'd like to thank also the hardworking educators and parents who help the students to submit their artwork. We'd also like to thank our diverse panel of judges for their hard work, selecting 3 winners in each age category. Now, our winners are Derek, age 8. Name of his piece is Frustration. Emily, age 8, Happy versus Sad. Kimberly, age 8, Sunny Tower. Aubrey, age 6, I'm loved. Hercules, age 12, drowned out. Hannah, age 10, falling. Katie, age 12, silent shouts. Tucker, age 12, fragile inside. Lucy, age 16, alone. Wendy, age 14, my brain 24/7. Uyemi, age 16, dual mind. Cynthia, age 14, contemplation. Camille, age 17, self-sabotage. Valerie, age 18, hidden in plain sight. Eric, age 17, mental escape. And Tessa, age 17, why don't we talk about it? We appreciate all the participants and thank every artist for all your work that you've submitted. Your voice matters. Your perspective matters. Your art matters. You matter.
Thank you so much, Cam. Again, congratulations to all of our winners. Art can really help you manage behaviors, process feelings, and help reduce stress and anxiety. And we really just want to encourage anyone who's watching, if you or someone you know is struggling, visit our website, mhahouston.org, to take a free mental health screening. You can also learn more about our programs, as well as see all of the fabulous art that was submitted this year. Finally, we would like to dedicate this year's art showcase to Sam, a Shadow Creek High School graduate, artist, and a creative who was an aspiring architect. Sam's family, friends, and loved ones got together to make a generous donation to Mental Health America and the art showcase, so that students would get the chance to experience art as a tool for wellness and healing. Thank you for that tremendous gift and for sharing Sam's art with us today. Thank you everyone for joining us. We can't wait to see what art you make for next year's showcase.
Thank you for sharing that. Thank you. Wonderful. You have a question? By the way, that young little man, yeah, that good practice.
You can, if I could just add that, this was on Facebook, right? So encourage you to follow us, learn more about us, and if you were impressed by this, I get jumped up and you can be very friendly about share it with your networks. Help us spread the word in a different way. It's a wonderful conference. But kids can't always talk about it.
Yeah, definitely.
Thank you, Dr. Freed, for your leadership. At the Center for School Behavior.
Yes, thank you.
North America, Greater Houston.
Thank you. It does really indicate and demonstrate the importance of art and, providing youth individuals with other ways to express themselves. Deputy Diva, did you have a quick question? Because we got to
Quick question.
go.
You say y'all deal with 30 school districts. Y'all deal with all of the school districts, and y'all audit them, go back and refresh them on the things that y'all have to offer.
We don't work with every school, but we want to. We do offer refreshers, and we will continue to do that for you. And we can also work with the sheriff department, the police department. We can train anyone, SROs, who have some sort of touch with them.
Yes. Perfect. We need to bring them into some of the partnerships. So with that, and we're still good on time, don't worry, because I want to introduce Pastor David Sincere. And gosh, how long have you been here? 8 months, 9 months? Is it longer than that? When did? Over a year. Okay, over a year. I guess it was February of last year that this initiative was launched. really with the leadership of our district attorney's office, juvenile probation, the sheriff's office, probation department. Really, you know, how do we reach kids? What else can we do for kids in our communities? How can we really expose, foster excellence in our youth? And that really is the name of the program, Expose Excellence in Youth. And Pastor David Sincere is the lead of this project. And again, it's amazing what kind of networks they've developed and how many children and families that they've been able to reach and connect with services. So thank you for being
All
here.
right. Well, thank you very much, Connie, for this opportunity to share the Expose Excellence Program. Every opportunity I get, I like to let people know the why of why I do what I do. And so many of you, you've talked about the programs that you do in terms of early childhood intervention, how it makes a difference, right? And many of you, you see clients, you've gone to school and you're practicing, et cetera. What happens when it hits home to your house, to someone that you love, that you care about, that, you know, I think that with these stats, it tells us that 1 out of every 5 individuals to be diagnosed with the mental health issue before the age of 18. And so that means that either we know someone or we have issues, right? Right? Okay. Nobody wants to say amen. I am a pastor. Nobody wants to say amen. There you go. And so for me, this whole issue concerning mental health is really personal. Why? Because when I was 7 years old, my mother was married to a drug trafficker. And when I was 7.5, my mother found out that Charles got killed in a car accident. And I never received any counseling. I never received any help. I was basically told as a young person to get over it and to move on. Where there was a church that was across the street from my apartment complex. And they found out what happened. And then they came over and they helped us pay our rent. They even brought me a birthday cake on my birthday and some toys. And so they really tried to provide us with those wraparound services to help us. And so there was an attorney that was a member of the church. We were not members there, but the attorney was a member of the church. And he took my mother's case pro bono, her common law marriage case pro bono, so that my mother could receive the Social Security benefits, right? Funds from Charles. Several years later, they won the case. My mother received a check in the mail for over $20,000, and she purchased her first house in Briargate. And that's where we do a lot of work in the community and try to help kids that are now 94% economically disadvantaged. And so that's my why. I'm passionate about this because I realize what it means to experience trauma at a young age and not get the help that you need. And so I thank you for what you do because it's important. And you can help someone like me when I was a kid to be able to grow up and be a productive citizen in society. So give yourselves a big hand. And so the Expose Excellence Program, it started because in Fort Bend County, we noticed that there was a 24% increase in juvenile violence. And over the last 3 years, there were 5 kids that committed murder in Fort Bend County. And so we needed a response to that. We needed to respond to it and do something about it. And that's how we came up with the Expose Excellence Program. The Expose Excellence Program started off with a task force of 4 different agencies in Fort Bend County: the District Attorney's Office, the Juvenile Probation Department, the Adult Probation Department, and the Sheriff's Office. And so Mr. Middleton had the vision of starting this program for all kids, but then also helping at-risk kids. And so that was about a year ago. We're 1 year old, right? When we started the program. And so what I wanted to do is focus on some stats over the last year, what we're finding out about our kids in the program. Number one, in the last year in the EEYP program, the Exposed Excellence Program, we've assessed over 121 kids. And 117 of those kids have been enrolled in the program. Right now, to date, we have in our program 103 kids, and they break up in different age groups. We have 13 in elementary school, 40 in middle school, and 50 in high school. Our demographics is we have 39 females and 64 males. And so in terms of mental health services, we have referred over 80 of those kids for mental health services. 80 of those kids to mental health services, which makes up about 66.1% of the kids that come into our program. In terms of family formation, poor family formation in unstable families and structures, we have 85 of our kids come from broken, unstable homes, right? About 85.2%. And so many of y'all mentioned some of the things that you're seeing with the kids. We're seeing some of those same things, which is vaping, right? 44% of the kids in Fort Bend ISD that have been suspended out of school is because of vaping and marijuana. We're seeing truancy, right? So I think someone articulated that. We're seeing truancy where kids are dealing with things and they're not going to school. They're skipping class, explosive behavior. Some of our kids, they don't want to say anything. They don't want to connect. They have that attachment disorder. And then we're also seeing the suicidal ideations, 2-year social delays because of COVID, right? And then we continue to have these huge achievement gaps. And so what is Exposed Excellence doing about it, right? How can we play our part to try to help these kids that are suffering from trauma and other different systemic issues in our society? Well, the first thing that we do is we hired, soon will be about 10 individuals, and they play 3 different roles. They play the role of a case manager, and so they're consistently all the time coordinating services for kids. They kind of play the role of a mentor. They connect with those kids on multiple different levels, and they also play the role of an advocate. And so one of the first things that happens when a kid is referred to us is we do a comprehensive assessment called a PACT assessment. We ask those kids about 125 questions so that we can identify the risk factors and build those protective factors around those kids. And one of the things that we do after we assess the kids is develop an individualized case plan for each young person. And our case managers, they manage those cases. We wanted to make sure that we limited barriers, right, to access to care and access to our program. And so the only requirements in order to be a part of the Exposed Excellence program is they need to live in Fort Bend County. And then they need to be between the ages of 10 and 17. We're getting referrals from school districts. We're getting referrals from churches, law enforcement agencies, and the community at large. Once we find out that a young person is having these issues within their homes, we also target their siblings. We want to make sure that we also stop that prison, school to prison pipeline with the siblings, so we target the entire family. No, you can clap. We also want to make sure that all of our kids are involved in pro-social recreational activities. And so when we do our assessment, we analyze and we see, well, what type of activities are those kids in? And so we have kids in basketball and football, in soccer, in the arts, and we want every kid to be involved in some type of activity. We also have campus-based programs where we have our partnership with Fort Bend ISD and LCISD, and we want to make sure that we have good student engagement. And so what happens is our case managers, when they do the assessment, part of the assessment is going to the school and pulling all the kids' grades. We pull all their behavioral information. The parents allow us to do that. We also pull their attendance. And if they're a SPED student, we pull that information also, and that helps us with our assessment process. And then we develop those campus-based type programs as we're engaging the student on campuses all throughout Fort Bend ISD. And so we also have a curriculum that we use in order to teach the kids various different things like life skills, et cetera, and whatnot. And I'll go into that later. One of the things that we've implemented, and juvenile probation has done a great job with this, with all of their different programs, is implementing restorative practices and restorative justice. And so we want to make sure that when we assess a kid, we're not stereotyping that young person, but we're giving that young person every opportunity to take advantage of all the services that we have for them and let them know that we believe in them and that we care for them. We also have implemented a system besides implementing restorative justice and restorative practices, a system based on social determinants of health. So when we do our assessment, we talk to the kids, but then separately, we also talk to the parents. And we're assessing to see all of those different risk factors that's happening at home in their homes. And we're looking at all of these different determinants concerning social determinants of health and seeing how we can help. And so we partner with a plethora of different agencies. We partner with Fort Bend Workforce Solutions. We partner with Workforce Solutions VRS, and we partner with Workforce Solutions Gen X to try to make sure that we can open up opportunities, not only for the kids, work opportunities, not only for the kids, but also for their parents. We partner with Disability Rights Texas. They help us in terms of analyzing IEPs for SPED students and making sure that those kids are getting what they're supposed to get in schools. We partner with Fort Bend Health and Human Services, Dr. Mentor. We have conversations with Fort Bend Social Services on a regular basis. And so say if there's a parent that's their kids are part of our program and they need rental assistance, we're going to refer them so they can get rental assistance, utility assistance, mortgage assistance, daycare assistance, and some of the other things that Fort Bend County provides. Here again, we partner with Fort Bend ISD, Fort Bend Regional Council, Lamar Consolidated, Fort Bend Family Promise. We partner with Fort Bend Social Services, the Sheriff's Department, the District Attorney, and we just solidified a great relationship with the Boys and Girls of Greater Houston so that we can continue to coordinate our kids into great programs, making sure that they're a part of those pro-social recreational programs. And so here are our kids, because we love sending our kids. This is our first year. They had a dynamic summer camp. Here's some of our kids having fun. And they just had a great time. And so we want to make sure that we give these kids every opportunity to take advantage of the programs that we're providing. And so what are some of those programs? What are we providing in EEYP? What have we developed over the last year? Well, we're teaching the kids job skills and career training, we're doing business and entrepreneurship workshops. We have recreational activities, summer camp. In June the 11th, we're taking the kids on a field trip. Life skills training. We also want to make sure that our kids can express themselves like you articulated in your presentation concerning the arts. And so we're connecting them to the arts. Tutoring, right? We tutor kids, and we have an outside agency that we pay for to tutor kids. This summer, we'll have over 150 hours set aside to tutor kids so we can prepare them for the coming school year. And so this is the one that our parents really like, right? They really like this one. Everybody say free. Come on, y'all act like y'all don't like free. Everybody say free. Right, free. Wow, I know everybody loves free. Well, we provide free driver's education for our kids, right? We pay for the permit part, and then we also pay for the behind the wheel part. We help them with financial advocacy, support. Also, here again, the arts. And one of the things that we pride ourselves on, as I articulated at the beginning of my presentation, is we provide free mental health services and substance abuse services through the Juvenile Probation Department. No insurance requirements and no income requirements. They just need to be a young person that's signed up in the EEYP program. Currently, we have 42 kids receiving mental health services through EEYP. We also want to, here again, we want to make sure that we can impact the parents. And so in juvenile probation, we already have a unit that provides a program called the Parent Project, where we can send those parents by themselves so that they can help develop skills to have a better connection and better understanding of their kids. You can clap, y'all can clap. And then we have a teen pregnancy program. We had a young lady that went to Willow Ridge, and she was in our, enrolled in our program, and we found out that she was pregnant. And I love what our teen pregnancy unit, what they did in helping her out and going and doing home visits and providing her with the things that she needs and encouraging her. And so she's getting ready to graduate. So though she's had that baby, she's still graduating on time. And so I just thank Fort Bend for providing that service to help that young lady to have upward mobility in our society. And so that's a quick overview of what we developed in the last year with the Exposed Excellence Program. And I'm gonna leave you with this. Yesterday, I had one of our case managers came to me and he said, David, I had an opportunity to go to one of my kids' karate competitions, but I didn't think that that young person was going to get a chance to participate. And he said that a couple of days earlier, he talked to the parent and they were having pest control problems. And so they boxed everything up so that they could have the apartment exterminated. And his karate uniform got put in a box and they couldn't find it. And so the karate instructor told the young person that if you don't have your uniform, then you can't participate. And so our case manager, he said, well, I'm going to advocate on behalf of that young person. And so he went to the competition. The young man was sitting there and he didn't know whether he was going to be able to participate or not. He was nervous but he really wanted to participate. And so our case manager went up to the karate instructor and he looked him in the eyes and he said, it's not this young man's fault that he can't find his uniform. Can you please let him participate? I'm his mentor. And so the instructor nodded his head and he ran to the back and found a uniform his size. And our case manager, his mentor, went to the young man and he said, go to the gym and dress up. And the mother started crying because she thought that he wasn't going to get a chance to participate. And his cousins were there. Everybody showed up. You see, This young man had a very difficult time trusting people. And when our case manager talked to him afterwards, the young man just ran up and gave him a hug. You see, this is what can happen when we all get involved, when we advocate for kids, when we become their mentors, when we go visit them on their school campus, when we do home visits. This is what EEYP is all about. And I think that all of us should give Fort Bend County a big hand for starting this prevention program. This is a prevention program. We don't work with any kids under supervision. Our mandate is to disrupt the school to prison pipeline and keep kids out of the system. And so I'm just humbled, to have an opportunity to be able to serve the community and to be the supervisor of this program. And I thank you for your partnership, Connie. Anytime I need you, I can call you. I send her emails. I may get up at 3 o'clock in the morning and I know she's not up and saying, well, what do you think about this? So just thank you. And thank you for giving me an opportunity to present this program. Hopefully next year, we can hire more staff and we can double the program. If you would like to know more about EEYP, you have the push card. Here's my information. You can take a screenshot of it. We love collaborations and we love partnering with all of our Fort Bend County agencies and nonprofits. Thank you.
Thank you so much. Our next speaker is here, so I am just going to be very brief. I was on the agenda, but I will not talk. You can go to our website and find out a little bit more about behavioral health services. We have been in existence now for almost 12 years, 12 years in October, and we were actually founded out of the justice system. It was me, half of me, the other half was doing contract work for Harris County. So it was half of me, it was basically judges going, we have all these people with mental illness, help us figure out what we need to do. The sheriff going, we have all these people with mental illness, help us figure out what we need to do. Since then, we've expanded, always thinking about, individuals that are in our justice system or at risk of our justice system. So we provide very specialized services such as competency and trial evaluations, sanity evaluations. But then we also provide a variety of services. You've heard a little bit about the infant toddler court, TBRI. We also have a SOURCE program. Kim Galloway, who's our clinical care coordinator for that program. That's again, kids that are at risk or involved in the juvenile justice system, a different level. They've already had some contact with the justice system. And then we do something for the adults. All of our services are free, also part of the county, so we're either grant funded or commissioner's court funded. And it really is about supporting individuals, identifying the mental illness, providing the services, but mostly connecting with them with services. We only provide the services when those services don't exist. So you can tell that often who we're dealing with are individuals with really complex needs, multiple barriers to care, Medicaid, uninsured. So that's who we see. I think lately I've been described as a gap filler. I'm like, that's good. It's a gap filler because if we can fill in the gap and then it works, then, somebody else can take it and expand it. But anyway, you can look at our programs. The Focus program is a new partnership with law enforcement where we're actually looking at it's funded through the Office of Juvenile Justice Delinquency Prevention. Really cool, improved screening and assessment. So we're working with IT and our law enforcement team to develop an app that can be used by law enforcement to help identify and then connect and then enhance the provider capacity to provide the evidence-based interventions. The target population again is, the 10 to 17-year-olds with mental illness and the co-occurring mental illness and substance abuse. So it's a really cool project. I'm looking for somebody to be a project manager. So if anybody, right now I'm managing that project and I need somebody. So sorry, but I just wanted to kind of really brief overview. Dr. Sutillo. Okay. And I already introduced you before because I said, oh, I'm just so excited to have this expert joining us on ADHD, who's vice chair and the chief of child and adolescent psychiatry at UT Health, and the director of the ADHD outpatient program. So I just thank you again for being here. I know.
Thank you.
Hopefully you live in Fort Bend County, but.
I actually don't live around here, but I don't.
So thank you for making the drive out.
Thank you very much. Thank you, everybody. Okay, let me just see. Just look at the slides.
They are 3 screens then.
Yeah, okay, so which one is, this is,
Okay, so you want it for this screen if you want to do the clicker,
oh,
or
okay,
if you want to use that yours, but yeah.
okay, and can I use this as a pointer?
Oh, there you go, the
pointer
red.
is here. Okay, okay, so thank you very much, Dr. Almeida. My name is Dr. Cesar Sotuyo. I work with mostly with kids with ADHD, but can you hear me all right? Yeah, but any other behavioral and psychiatric disorders. And it is very exciting to be here because part of what we do all day is trying to prevent kids from getting in trouble. And also, when they get in trouble, try to figure out how to help them to get out without trying to find like whose fault it is. And I've been working on talking to people about that for a number of years. So these are my disclosures. I do a number of things for different companies, but I speak just for myself. Everything that I say has nothing to do with UT Health, necessarily reflect UT Health opinions. Okay, and I want to thank Dr. Sima Jacob and Fundola, also the George Foundation and the Fort Bend County for inviting me to be here. So this is what I'm going to be talking about. Because for a number of years, ADHD has been thought to be like a school problem, like an academic problem. And that's not the main problem that we see in the clinic. So it's a little bit looking at beyond the academic performance or having better grades or lower grades, and looking at what happens if you don't intervene early or as early as possible. So I'm going to talk about the risk of ADHD and also what to do for a little bit of what to do for early recognition and prevention, which is something that we don't do a lot or enough in psychiatry prevention. We always talk about what to do at the other end, but not in the beginning. And I think it's much better to start early. So as far as the definition, ADHD is a very highly genetic disorder. 74% of the cause is genetic. And it's very frequent. It affects about 5 to 8% of the children in school age. And it's a neurodevelopmental disorder. What it means is that you're always comparing the symptoms to what is expected at that developmental age or level, okay? It's a brain-based disorder. It's not a liver disorder. It's not a toenail disorder. It's a brain disorder, right? It's also not a parent disorder, all right? And it's a brain, we know it's a brain disorder because through years of research, it's been demonstrated that some areas of the brain that are involved in regulating attention, focus, impulse control, and reward processing are affected. So what is the meaning of that? The meaning is that if you have a thought, you have to think about it first a little bit, and then you act, depending on whether it's in your best interest or not. So when you see a very nice cake, you may decide to eat the whole cake. And then you say, well, I already ate 3 cakes, so I'm not going to eat that cake. All right. So that's impulse control and that's reward processing. So that means that you have to think about it and then you have to stop and then you have to process and make a decision. Well, that is done by several parts of the brain, and those parts of the brain are not well developed in children with ADHD, in people with ADHD. So they have a thought and they do whatever. They don't process it. So that's why they get in trouble, because they don't have impulse control, or their impulse control is impaired. Okay. And the symptoms that result from that are severe hyperactivity, so they move a lot. They think they want to move and then they move. They're impulsive in their behaviors and in their decisions, and they have inattention. They cannot focus on one thing. Everything is interesting to them, and they have difficulties with sustained attention and also divided attention. When you're doing something, you have to, I'm here, I'm talking, I'm making sure that I'm close to the microphone and looking at the slides and making sure that you don't fall asleep. I'm doing a lot of things. So they would say, oh, that's very interesting. Oh, look at that flag. And then they start looking at the flag, and that's the end of the story. Okay. So that's inattention. All right. And then it has to be very, very like disproportionately high presence of symptoms compared with what is expected at that age. And then it has to appear in several areas of the child's life, at home, at school. It's not just in one environment. And then it has to happen for a long time. It's not just like one bad day or one bad week. It happens for at least 6-8 months or something like that. It keeps going and going. And it usually appears prior to age 12. So you see, there's a lot of different categories. It's not easy to get a diagnosis of ADHD, because if you follow the criteria, you have to meet a lot of things and always compare with what is normal. So it's not true that everybody is diagnosed with ADHD and all, 90% of the kids in the US have ADHD as a diagnosis. That's totally false. And you would think that if you read the newspapers, because they tell you that. And then the last thing is that, well, we're going to talk that it causes a lot of problems, and you'll see that in a minute. But the most important thing, in addition, that is a frequent disorder, is a brain disorder, and is nobody's fault. It has very, very safe and effective treatments. So they're just like right there at the tip of our fingers. So it's just a matter of using them. And we're not very good at making people use the treatments. And the treatments are psychoeducation, behavioral therapy, school intervention, and medication. That is the treatment. The treatment is not the pill. The treatment is the 3 things, all right? And the sooner you get to intervene, the more you're going to do these interventions here on the left-hand side. The later you intervene, the more you're going to need to use medicines and stronger interventions. Okay. So what happens with the symptoms? So through the lifespan, these is preschool, school age, adolescence, and early adulthood, and these are the symptoms. So impulsivity tends to decrease over time, like this. Hyperactivity also tends to decrease. That is why in the past people said that it's in the books also that ADHD is a child disorder, that it disappears in adolescence because hyperactivity and impulsivity tend to go away. Although you still see the adolescents being restless and even the adults being restless inside. Okay, inattention starts in the beginning and then it keeps going up. And the other thing is that comorbidity, the consequences, the complications tends to get worse. So depending on where you're looking at, you can be looking at preschool, you're looking at these symptoms. You look at school age, adolescence, or early adulthood. You're going to be looking at different configurations of symptoms that is the same disorder. All right, that was used to be called the subtypes. We no longer use the subtypes because you can be hyperactive, impulsive in the beginning, then you are combined, and then you're inattentive later in life. So it doesn't matter how you call it. We call it current presentation, okay? And, you know, this is an oxymoron, but the sooner you intervene, you know, if you get a stain in your tie, you don't say, leave it for tomorrow. I'll just, you know, you go quickly and you try to take it out. You do the same in heart disease. You do the same in cancer. So you have some hyperplasia or mild hyperplasia, you want to intervene as soon as possible. You have carcinoma in situ, that's much better than if you have invasive carcinoma. And these are the problems that you're going to get. These are the metastases from ADHD. You're going to get school failure, substance use, oppositional defiant disorder, depression, and suicidality, increased accidents, and death, premature death. That sounds familiar. That's what the other gentleman, the pastor, was talking about right before myself, all right? So those are the negative consequences. And then you have to deal with, you know, with that, and that is much more painful and also much more expensive. All right. So I was just, still haven't finished, but I was this week on a meeting that is called Responding to Current Youth Mental Health Crisis. And the Surgeon General was talking about this, and I just made a slide about that. Because he was saying that what is what we want to prevent? And we know that we can prevent that because the literature shows it and the science shows it. We're going to prevent school dropout or low academic achievement and lower graduation rates. We're going to prevent substance use. We can prevent early unplanned teen pregnancy, and also prenatal exposure of the kid to drugs, which is then the ADHD for the next generation, because ADHD is genetic, but one of the non-genetic causes of ADHD is being exposed to alcohol or drugs in utero. So you see how it's going to perpetuate over the next generation. And then this one, encounter with the law enforcement and juvenile justice system. It's been very, very well known that a lot of the people that are in our justice system have ADHD. This a disproportionately high number of ADHD compared with the general population, which is 5 to 8%, as I told you. In the justice system is much higher. All right. And this is what you know, because in psychiatry we always say like, oh, let's wait till we have we call it an impairment. Let's wait till you have an impairment. And this is what happens. It's going to spread into oppositional defiant or conduct disorder, substance use, and early pregnancy. That is for, you know, poor impulse control. You want something, it sounds like a good idea. You do it without thinking of the consequences. And then school failure, school dropout, and then also occupational underachievement. It's been shown that people with ADHD who are not treated have a significantly shorter career as far as how much or how far they go in high school and in college, independently of their intellectual functioning. All right, so that's what I call metastatic ADHD, because people understand it if you talk in oncology terms, right? Okay. So what is the literature showing? This is what we know. We have in people with ADHD, we have high rates of legal problems, and these are some studies done in Scandinavian countries where they have a system that, well, we have universal healthcare system, but also they have a system that the medical record can be accessed, and then you can do population studies for, you know, you pull everybody who has this diagnosis, and then you do population samples of millions of people that follow over, you know, 10, 20, 30 years, and then you see what happened. And I'll show you some of these. You have high rates of substance use, also premature death due to accidents, and I'll show you about it, and also due to suicide. Kids with ADHD have a high rates of suicidality because they have failures, repeated failures, because they don't progress well in school, and because they're frequently victims of bullying. And that is trauma, all right? higher accident rates. I'm not just talking about about car accidents or motorbike accidents, but falling off a tree or drinking bleach at home or something like that. Okay. And then also it has a much higher economic cost to the family and to the kid, and also to the society. Because if you have a kid that is going a lot to the emergency room, you have a lot of cost over there. That is totally preventable. It also has a very big impact in the family. This is a graph of the length of marriage. How many couples stay married in controls and in kids with ADHD. Okay, controls are this, and in families with kids with ADHD. So you see that the marriage is not lasting as long because having ADHD has a big pressure on the couple, on the family, and they end up many times being not agreeing with each other, and then that the consequences is losing the bond. This is a slide on cost. These are like different countries they're all in Europe. And the point of this slide, and these are thousands of euros, which is a little bit more than $1, $1.2. So in red you see healthcare costs. In yellow you see education costs, and then also cost to the families, because the different studies were measuring different things. All right, but you see how the cost on the healthcare system is very high. It can go from almost 4,000 euros per year. But look at the cost in this study in the UK, in England, on the educational system, because they have to provide special assistance for school, one-on-one school, catching up classes, repeating a year, for example, is very frequent in kids with ADHD. So you have to look at the cost, not from the healthcare perspective, but also from the other parts of the spectrum perspective. This is a study that we did in Spain. We interview it's a small study, only 300 families, 321 families, and we asked them about how much they would spend in different aspects of their life associated with ADHD. And what we found is that these were all the costs. This is the cost of non-pharmacological treatment, pharmacotherapy, but also other services, time spent at the visits, and caregiving. And the point is that you have a lot of direct cost, but you have also a lot of indirect cost. And the cost in kids that were not non-responders to medicine was 7,600 euros per year. Even in responders was 5,000, more than 5,000 euros. All right. That is for one patient that has ADHD, but because this is highly genetic, many families have sometimes two kids with ADHD, or the father and the child be on one of the kids, because it's more prevalent in males. All right. Okay, this is one of the studies in Sweden that I told you about. This is the rate, this is 2 different years. This is in men and in women, treated and untreated. And these are the percentage of them who stay without a conviction. All right. So what you can see here, if a patient has ADHD and is untreated, the rate of remaining with no legal problems, it's much lower, much without legal problems is much lower than if they're treated. So if you treat these people, they're going to go from having less than 40% stay without a problem to 50% stay without having legal problems. That's huge. It's not so evident in women because women have less legal problems in general, less violence and things like that. But this is done in a population of 16,000 men and 9,000 women in Sweden. We did this study. This was the PhD dissertation of this doctor, who's a pediatrician, and Maite Ruiz Goicoechea, she came to my office. She said that I want to do a PhD on injuries of kids with ADHD because she's a pediatrician that works in an emergency room, and she realized that a lot of kids who came to see her with fractures, with falls, with different accidents had a diagnosis of ADHD, and many times they were not treated because that was happening, for example, during the summer or on weekends. So they were not taking the medicines, and they were, having a lot of falls and emergency visits. So we did a meta-analysis of all the studies, and we found that there was an elevation of, you multiply by 1.53 the chances of having accidents. It's called like unintentional injuries to differentiate from traffic accidents. And we found that if you treat that on the studies that that showed treatment, you go a deviation to the left, that means that is protective with an effect size of 0.8. That is the effect size that is similar to taking a medicine or not, all right? So some medicines, like the difference between taking a medicine or not. That is a significant improvement, very, very significant. We also found that these kids had a much higher risk of accidental poisoning. So they were drinking all kind of household products, and then they were or taking their parents' pills, not to get an overdose, but just because they thought they were candy or something, and they would be ending up in the emergency room. So having ADHD increased by 3 times the risk of being poisoned in the home. Okay, we didn't have enough. Here you see the increase, in this case is to the right from here. We multiply by 1, you multiply by 3, okay? And these are the different studies. So we didn't find evidence that the medication was doing anything one way or the other because there were no studies showing that. That was the only reason. Okay. And then this is the study about mortality. So basically, having ADHD increases your mortality risk by 2-fold. Okay. So kids with ADHD or young adults with ADHD are 2 times more likely to die. But this is usually not, not in young kids, not in children and adolescents. That's still elevated. It's 1.6 times. All right. But it's mostly in young adults, which increases for more than 4 times the risk of dying. And these are for different reasons. So there was this editorial on this journal that was titled "The Pathways to Premature Death in ADHD," and it's because of antisocial disorders. So they get into violence or crime. They get into fights outside, whatever, outside a sporting event or in a bar or whatever. Crime, substance use, which leads to accidents, and fighting, inattention and impulsivity also leads to accidents, because they're looking at their mobile phone while they're driving or they don't pay attention. And also poor health habits. It's been shown that people with ADHD have higher rates of negative health outcomes, like more obesity, they go less to the regular checkup. For example, women for the regular gynecological checkup, men for their heart checkup and prostate checkups and things like that. They don't, because it's not a problem. They don't see, they don't see what's going to happen, because if it doesn't hurt me right now, it's not an issue. So that's very important. And also risky behaviors. As I mentioned, health risks, including doing things that are kind of dangerous as a hobby, things that can get you into traumatic brain injuries and things like that, or speeding and accidents, okay? All right. So the literature was, the people, many people, what they say is that, well, we treat ADHD with medicine, and the medicine is just covering the symptoms. It's like a Band-Aid. And then it doesn't have any effect long term. All right. That's totally false. Okay. Because what happens is that it's very easy to say something, and then it takes decades to prove that is wrong. You can say whatever, oh, ADHD medication is going to affect your heart. And then you have to do a study and wait for people, and then you demonstrate that no, it doesn't do anything bad to your heart. But in the meantime, there's a lot of hot press, and and you have to defend yourself in the clinic. Oh, you gave me my kid a poison, and you say, well, I was here. You came to see me. See what I mean? I didn't go out to look for you. You see what I mean? So this is a study on the outcomes, of what happens on functional outcomes over time on people who are treated versus people who are not treated with medicine for ADHD. And what they found is that this is the same kind of graph. So here is the line. This is the one. So if it goes to the left, it decreases the odds. If it goes to the right, it increases the odds. Okay, and then you see here the individual studies with their error bars, and this diamond is the summary. Okay, so what you want to have is the diamond to the left of this line. That means that it's going to be beneficial, and I just added this to remind myself. Okay, so academic outcomes, there's evidence that it improves. Accidents and injuries, several studies, there's evidence that is improvement. And then mood disorders, because I told you before that kids with ADHD may have a high rates of depression because they have a lot of failures. So this is what happens if you treat it. If you don't treat it, you're just going to wait until something bad happens, and then you have to deal with the consequences. This is a very interesting graph that I recently saw in a talk that we had like 3 or 4 weeks ago in our department from Dr. Pliska from San Antonio. And he's looking at what happens if on school performance, depending on the months of treatment. All right. So these are the number of months from 1 to 25 to 29. Okay. And these are the grades, from lower grades to higher grades. And you see here that the longer you are on treatment, the more your grades are going to improve. Now, the medicine doesn't do anything to your intellectual function. I can take a lot of medicine. I'm never going to learn how to play the piano. All right. It doesn't do anything to you. But if you're studying and you take the medicine, you're going to absorb what you're studying. It doesn't make you brighter. But the same thing, if I take off my glasses, anybody could say that I don't know how to read, because if you put it like that, I don't know how to read if I have glasses, if I don't have glasses, okay? So that's what the medicine does. It reduces the burden of the disorder. It takes away the symptoms, at least in part. And then you see the child that is underneath, and then they can develop, and then they can do whatever they want to do, okay? So I hope I convince you that ADHD is a severe disorder that it is not only going to affect the grades, whether you have an A or a B, it doesn't matter. And not everybody has to have A pluses. And I had a doctor in the clinic in where I work in Spain before I came over here, who said, not everybody has to go to college. And I said to him, yeah, but if you can go to college, why not going if you want to go? All right. And then if you don't want to work in your college degree, that's fine, but at least you have the choice. All right. So we're going to talk, just to wrap up, a little bit about prevention and early recognition. And in order to do prevention, you have to know what are the causes of ADHD. So I already told you that, genes is about 74% of the cause of ADHD. So you cannot choose your parents. That's already done for you. So you cannot prevent that. But the other part, there's some things that you can prevent or you can intervene. So if a person is smoking while pregnant, that increases your odds of having ADHD by 3 times. So if the general population is 5%, that would be 15%. Okay, at least 15%. Alcohol in pregnancy, it increases your odds by 2 times. Drugs don't increase that much, but we don't recommend it, okay? So now, because low birth weight also increases your odds by 3. And that's what I was talking you about before. Like if you have a teen that is pregnant and she doesn't want to tell her parents, she's not going to go to the gynecologist. She's going to wait and wait and wait until it's very obvious. And then she's going to miss all the prenatal care, the vitamins, the healthy nutrition. And then the kid has higher risk of having low birth weight, okay? That increases also by 3 times, all right? Severe psychosocial adversity, like someone who's in an institution or something like that, or who's suffer severe neglect or abuse, that also increases. All right. But I tell parents, because I have a lot of parents in my clinic that are worried that, you know, if my child doesn't have the iPhone 17, he's going to be frustrated and then he's going to develop ADHD. That doesn't cause ADHD, all right? So it's like big psychosocial adversity. It's big deal, all right? And then, of course, if the parents have ADHD, that also increases a lot, both from the genetic part, but also from the chaos that is in the family. Because these families may have a lot of chaos going on. And sometimes we have to help them to put it together, okay? So those are things that we could intervene. Avoiding early pregnancy, avoiding smoking while pregnant or alcohol while pregnant, and looking at, you know, low birth weight and trying to do prenatal care, okay? Now, risk of late detection. Female girls who have mostly inattentive symptoms are usually left for the end, you know, because they don't bother anybody. They are back there at the end of the class, they mind their own business, and they are not picked up till they are like maybe 14, 15, 16, while they're in high school, and then they're dropping their grades. Before that, everybody thought she was a dreamer. She's like writing poems. It's just totally out of it. But if she's a little bit intelligent and she has more or less parents that are keeping her, she can do primary school pretty well with no problem whatsoever. All right. High IQ, being very intelligent also is a risk for, I mean, it's a good thing, but if you have high IQ, you're not going to show a lot of symptoms in the beginning, and then you're going to be mixed. And I have a lot of kids who are starting to fail when they go into college because they have been scaffolded by their parents. And once they lose that structure, they can't handle it. They cannot keep it together. Now, if you have a class with low numbers, also is like having a teacher for yourself. So that's going to mask the symptoms. Or if you have very low demands or low expectations, that's not going to show until you go to a school that is more demanding. Okay. And also, I get a lot of these, you know, because there's always something happening in everybody's life. So someone is getting divorced, some, you know, grandparent died, someone has, you know, suffer a hurricane coming through them, or there's always things going on. When a kid comes to the clinic, many times they have gone to the pediatrician or to the school counselor, and they said, no, that's because your parents got divorced, not because your little brother was just born and you were just jealous, no, because this or that or that. And then you blame it on things on the environment. And, you know, it's important not to have ideas of what is the cause, but just look at the symptoms and look at, you know, what is it that is going on. This is what I show you about the IQ. So, you know, this is the age at the diagnosis, 20, 30, 40, 50 years. And this is the IQ, the normal IQ, you know, the mean IQ is 100. So your IQ is higher than 100, so you're kind of bright, very bright. You're going to be picked up much later than if your IQ is kind of on the 90s or you know, just below 100. But you're going to have problems early on. Okay. Now, in order to pick it up at school or at different levels, at the pediatrician level, we can use the ADHD rating scale. This is a rating scale that has all the symptoms, you know, the 18 symptoms of ADHD. This is inattention, this is hyperactivity, and this is impulsivity. So if you have, and then you score it 0, 1, 2, 3, and then, you know, you have problems, you know, you have problems here, that means that you probably, you know, these are probably positive. That doesn't mean that they have ADHD. This is not a test for ADHD. You don't, it's not like a pregnancy test. Some people think, give me the test for ADHD. No, diagnosing ADHD involves different evaluations, interviews, and rating scales as well. But at least you have the symptoms. You have the collection of the symptoms. You have a lot of crosses over here. It's unlikely that you're going to have ADHD. If you have a lot here, maybe the kid has it. Okay. The other thing that happens is that when I send this to the schools, the teacher is saying, no, this kid doesn't have ADHD. So they score everything on the 0. All right. And then they write here, like, he does not listen. No, he often doesn't listen. And then he writes, no, he never does that. And he's very unpolite. He never listens to me. He writes that on the margin. Or he says, he has difficulty sustaining attention. He scores that as a 0, but then he tells me he forgets everything that I tell him. He doesn't follow in class. He's just uninterested. So they make an attribution and they say, this is not because of ADHD. This is because his parents don't treat him very well, or they didn't teach him anything, or whatever, or he has bad manners. All right. So, and I tell the parents and the teachers, I'm not interested in what you think. I don't care what you think. All right. I'm interested in what you see. What you see at the school. If you tell me that this kid is moving around, I'm very interested. If you think that is because he's very cold and he wants to get exercise, I don't know if it's that true or not. I have no idea why people do things. I have absolutely no idea, and I don't want to try to even start guessing. So, but I use the information that they give me to see if they fit in a category that is described as a disorder, and I don't do anything else. That's what we do. Okay. And then you score it, and then depending on the score, you can decide whether this kid is at risk or has some symptoms. We did for example, we did the validation of this scale in Spanish for Spanish population, and we did the scale. We went to the pediatric clinic, and then we gave that rating scale to the kids. A lot of kids who were coming for a well visit. And those were their scores, okay? So most of them were below the cutoff score of 17. And these are the scores of the kids with ADHD that we saw in the clinic. So you see that they have a good separation, and you could make a good separation looking at the area under the curve. Looking at, this is called receiving operating characteristics. So that means that the farther you are from this line in the middle, the better the test is to detect positive versus negative, people who have the disorder versus normal controls, okay? If your graph is very close to the line, your test is just as good as tossing a coin. It's like 50%, you're 50% right. Okay, just toss a coin and you save a lot of money as well, all right? Now, so that tells you that the symptoms of ADHD in a severe way, they're not very frequent in the general population of kids, but people still think that a lot of kids have a lot of symptoms of ADHD. So what we did, we went to the preschools in 2 regions in Spain, and we did the same test but adapted for kids. And then we look at how many kids, the percentage of kids who had 0 symptoms, 1 symptom, 2, all the way till 9 for hyperactivity, impulsivity. From that list that I just showed you, you see how many have 9 symptoms? 0.56%. The cutoff for the diagnosis is in 6, all right? So anything to the right of 6 would be positive. And you see that these symptoms are not very frequent in preschool kids either, all right? But there's some, if I was to develop a screening system for early detection, I would like to see these kids that have 4 or 5 symptoms, even though not just the ones that have 5 or 6 symptoms, okay? We found similar things for inattention, both from the parents' perspective and from the teacher's perspective, because we gave the scale to the parents and the teachers. The point is that even in preschools, these are not very frequent. symptoms, but there are some kids that are starting to show something that is worth having a look. I'm not saying that they have ADHD. I'm saying that keep an eye on these kids and see what happens to them. Because the earlier you detect it, the better you're going to be. All right. So then to end, I mean, it all comes back to what's your philosophy. And this, I take this from Dr. Ross Green. He's a psychologist. He was at Harvard, but now he's outside of Harvard. And he wrote this book. This is one of the best books ever, The Explosive Child, that I've read in child psychiatry. But it's very simple. He says, kids do well if they can. So if you think that kids do well if they can, and you can also say it for people in general, but then if they don't do well, you think that something's happening. You think that you need to find out what happened. And I tell my parents in the clinic, when your child was a baby and they had diarrhea and they messed up your shirt, you didn't think, oh, you messed up my shirt. Oh, you thought, wow, something's wrong with this kid that has very bad stomach problem. So I'm going to try to find out. Okay. Now, if a kid is doing the same thing, but he's like, trying to beat you up, then you're going to start thinking, oh, this kid is trying to beat me up. I think the opposite way. I think something's wrong with this kid. Why is it that he's so aggressive? I need to figure it out. All right. And then you start looking what's happening, because the other possibility is that kids do well if they wanna. And if they don't do well, I'm gonna make you wanna. All right. And then you have a power struggle going on, because I'm gonna tell you what to do. You're gonna do what I say, and because you don't want to do, and then you're gonna, some kids are gonna say, okay, I'll do what you say, because you use your might. But not all problems in life are solved with might. Some things you have to figure out what's going on. And these kids, they're not going to react well to authority. The more authority and pressure you put on them, the worse they're going to go, because they don't have impulse control. So if they tell you whatever cuss word they want to tell you, they don't care if you're the teacher, the principal, the sheriff, or the president of the United States. They don't care. They're just going to tell you whatever they think, because they don't have impulse control. And that's what's going to happen. So you corner them, they're going to be in trouble because you corner them. All right? Okay. So to conclude, ADHD is a highly genetic disorder. 74% of the cause is genetic, and it's very frequent. It affects 5 to 8% of the general population. And it's a neurodevelopmental brain disorder. It's associated with a lot of behavioral problems, poor academic achievement, accidents and death, substance use and legal problems, and also teen pregnancy, as we talk about. And it has a big impact on academic progression, but you can reduce the negative outcomes if you do early treatment, if you use the 3 parts of the treatment: psychoeducation and parent training, the school part, the school component, and the medication, or one or the other. And then you use it consistently every day, and every day of the year, not just during the school days. And early detection to screen, I would say we need to screen any kids who's not doing well in school, any kid who's failing more than what is expected. Certainly any kid who repeats a year needs to be screened for ADHD. Any kid that has behavioral problems, they may not have ADHD, have something else, but that is worth having a look, and the sooner the better. Certainly hyperactivity and aggression, and also any learning problems as far as reading, writing, and speech. Okay. So with that, I want to thank my team at the clinic, who help us a lot to get in touch with these kids and deal with all the issues that are coming up. Without the team, you can't do anything at all. Absolutely. And then the rest of the division. Thank you very much.
this is amazing. And I only have a couple minutes, so I would like to share an opportunity for some questions. So I've never met Dr. Sotelo, and but I felt that this was deja vu because as I mentioned before, in 1985, my dissertation was on it's called hyperactivity back then. And it had just changed from hyperkinetic disorder and minimal brain damage was
Exactly.
so some of you are too young for that, but it's interesting because Russell Barkley, who was referenced here as one of the doing that outcome study, was one of the first gurus, I think out of Worcester Medical School, and he developed this parent training curriculum, very effective. It's interesting because the dissertation was what's best, medication, parent training, school intervention, or a combination. Needless to say, a combination. So, of course, I was exhausted after that and never did anything with it, but it's really interesting. I also wanted to mention, I'm thinking about this and, what an amazing discussion because Mr. Rupani, you started out by welcoming us with the Rupani Foundation and basically saying, why aren't we starting before birth? And absolutely, it's like, we really need to start there with those risk factors. I mean, we know smoking is related to low birth weight, related to ADHD, related to a variety of other things, these psychosocial stressors. So it just kind of all came together. There was one other, and then I was also thinking about those adversities and, somebody talked about the systems, the MHA, clinical interventions, but then also what we need to do in terms of our systems that really support families and support this. We know healthy food, but also, maternal leave, family leave policies. And I think that's something we need to be aware of. And I think we talked a little bit about this disproportionality and race equity. We need to be aware of this because, I know young women that work for very nice companies and they have 4 months off of paid maternal leave. I would be surprised if anybody here has, that much time. But, so I think we need to really think about that because what I see is, again, we have these policies, they tend to be disproportionate and they tend to be, benefit, or maybe not, again, there's this disproportionality. I know that in Europe, for example, they're actually looking at a luxury tax because families that get to work remotely are saving a bunch of money on transportation, right? And cars, right? But yeah, look at here. We have most of our families that have to show up, right? Are the ones that are actually making the lower wages. And of course, probably can't afford those increased gas prices. So I think it's just really, this is so fascinating. I also just want to echo that importance of that appropriate diagnosis and the rating scales and really looking at assessments that really differentiate. And so I really think that is just really important. Because over the years, you're right, I think we kind of dump everybody into ADHD. It looks like ADHD. It might be bipolar disorder, it might be FASD, but we're going to give it ADHD and we're going to go with medication. And so, a very effective intervention has really gotten a bad rep because maybe it was not the appropriate medication or intervention for that. And I think this emphasis that it really needs to be those, I couldn't believe you said that it really needs to be that combined intervention to really have an effect on children.
Yeah, there is some important, very important things that you mentioned. One thing is that people are sometimes forced to say artificially forced. Is it medication or therapy? And I say, well, it's not one or the other. Maybe you're going to have to use both, but not for everybody because not the same therapy is going to be forever because you may have to For example, if the kid has severe oppositional defiant disorder, you need to do some parent intervention and some, working with behavioral management. But if the kid doesn't have that and you give them that intervention, you're wasting your time and they're going to say, this doesn't work. Well, this doesn't work because they didn't need it in the beginning. Then the other thing is that people still tend to think, and I look it up in my clinic. I was very, very surprised because I thought, the level of medication adherence in the US would be much better than the one that we had in Spain. And we found incredible low adherence rates in the US because people were in our clinic here in the medical center, not somewhere in the middle of nowhere, here in, the fourth biggest city in the US. People stop the medicine during on the weekends, and they say, "How is the kid doing?" "Oh, he's a nightmare." "Why did you stop it?" "No, I don't know. They told me to stop it." So, I had one mother this morning, and she told me, "No, I give the medicine when I think he needs it, when he's going to do a test." I mean, well, if you didn't study for the test, and then you take it the day of the test, there's nothing to come out. So it's totally useless. And then the kid was having headaches because she would give him 50 milligrams, and I never used 50 milligrams to begin with. I used 20, and then 30, and then 40, and then 50, 1 week at the time. But then she would blast him with 50 milligrams of Vyvanse, and then the kid is having headaches. Of course, he's having headaches. I will have a tremendous headache if I take it just like that one day. So all my emphasis is, okay, we're going to start the medicine. We're going to take it every day. We're going to take it on weekends. We're going to take, you don't rest from your diabetes medicine. You take it every day. And then we need to eventually, when he's doing all right, we need to see if he still needed. And 50% of the kids won't need it eventually. But the other 50% will need it. And that's okay. I still need my glasses. I mean, that's fine. You have to do what you have to do. I mean, I'm sure that if we put, all the pills that we're taking here in this room, we'll fill a big bucket because everybody's taking pills for whatever they need. And that's fine. That's it. Cholesterol, thyroid, I don't know. Why not take it? I mean, no, better. They say better not to take it. No, better to take it because, life expectancy was 19 years old in the beginning of the century, the last century. And now you get to 80. That's because of modern medicine.
I think it's excellent points, and it's just really, emphasizing that this is a neurodevelopmental disorder. It's not something, that people are just trying to control their kids. But it's interesting. It does challenge our systems, like the justice systems, the public community mental health systems, where Adderall and, ADHD really has not been treated because, people are going to use it. They're just looking for stimulants. So there is a lot of education, not only among the community, but among the provider system.
Yeah.
We have time for one question because I know it's Friday and Beth.
Yes, are there any medications that don't really
Some of them don't decrease appetite. Some of the stimulants don't decrease appetite. All right. Sorry, some of the non-stimulants don't decrease appetite, but they tend to take a little longer to work. All right. Pardon? No, the non-stimulants like guanfacine or clonidine or atomoxetine. They are the stimulants like Ritalin and Adderall and Vyvanse, and then the non-stimulants. And those take longer to work.
One more question, is there, okay, we have one more question.
How can you work with the parents, because parents are not wanting to give their kids those medicines yet. In the mental health field, some people may understand that if you don't give them, they're gonna experience the failures and all those things and then the different stuff. So how do you try to work with the parents to, either do you try behavioral therapy for a certain amount of time and they see it doesn't work and then you go to them, how does that work?
I think that's a mistake because that's buying into their fears. When they don't want to take the medicine, I ask them why. And then they usually say, oh, my uncle was schizophrenic and he was in a mental institution for 50 years and they gave him haloperidol and I don't want this. No, this is not haloperidol. This is something different. So sometimes it's like that. So I try to see what is it that is preventing them. And then if they absolutely don't want to use the medicine, I tell them how bad it needs to get until you change your mind. You have to draw a line in the sand and say like, okay, you want to wait till they flunk 5 in January or you want to wait in May? Are they going to summer school? Are they going to repeat the year? I don't know. For me, 5 flunking is enough. Maybe 2 flunking is enough. But for them, everybody has their own. And then they say, okay, if you repeat the year, that means that your way is not working. And then you can refer them to behavioral therapy. But sometimes behavioral therapy is if the kid is all over the place, it doesn't work. I had a kid the other day, I was writing in my computer. I sit in a little stool in front of the computer, and he's just jumping like that, but much faster. And he's saying, why are you writing? I'm hyperactive. Don't write that. So, he's like, you are. So, that kid, it doesn't matter what I tell him. He's going to start jumping the minute I look away. And it's beyond. It's like telling a diabetic, don't get high blood sugar. It's impossible. It's impossible. So I work with the parents on finding where they are, and then I try to see what, one step at a time. But I don't buy them. I don't buy their fear if they say, no, this is absolutely not. The other parents who just, other parents say, guarantee me 100% that this kid is not going to have a side effect ever, never. And I say, I don't guarantee you that this building is going to be standing in the next 10 minutes.
Right.
I don't know. I mean, we have an earthquake in a minute. So, I cannot guarantee the results, but I can tell you that if you do what we say and what we work with us, we can be in a better place. And little by little, he'll be much better. That I can try. Yeah.
Thank you so much. You have a door closet? You had to stay till the end. That was like, need to be here. Can't see you. Are they here? Lopez? Oh, you have to be present. I said, name? Are you with? Thank you so much. Thank you. This is great. I really thank you all. I mean, I learned a lot. It was really very reinforcing for the work that we're doing. I need you all to help continue this work. We have some ideas that this is just a great opportunity to really focus on, that starting early. And thank you all. Thank you for my staff. That, we don't have communication people. We don't have outreach people. So Shannon is our project specialist. She does data, and that I am so impressed that you now are able to do that. Allison is our administrative assistant, who is amazing with the technology and the flyers. You're going to break the backup, and then Veronica and Sandy were out there taking care of registration. Dr. Crowley has helped with speakers. Faye and Salon and Kim and huh? Oh. There's still people working. Oh. Thank you all. No. Sorry, I got a little distracted there. Dr. Sotelo, maybe a diagnosis. No. Anyway, thank you all. Please fill out your evaluations. Have a wonderful weekend and happy Mother's Day to those of you that are moms.